you hear me? Shweta, can you hear me?
Am I audible now? Okay. I hope everyone have joined.
Hello? You are not audible. You
Okay.
are
Am I audible now?
no.
So good afternoon, everyone. This is PSC Sirolia, moderator for poster presentations. And on behalf of the organizing committee, I welcome you all in the IAPCON 2022. So there are a few instructions for you all. We have allocated 6 minutes, 3 minutes for the presentations and 3 minutes for the question and answer round for each participant. So total 6 minutes are there, and after the 3 minutes presentation, your presentation will automatically stop. And we will put an alert just before the completion of 3 minutes, 6 minutes for after the question and answer for each poster to wrap up. So, for the session one, I welcome judges Dr. Emmy Seo. She is the Associate Consultant, Department of Palliative Care in Bangalore Baptist Hospital, Bengaluru, India. And I would also like to invite Dr. Rupesh Jain as the second judge. He is a professor and head of pain and palliative care unit, LN Medical College, Bhopal, also associated with Global Pain School as the course director. So,
Good afternoon, everyone.
Good afternoon, everyone.
so we will start our session, okay, with the first poster.
Before starting, can I make one request, please?
Yes?
I am Nilima Shingade and I have a quiz session at 2:30 p.m.
Okay.
So can you prepone or postpone my poster? It's P15.
Okay. It's at 3:50.
P15. My poster number is P15.
Acha. Okay. Sure, ma'am, I will ask.
Thank you.
Dr. Sucheta,
Yes, please.
please start your presentation.
Should I start sharing my screen?
Yes, yes.
Please make sure you adhere with the time. Whatever instruction has been given, please follow the same. 3-minute presentation plus 3 minutes for question answer. You are requested to please adhere with the time to complete the session on time. Thank you.
Is it visible? The poster?
No, it's not.
The poster is visible. Hello?
No, the poster is still not visible.
Still not visible? Mm. If I share the entire screen, it is not being visible.
Dr. Sujat, share your screen.
Yes. Is it visible now? Hello?
Not now. Not now.
Not. Uh, then how can you make it visible? Because it is not showing. I have tried. I've tried to share the entire screen. See, share screen. I have my PPT minimized over here, but it is not showing actually.
First, you share a
Do you have
screen,
my?
then click on PPT. First, share screen.
Yes, I'm doing the same thing only.
No, no, you are not visible. Your screen not visible.
कौन है?
Still not visible.
Dr. Sujata, are you able to see a share screen button on your laptop?
Yes, I have pressed that share screen, then entire screen. Then I'm sharing the entire screen,
Yeah,
but the
please.
PPT is not coming. PPT is there minimized in this laptop, but it is not coming. Do you have my PPT? I mean the PDF saved with you. Can you display that? I'm trying the PDF version also. It's not coming.
Yeah, you can proceed with this. That is fine.
Without showing the.
don't you just zoom in? We can look at this.
Can you see my slide?
We
Can
can
you
see
see
a
it?
poster, but it's too small. You can zoom in.
Okay, okay, okay. Okay, I am zooming in.
Just the bottom right
Now is it
here.
fine? Yeah, okay. It's fine. Is it fine now? Can you see this?
Yes, we can see, but it's not clear.
It's not clear till
It's
now.
fine. You can use the previous one and zoom with yes. Yeah, and you can
Now
scroll
it's
down
visible.
accordingly. Yes, go ahead.
So, may I start now?
Priyasi?
May I start now?
Miss Priyasi?
Dr. Sucheta,
Yeah.
please start.
May I start now?
Yes,
Sorry?
start.
I can start. Okay.
Yeah.
Thank you so much. Hello, everyone. I'm going to present a very interesting case, neurodegeneration with brain iron accumulation, a rare and unique challenge in neuropalliative care. Neurodegeneration with brain iron accumulation is a rare heterogeneous group of neurological disorders, which is characterized by abnormal accumulation of iron in the basal ganglia. It is a relentlessly progressing neurodegenerative disorder without any cure. Neuropalliation and rehabilitation can play important role in the management of this rare disorder. The case under discussion is an 18-year-old male who presented to the Physical Medicine and Rehabilitation OPD of Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi, with a complaints of gradually increasing involuntary movement of neck, speech and swallowing difficulties since last 2 years. On examination, the most prominent finding was cervical dystonia with mild dysarthria. And Wilson's disease was ruled out by ophthalmological examination. There was no K brain. Investigations showed that his MRI brain has a characteristic eye of the tiger appearance, which is very prominent feature in neurodegeneration with brain iron accumulation. He was being treated with trihexyphenidyl baclofen diazepam without any significant improvement. So he was referred from neurology department to the department of rehabilitation, and he was planned for injection botulinum toxin for his cervical dystonia. 135 unit of Botox was injected in the following muscles: left semispinalis capitis, left splenius capitis, left levator scapulae, and bilateral sternocleidomastoid. And you can see the pre and post injection pictures uh, that the patient who were unable to hold his head straight before the injection, 2 weeks after the injection, he was very well able to do so. The Farman-Marsden dystonia scale also showed improvement after 2 weeks after the injection. Now coming to the discussion, NPIA was first described by Hallawarden and Spurs in 1922, so it was called Hallawarden and Spurs disease. It is also known as pantothenate kinase 2 associated neurodegeneration or PCAN. It is a genetic disorder. It can be familial or sporadic. It can be early onset rapidly progressing type or late onset slowly progressing type. Only a handful of cases of NPIA are reported from India. Most of them were treated symptomatically. Deep brain stimulation, pallidotomy, thalassotomy were tried in other countries without much success. Here we can see in this case that botulinum toxin has been found to be very safe and useful in our case, along with supportive rehabilitation measures. So we can conclude that rehabilitation and palliative care have important role in improving the quality of life of patients with ADHD. Thank you.
Dr. Rupesh, go ahead.
Yeah, wonderful case, Dr. Sucheta.
Thank you, sir.
What was your plan for further management and needful regarding what was the duration of action in this case of botulinum toxin?
So duration of action, what I have seen in this case, I followed up this case for long, and after 12 weeks, he again developed recurrence of this cervical dystonia, and I had to give a second dose of Botox in this case. And as it is a relentlessly progressing neurological disorder, there is no cure. So this is just to improve the quality of life of the patient and to give symptomatic relief to the patient, because he was having severe difficulties in declaring. Videos would have been a better explanation for this, these symptoms. He was having severe difficulties in swallowing, and he was not being able to hold his head straight. And after the injection, he got relief, very much relief, and as time progressed, the symptoms recurred after 3 months, and after the second injection, again he got some relief.
Okay, so what could be the long-term treatment or cure for this type of patients?
So actually, now where I'm working in Institute of Neurosciences, Kolkata, it's a neurospecialty hospital. Here we are treating NBIE cases with deep brain stimulation, where we are getting very good results.
Yeah, that's what I want to listen from you. Okay, and what is the prognosis of this patient? Long-term prognosis?
Sir, long-term prognosis is, I think it's we will not be able to cure him totally, but with rehabilitation and palliative care and rehabilitation working hand in hand, we are giving the patient a better quality of life. That's what I can say, because we cannot cure this patient totally.
Okay, thank you.
Even with our neurological.
Okay, thank you.
I just have a question. Botox is used for this patient, but do you have other patients that you suggest with other conditions that you could use Botox in, like in palliative care patients?
Yes, ma'am. We do use Botox, like in patients with long-term spasticity patients. Even in CVA cases, long-term CVA, impending contractures, there we can give them a better quality of life using Botox. Their impending contracture can be relieved. I mean, those joints who are not totally fixed by Botox, by the contracture. So we can mobilize those patients by injecting Botox first. Their spasticity will be decreased, and then we can mobilize the joint. Their pain of they will be relieved of the pain of the contracture, and the severe spasms and spasticity can be relieved by injection Botox. We have seen many. We have injected in many cases of CVA and spinal cord injury, etc.
And would the duration of action be the same?
Mainly 3 to 6 months. We have seen with therapy. We always combine it with physical therapy also, and we have seen good results in up to 6 months. And of course, many patients, they do not require any revision of the Botox dose, because we continue them with physical therapy, occupational therapy, and all.
Thank you.
Thank you so much.
Next one, please. Dr. Abhishek Chakravarti.
Hello, good afternoon. May I present?
Yes, please start.
Yeah. Is my poster visible? Hello.
Yes.
Yes, it's visible. Go ahead.
Okay. Good afternoon, respected the judges, and everybody present around. I am Dr. Abhishek Chakravarti from Department of Radiation Oncology, AIMS Rishikesh. I'm going to present my poster on outcomes after palliative radiotherapy and chemotherapy in elderly cancer patients. So we conducted a retrospective study on the outcomes of palliative chemo and radiotherapy in elderly cancer patients. And malignancies in geriatric patients account for around 51% of the cancer burden, with the majority of them presenting with advanced stage of metastatic disease. The diagnosis of malignancy in elderly patients is usually delayed due to many comorbidities, which mimic the symptoms that are also seen in malignant patients, like prolonged cough, weight loss, and joint pains, etc. So, chemotherapy and radiotherapy provide symptomatic relief, symptom palliation, and improvement in quality of life. Hence, the study of outcomes after such treatment is deemed necessary. So, the aim of the study was to assess the clinical outcome after palliative chemotherapy and radiotherapy in geriatric patients. And it was a single institutional study conducted in the Department of Radiation Oncology. The patients who were registered from July 2018 to 2021. 106 patients which were aged more than 65 years were considered for the analysis, and out of which 16 patients defaulted. So at the end of the analysis, 90 patients were followed up. So following parameters were assessed, like age, performance status, the primary malignancy, associated comorbidities, the symptoms at the start of at the presentation, the treatment which was given, and the overall survival of the patient. So results. So out of 106 patients, 16 defaulted. So 90 patients were followed up, and the mean age was of the patients was around 70 years, with a male to female ratio of 1.9:1. And all the patients who presented in the advanced stages were around 55 patients, most of which the 55 patients were metastatic patients, and 23% of the patients presented with complaints of bony pains, neurological deficit each, and 4% patients also presented with hemorrhagic disease, acute blood loss, which was managed with palliative radiotherapy. So majority of the patients had symptomatic improvement following the treatment in the form of pain relief, in the form of relief in the neurological symptoms like cord compression, which had led to lower limb weakness, which improved gradually with palliative radiotherapy and rehabilitation. And there was also the hemostasis, which was achieved after hemostatic radiotherapy. 13% of the patients suffered from systemic hypertension, 7% with respiratory comorbidities like asthma, past history of TB, and COPD. 6% of the patients were suffering from diabetes, and 60% of the patients had a performance score which was ranging between ECOG 0 to 2, while 40% had a performance score of ECOG more than 2. So 75 patients were subjected to palliative radiotherapy alone, out of which 57 patients completed the treatment, and rest of the 18 patients either could not complete the treatment or had acute toxicities which led to defaulting the treatment. 10 patients received only palliative chemotherapy, out of which one patient expired due to toxicity during chemotherapy. 4 patients received both palliative radiotherapy followed by palliative chemotherapy, and along with one of the patients receiving hormonal therapy. So of the 47% patients who expired during or before the start of treatment, 46% patients expired due to the disease-related condition, while 54% patients expired due to other comorbidities like poor tolerance to chemoradiotherapy, COVID, and kidney diseases, sepsis, and respiratory failure. So at the end of the study, the discussion I would like to discuss is, I would like to conclude that palliative treatment needs tailoring for each patient, depending upon age, the performance status, the comorbidities, the disease burden, symptoms, and emergencies. Thank you.
Okay, Dr. Abhishek.
Yes, sir.
Yeah, wonderful presentation. I just want to know what kind of palliation you have given to your patient other than palliative radio and chemotherapy.
Sir, actually, my study was mainly to emphasize on palliative chemotherapy and radiotherapy. Apart from that, if the patients are like, if we do a comprehensive geriatric assessment for such patients, so if the patients are having conditions like depression, we can subject them to psychosocial. We can like refer them to psychologists for a better care. And if such patients require more nursing care at home, we can also advise them for home-based care. And we can also, if the patients are very debilitated, we also advise them for hospice
What
care.
kind of palliative care setup in your institution?
What kind of palliative care, sir? We have physical rehabilitation also we are giving, sir, and
It's a multidisciplinary or a single
the
discipline?
multidisciplinary mostly.
Who else are involved in palliative care other than your fraternity? You are from radiation oncology.
Yes, sir. Sir, medical oncologists are also involved in our institute, and mm, uh, इसके अलावा sir, mostly actually our department is only taking care of palliative treatment in our
Okay.
institute.
Okay. And what about the 21% of patients having bony pain?
Yes, sir. I followed up the patients, and
Of bony pain in your institution?
sir, bony pains usually in malignant conditions we are giving radiotherapy. Apart from that, bony pains we either if they're associated
Straight
with
away you are giving radiotherapy or what else the protocol?
sir bony pains if
The
they're
effect
associated
of radiation will come after some time. Till then, how you manage bony pain?
sir, we are starting with with WHO this analgesic protocol that we follow. First, we are starting with NSAIDs. If the patient is not having relief with that, we are adding weak opioids. And gradually, if the patient is still not having, we escalate it to morphine.
So what is the dose of morphine in such kind of patient?
Sir, 5 milligram 4 hourly we prescribe.
Okay, other than WHO letter, what is the other co-adjuvant analgesics, adjuvant drugs for treating bony pain?
Uh, Sorry, sir, I'm not aware of that.
Okay, thank you.
Thank you, sir.
Yeah, thank you, Dr. Abhishek. Nice presentation. Thank you for mentioning about the results that you had. It was not there in the poster about the effectiveness of the radiation that you're given. What I'd like to know was, did you get a percentage of how many who benefited from these treatments?
Ma'am, mostly it was a retrospective study, but I still tried to follow up a few patients and by telephonically contacting them. And actually, 47% of patients had actually expired, so I could not get the data of that. But
Yeah, because
few
yeah.
patients who were alive, for that I did get. Few of them had improvement, but
Yes.
I cannot say everybody had. I don't have the exact data of that.
Yeah,
Sorry.
because to have a good study, it'd be good for you to present the percentage of how many improved with the treatments, and also, you know, triaging them according to their performance status. So that will be very useful for other practitioners to know how to gauge and triage patients for these treatments, weighing the
Yes,
benefits and risks.
yes, ma'am. I'll try to follow up in the future if I get opportunity.
Yeah, thank you.
Thank you so much, ma'am.
Okay, so the next poster, Dr. Amit Jain.
Hi, good afternoon. Good afternoon, sir. Good afternoon, ma'am. So I'm sharing my screen. Are you able to see? Sir, you able to see the present?
Doctor, please cross this share.
Yeah. See. Yeah. Able to see?
Doctor, please stop this. We are sharing your presentation from our end.
Okay, okay. I'm stop sharing it. Yeah, please. Sorry for this. Can you see it now or please?
Please go ahead.
Yeah, yeah. So good afternoon, everyone. Today, this presentation, I will like to say the my poster presentation or topic was assessment of end of life care and quality of dying in a tertiary hospital. I'm palliative care consultant in Dharmshala Narayan Super Specialty Hospital, Delhi. What we do in our this poster, we calculate the total deaths in our hospital from the month from July 21 to December 21, and we found out that 45% of people die with terminal illness. But and a patient at end of the life care, how they got the treatment in the form of symptomatic relief, in the form of clinical management, and end of life care, whether they actually receive and whether these expectations are differ from like expectation of death and whatever the curative and palliative part they have received during their treatment. So what our aim was to assess the quality of dying and end of life care relation in relation to all this investigation, treatment, and symptom management. Because we are a tertiary care hospital, most of our the intention was on the curative. So in this study, we did the retrospective study and we did it from the records of the patients who were admitted in our oncology ward, not in ICU or CCU. We do the study only on the oncology ward and from July to December. We have included the patient who died in the above period in around 48 hours of admission and patient who are above 18 years of age. We exclude the patient who died in emergency or in ICU or in CCUs. And we collected the data from the sheets that how many are, what treatment they have received, what diagnostic procedures and investigation and interventions which were done there on this patient, and what was the result of all these investigations. So what we define it, we make a questionnaire on the basis of just like that 5 point scale from strongly agree to strongly disagree. We ask the patient relatives first, would they are they expecting that their patient will die in next 48 hours, or any of the consultant has ever said to them before admission or at the time of admission that this patient might die in 48 hours. Most of the time they said that we didn't been informed about that our patient is about to die in next 48 hours. They said that this patient is sick and we are doing whatever the best possible. Then we establish the quality of dying in relation to certain intervention like hygiene care, if they are getting the adequate bedsore care or any oral care and anything, and if what other procedures are doing by nurses over them, like sectioning, oxygen delivery, mobilization, any vascular devices and invasive procedure. And most of the patient comes in septic shock or in bedridden condition or with multi-organ failure or with like renal failure. So most of the part we did like in consultant advice for dialysis therapy, hemodialysis line or anything to prolong the life. So we calculated all that investigation, all that intervention done or advised or whatever the medications of were prescribed to them. Then in the end we find out that total like 104 patients were included in our study, and we find out routine blood tests were given performed in 85% of patients in almost 85% of patients that everyone knows that this patient will going to die in next few hours or still routine investigation were being carried out. And what we find out that most of the patients had respiratory fatigue in 72%, urinary
Hello,
incontinence. Yeah,
Dr.
please.
Amit.
Yeah, ma'am.
The presentation time 3 minutes are over. Can we start with the question and answer?
Yeah, please, sure, ma'am.
Yeah, Dr. Rupesh and Dr. Amy, please.
Yeah, so just thank you for the presentation, Dr. Amit.
Thank you.
Thank you. So 104 patients were included, and you had excluded patients who died in the ICU, CCU, and ER. Yeah. Actually, a lot of deaths do happen in ICU. So is there any reason why you excluded them? Because out of that, however many percent, 45% of people die. So is there any reason why you have excluded that?
Yeah, I have excluded death in the ICU because in the ICU part, they are more concerned with the curative part rather than the palliative part. But the patient is sick and everyone is suspecting like stage 4 cancer or terminal illness. So that patient should not be moved to ICU for the curative part. And in our ICU, most of the things are towards the curative side. They are doing everything on the ventilator, on lines, arterial lines, and dialysis. So we exclude that part because in that ICU, palliative part is missing in that patient.
Okay, but you said that ICU consultant referrals were more sought. So did they come and see the patients in the ward?
Yeah, they come and see the patient in the ward and they advise for the ICU admission. Some are shifted to the ICU even when admitted in the ward, that in the later stage just for 2 hours or 3 hours at the end they were shifted to the ICU. But only intervention what they did here was just a ICU consultant visit rather than a palliative care visit to the patient. They are primarily admitted under the medical oncology, surgical oncology, or radiation oncology. But
So
palliative consultation was less rather than ICU consultation was more.
So you saw in your chart review that was the result. Okay.
Yeah.
So okay. How did you assess the quality of death in terms of whether did you have any protocol for symptom control, whether the patient was comfortable not having breathlessness?
We go for the holistic care, like we go for the physical care, how much physical symptomatic relief he is getting.
Did you have a particular format or protocol?
We designed a simple protocol, like 5-6 points we have taken physical care, psychosocial care, spiritual, and any other concern by the relatives or any other wish of the patient. Just on the 5-6 points on the plain paper. No other definitely scale we have used. Like from 1 to 10, we have giving the scoring and then we assess the quality.
Okay, thank you.
Okay, Dr. Amit, what is the policy of end-of-life care at your institution?
As such, in our policy, it was written that as per the wish of the patient and the relative, it should be done, should be physically relieved of symptom management and whatever they want in the ward. But most of the time, the death in the ward, usually when visited by ICU consultant, they said that
and your hospital is NABH accredited hospital?
Yeah, it's NABH accredited.
So there must be
tertiary care hospital.
So there must
There is
be
a
a
form.
definitive, yeah. So there must be a definitive end of life care policy at
Definitely.
your institution.
Definitely, there is a form.
Go
Yeah.
ahead with that policy and make changes according to the plan you have made, because you are doing wonderful job. I have
Yes, sir.
seen
We
your
are trying,
data.
sir.
You
Yeah.
are
Yeah,
doing so.
sir.
You need to edit your end of life care policy at your institution.
Definitely, definitely, sir. I'm
That
trying, sir.
will change a positive
Yes,
side.
sir. Sir, I am the only
Okay.
person who is doing palliative care. Right now, after
Yeah.
me, I've done that initial fellowship. After me, two
Yeah.
person have recently joined, and now we are making a
Okay.
department in our
Okay.
farm.
Because there is a problem with triaging of these patients. So
Definitely,
better
definitely, sir. There is.
change the end of life care policy at your institution. And I think the future is very bright. है ना?
Yes, sir. Definitely, definitely, sir.
Good, wonderful
Next year,
job
I
there.
will.
Okay.
Thank you, sir. Thank you.
Thank you.
Thank you, sir.
Please go ahead with the next presentation.
Yeah, sir. So I have to share the screen with that.
Good afternoon. I'm Sujata. My presentation topic is patient satisfaction and barriers to quality of nursing care in oncology units. A hospital is an organization that provides treatment to a patient where the primary component of the hospital resource management is patient satisfaction. This particular study is done to determine how much the oncology patients are being satisfied with the nursing care quality, and we could able to find the barriers also. The study setting is it's done in one hospital with a cross-sectional correlational study, and we have selected around 100 patients by using convenient sampling, and the tools which were used to collect the data were patient satisfaction measured with the nursing care quality questionnaire, and barriers with the help of a checklist. We have collected the barriers from the patients. The statistical analysis, which was done with the help of SPSS version 19, and the result says that 33.31% of patients were satisfied with the quality of nursing care, and the overall barriers were around 33.5%. And this study concludes that the study revealed that among highly satisfied patients, the majority were undergoing chemotherapy, where the least were undergoing the radiation, that is 68%. It also reveals the major barriers where the workload of the nurses and the lack of time, inabilities to speak the local language were the major barriers of patient satisfaction. Thank you.
Is it possible to increase the size of the poster, please? We can't actually see the results.
Madam, I could not able to do it. That's
Okay,
why
no,
I
no
asked.
problem, no problem. So when was this study conducted?
Around 2 years back, I have conducted the particular study.
Okay, and did you, with the conclusions, did you devise any way of crossing
yes,
the barrier?
This study findings were reported to the medical superintendent regarding the particular language barrier. We could able to do something. We could able to observe the trained nurses, locally trained nurses, so that the language barrier we could able to improve. Actually, we could able to cut short the barrier between the nurses and the patients.
So any other efforts to cross the barriers?
Some of them, they were saying one more barrier we could find is lack of motivation. So we could able to organize many in-service education through which their attitude we could able to increase the attitude towards patient care.
Okay. Did you find any other patient barriers besides these?
Other than that, they have found that the lack of resources, for which also we have done the audits, internal audits, and we could be able to improve the resources, what is lacking in the particular units, oncology units, that we could able to improve it. And we found that major problem is inadequate nursing number of staffs. That also in those units we have increased the number of staff.
So have you done another survey just to see whether the efforts you've done have produced the results?
Actually speaking, I have I went and spoken to those units regarding this, but I have not taken a survey as such. It was done as a descriptive study like this.
Okay, thank you.
Thank you.
So you have actively involved in patients of palliative care?
In our setting, we don't have palliative care, sir. Actually, for pain, they are giving palliative medications are being given, but setting as such, we don't have.
So on what basis you have designed this study? What was the...
Actually speaking, majority of the oncology patients who are, whether they are satisfied with the nursing care, quality of nursing care, are they satisfied, and what are the barriers which is obstructing them to get their satisfactory level? That is what we would like to see.
So if you are not involved in active care of palliative patients, so how would you understand the barriers? I think I encourage your efforts that you have done a very good job, but how will you going to understand the barriers if you are not involved in active clinical care of these patients?
Actually, palliative unit is not there. That we are involved in patient care.
Okay. So I just want to ask, what triggers you to do such kind of a study? Is there any incident or any motivation or any courage or encouragement from others?
Actually, I'm sir, just
okay. Thank you.
Yeah,
Thank
it's
you.
probably more like a quality assurance thing. But have any of your nurses undergone palliative care training? Is my
yes,
question.
yes. Actually, I have taken up certificate courses, and I have been trained in palliation. So I am been training the nurses in palliation.
Okay, you're continuing to train. That's good.
Yes, yes,
Yeah.
yes.
So,
Education.
so with the same principles of palliative care, it's important
Yes.
for you to make sure all the nurses are also trained in them.
Yes, yes. I'm doing actually.
Thank you. All the best.
Can we have the next participant, please?
Dr. Amit, are you there?
Yes, I'm there. Yeah. So you're going to get a score. So
Dr. Amit Jain?
Takes of 10 points for each of the questions.
Yes, sir. Hello, sir.
Are you sharing or shall we share from our end?
Sir, it's good if you can share at your end.
Sure. Quick.
पूरा बंद करने दीजिए. Good afternoon, everyone. In this poster, like everyone has used the systemic morphine for breathing difficulty in our palliative care. But I have tried in a breathing difficulty in morphine in the form of nebulizer, and that too especially in the form in CKD patient. Because in our office, CKD patient were not getting adequate like morphine. They were saying that it's nephrotoxic, though in low dose it's not. But as such, I tried morphine nebulization for breathing difficulty for refractory dyspnea in CKD patient. So, as you all know, dyspnea is a subjective feeling of sensation of breathlessness and is one of the most common complaints in palliative patient. Systemic morphine has definitely a role in elevating the dyspnea, but nebulization role is still not yet proven. Though many of people have tried nebulization role, so what we did, what our aim was to study clinically any improvement in breathlessness in this CKD patient in which systemic morphine cannot be given safely. So what we was we take a 30 mg of morphine, dilute it with 5 ml of normal saline, and through alternate nebulizer, we start giving the morphine in the form of nebulization in a distant patient. So what we record that is there any subjective effects on reading of bars that after say after 5 minutes, 15 minutes, 30 minutes, and 60 minutes of nebulization, is there change in the dyspnea? Is there change in the respiratory rate or any other thing or patient getting drowsy or any effect on the urine or uric rate on next day? So we tend to monitor the respiratory rate, SpO2 and pressure during that 1 hour of nebulization and after that. And what found that no major adverse effects were noted in 1 hour of giving the nebulization. We repeat it every 4 hourly for the dyspneic patient, and what we found that there was a decrease in the respiratory drive. There was a palliation of the symptom. The patient was getting more better, and dyspnea was improving in 7 out of 10 patients with no major effect like respiratory depression, sleepiness, nausea, or vomiting. We concluded that morphine as such act go by systemic it act on beta 2 endorphin and mu 2 receptors. But when we study the literature, there are some other mu receptor located in the lung, which we see as P receptor, that are located in trachea and nasal bronchus. That activated and when we give morphine in the form of nebulization, these receptors get activated and which decreases respiratory drive, which help with the palliation of the dyspnea and patient feel better for that. So that was the meaning of giving trial this nebulization morphine for breathing difficulty in our CKD patients. And open the question.
Dr. Amit, is the
Yes, sir.
nebulized morphine is recommended for patients
So as such, it is
nowadays?
recommended
What
for
is the current
intractable cough.
recommendation?
So current recommendation of a cough, irretractable cough, we give nebulized morphine, and that too they are studied in the dose of 10 mg. But we tried for 30 mg with 5 ml saline nebulization and 4 to 6 hourly. As such, in COPD, one study they in lungs thoracic journal, they are given one study for cough and dyspnea with nebulized morphine. But not so because not so significant that they keep on continuing this nebulized morphine. But what we have observed in the palliative patient, nebulization morphine can be given if in CKD patient when systemic morphine they are trying to avoid. We are getting the low dose morphine or fentanyl, but we tried for nebulization.
Yeah, Dr. Amit, did you try spacing the doses of morphine, like the systemic morphine? Because the recommendations, there are no very conclusive studies that show that nebulized morphine helps. Yeah.
Yeah, there is no conclusive medicine study so far for nebulization, and whatever they have done with 10 mg of morphine, they have done. But we tried for 30 mg, but as such, it's a very less patient, 10 patients we have done.
Yeah, but
So
did you try
maybe,
spacing systemic morphine in the first before doing this nebulization?
No, as such, we didn't try for giving systemic morphine because patient was already CKD and they're not on dialysis and something. So in that, we didn't try for systemic. We directly tried for nebulization.
So what did you do? I mean, these patients were admitted patients, but what if they wanted to go home? What would you do? How would you give them the nebulization?
It was just for an acute emergency phase only. Like when they were very sick, and apart from other nebulization, we tried giving morphine nebulization.
So you meant to say that you gave this for end of life care, or
not exactly end of life, but the time of admission when they were came in with more breathing difficulty. In the ER, we tried giving nebulization morphine apart from routine nebulization.
Yeah,
But we are giving steroid and everything. It's just we tried one more mechanism as morphine nebulization.
so my question is like, what would you do when patients will continue to have breathlessness? Because CKD, yes, they will keep having breathlessness if they don't go for dialysis, and especially for palliative patients, they're not going for dialysis. So they will have these breathlessness events. So how would you manage if they're home and this breathlessness continues at home?
We didn't recommend anyone so far to take this nebulization morphine at home. We just tried at the hospital that if any side effect will occur, we will handle.
Okay. Yeah, it would be a good thing to follow up on these about these patients to know what you would want to do, because they will come back again and again. And would you want them to keep coming to the ER?
Definitely, I'm doing that. We'll make a study.
Yeah, thank you.
Thank you. Thank you. Thank you.
Next presenter, please. Ravlin Nagi. Do we have Ravlin?
Dr. Ravleen is not there. Dr. Ashwin is also not there. So we can move to another session, another topic.
Okay. Okay. Dr. Anshita Sharma next.
Excuse me.
Yes.
Dr. Ashwin, on his behalf, I am there. No, Dr.
Okay.
Devdatti.
Okay. Sir, please go ahead.
P7 is my number.
Yes, sir. Sir, please share your screen.
So shall I share my screen?
Yes, sir.
Okay. Hello. Hello.
Yes.
Am I audible?
Yes, sir, you are audible. Please share your screen.
How can I share my screen, ma'am? I gave them the PPT, your tech team.
Okay, sir.
I gave them that. I have emailed the PPT.
Okay.
Yeah, this is exactly. Yeah. Good noon, all. Here, actually, this is a bit blurred, but here we are. We did a retrospective analysis of the caregiver satisfaction on the basis of FAMCare scale. We have been using FAMCare scale to assess the caregiver satisfaction amongst us in the health in patients for healthcare workers, and for that we analyzed 400 patients in our OPD in Department of Palliative Medicine in SMS Medical College, Jaipur. We got all the 400 forms duly filled and duly signed. And I would like to just introduce this FAMCare scale. FAMCare scale is the family care, cancer care, comprehensive care done, and in this FAMCare scale, we try to understand the profile of end user, and we try to retrospectively analyze the treatment received, the relief obtained, and patient education and counseling in terms of the attendants or the caregivers who are giving care to patients at home. Aim of study was to assess patient satisfaction levels regarding palliative care services rendered by us. In it, we conducted the study on 400 patients, and on the first follow-up and the second follow-up of 15 days, both responses were recorded. It was a 20-point FAMCare questionnaire. Actually, it is not. Let me a minute, please. Now, in which 20 point out of 10 and 20 questions, I have evaluated the 10 questions. चिकित्सक कर्मियों द्वारा पूछे गए प्रश्न, यानी the questionnaire which was questioned by doctors. In that case, 13% people were very satisfied, 70% people were highly satisfied, and rest were dissatisfied. Another question was availability of doctor to the family. In that case, 14% were very satisfied, 54% were satisfied. And then how did the diagnosis of the disease was done? In that case, again, 72% were satisfied. Such like this, overall, the conclusion of the study was this, that 60% of the people were satisfied, 40% were very satisfied, and almost 2% were dissatisfied. That was a very low score. We concluded that retrospective analysis of the caregiver services, like what has should periodically be done to identify a lacuna, so that assessment can be done that what are the areas in which we should improve as far as caregiver satisfaction is needed. That's it.
Okay, Dr. Sharma, what was the aim of the study? Is to assess the patient satisfaction or caregiver satisfaction?
Caregiver satisfaction, sir.
But you have write down in your slides, the aim of a study was to assess the patient satisfaction.
Patient and caregiver both. Caregiver.
Just look at your slides.
Yeah, actually, क्या इसमें availability sir, it's not. I cannot see it here. I will see it on my phone. Wait a minute. There is some problem with the technological part. To assess patient satisfaction levels regarding palliative care services rendered.
And you are saying that patient caregivers satisfaction?
The patients are in our setup. The setup the patient.
Listen. Both the things are altogether different sort of things, है ना? Patient satisfaction and caregivers, है ना? What you will analyze, you just tell me.
We analyze that we got a 20-point questionnaire. Questionnaire patients के जो attendants थे, we asked them to fill that. And these all questions we have evaluated the all charts. They are based on the responses filled by the patient's attendants or the patient himself. They are analyzing our response. They're analyzing our response. Matlab, their attitude towards us. What are their viewpoints about our services? What service?
That was patient satisfaction or caregivers?
Sir, patient's assessment of caregiver satisfaction. This is patient's assessment of caregiver satisfaction, how they are satisfied by our services.
Okay, thank you.
Welcome, sir.
Yeah, so the question was, how did you take the questionnaire? Did you take the questionnaire from the patient?
No, questionnaire
from the attender?
Questionnaire is a FamCare 20-point program. The standard FamCare scale which we have, we just utilize that.
So you took the question, you question both the patient or the caregiver, either one, just to assess how the doctors, how they are satisfied with the doctors and the healthcare providers services. Is that what you?
Yeah, we question the patients.
Okay. So wouldn't it be better if you had done like an audit and then later did some changes, then reviewed whether the changes were?
Yeah, we did changes. We are working on that. It's an ongoing study.
Yeah.
We have already studied them.
So a better way to do it would be to do an audit, like a 100% standard for the satisfaction, and then based on that, what percentage you got, and then make changes according to that, and do a re-audit. So there will be a better thing to do.
We will go for a re-audit.
How you will validate your questionnaire? That was the problem.
Yeah.
That's a standard questionnaire of FamCare. FamCare scale है ना जो 20-point questionnaire. We have just used that.
Okay. So now that you have a standardized validated tool, then you can use make it an audit.
Yeah, we have done our audit of almost 437 patients right now.
Okay.
And that audit was done in a digital tablet, digitally signature by every patient. And that was done accurately. A patient was not they were in a very critical stage. So we asked their attendants to fill the questionnaire.
Okay. Thank you.
Thank you. Thank you, madam.
Okay.
Thank you, sir.
Ma'am, can I start? It's T8. Yes, please. Please start. Yeah. Sure. And is my screen visible? Yes, your screen is visible. Dr. Devdat Sharma, please mute your mic. Okay. So, good afternoon, respected mentors and friends. Myself, Dr. Anshita Sharma, I'm second year palliative medicine resident from Tata Memorial Hospital, Mumbai. My study topic for this presentation is symptom profile and outcomes of advanced cancer patients referred for palliative care in an emergency department in a tertiary care oncology center. To introduce my topic, patients with advanced cancer presenting in the emergency department with distressing symptoms, palliative medicine has a very important role in acute palliative care emergencies by reducing the symptom distress and improve the quality of life. Aim is to determine patient's characteristics, reason for referral, symptom profile, goals of care documentation, and outcomes of such patients with advanced cancer for palliative care consultation in emergency department. It is a kind of retrospective descriptive study design using electronic medical record of patient in emergency department over the period of 2 months. Variables recorded are cancer diagnosis, presenting symptom, performance status, management, and outcomes. The inclusion criteria is advanced cancer patient referred to palliative care center in emergency department, and the exclusion criteria is incomplete documentation. Uh, Looking at the diagram, the result out of 349 patients, 250 patients were eligible, and with the median age of 50 years, most of the patients were adult of 72.8 percentage, followed by geriatrics 21.2%, then pediatrics approximately 6%. Maximum patients were female of 53.2%, then male of 46.8%. Out of 250 total patients, 60.4% of patients were from outside Mumbai and 39.6% patients were from Mumbai. 56.8% patients with ECOG of 3 to 4 and 43.2% patients with ECOG of 1 to 2. The most common diagnosis detected is thoracic malignancy of approximately 18.5%, followed by gastrointestinal malignancy, head and neck malignancy, breast, hemat, pediatric malignancy, and so on. Most common presenting symptom is pain, approximately 37.6% patients, respiratory symptoms, gastrointestinal and GU symptoms, CNS symptom, metabolic disturbances, fever, and bleeding. Most of the patients were managed with opioids. Out of 250, approximately 80 patients need opioids, IV antibiotics, O2 support, steroids, hydration, antipsychotics, benzodiazepine, electrolyte correction, and transfusion. Goals of the care were documented in 77% of referred patients, out of which 66 were best supportive care, 23% were early palliative care, and 11% were end of life care. So the outcome of my study is 75.2% patient came for the OPD follow-up and 36.7% from the Mumbai patient we recruited for home care facility. 14% patients referred to local palliative care centers. 10.8% patients were died. To conclude my topic, advanced care patients who attended the emergency department were mainly female with advanced lung, gastrointestinal, and head and neck cancer and hailed from outside Mumbai. Pain and dyspnea were the most common presenting symptoms, treated mainly with opioids, IV antibiotics, steroids, hydration, and the goals of care documented in 77% of the referred patients. Thank you so much.
Dr. Anshita, wonderful study, wonderfully presented. And what is the end of life care policy at your institution?
Sir, in our institution, sir, first of all, we start the pharmacological management of the symptoms of end of life care like dyspnea, pain, and delirium.
No, I am talking about end of life care policy at your institution. You can say like what is the criteria for triaging of these patients, IPD admissions, referral.
Okay. So basically, sir, if the patient is not from palliative medicine department,
You have read anytime your institutional end of life care policy? Have you read?
Yes, sir, I do read, but I cannot recollect the exact language right now.
Okay. Okay. So what is your take home of this study? That is very important.
Yeah. So, sir, after doing this study, I just came to know that the 77% of patients were referred
and their goals of care is documented. So seeing this, this is really beneficial for the quality of life of the patient. That the documentation is very important, like whether the what is the intent of treatment, the patient and the relatives know what is the intent of the treatment, so they can plan accordingly their place of care and their future, what are the goals of care, what are their future prospects looking at a condition.
And the good take home from this study is many of the patient can be managed in a OPD setup or a home care setup. So there is
Yes, sir.
less number of patients who really require hospitalization. Okay?
Yes, sir. Yeah.
Yeah, I also want to say that it's a very well done study, very nicely presented. Also, another take home would be, are the ER physicians trained in palliative care in the hospital? Or do they send the referrals to palliative care department?
And they send referral to palliative care departments, and we residents, we remain on the rotatory emergency duties. So whenever the reference is there, we go to emergency department and see the patient and treat accordingly.
So are you the team that writes documents the goals of care discussions?
Yes, ma'am.
So that's where you've seen that 77% are documented. So that's definitely a place for improvement, but it's actually very good already, but it has to be 100% because you're talking about Tata Memorial Mumbai. So it's a great institution. So have the ER physicians been trained in palliative care, at least a certificate course or some basic training? Or are they clued on to immediately refer patients?
So, ma'am, right now, not we cannot say like it's not any certified course. They are not trained under any certified course. But yeah, ma'am, we do have 6-week course and other short courses. So they just give us a referral. They are not properly trained, but we don't have actually any ER physician. We have the medical officer in
I
our
see.
emergency center.
Okay.
Yeah.
Okay. Yeah, thank you.
Thank you so much. Thank you, sir.
May I start?
Yes, ma'am, please start.
Good afternoon, all faculty. Dr. Pratima Agrawal, working as a medical officer in BMC-HRC. Today's my poster topic is feasibility of subcutaneous route in outpatient palliative care department. Introduction. We every time when patient come in palliative department, there is very difficulty to find a accessible route for drug administration and quick symptom relief. The subcutaneous route require minimal expertization, minimal technical assistance, and a low infection rate. Our aim was to evaluate the effectiveness of subcutaneous route in outpatient department. Sample size was 25 patients, and it was a prospective interventional study. All cancer patients who come in our OPD with moderate to severe symptom on NRS score were taken in this study. Exclusion criteria was anasarca, fluid overload, skin infection, bleeding diastasis, hypotension, and we also exclude the patient who have severe allergic reactions, which I not mention in this is poster. We took 24 gauze cannula inserted at the upper arm, mainly upper arm, because it is the mainly accessible site of the patient. Parameters we recorded symptom severity on NRS score 0 to 10. We recorded the data on baseline 15 after 15 minutes and after 30 minutes after drug administration.
Other data we record: indication, drug used, volume, patient feedback, and side effects. The results, we find the primary tube was head and neck was 28%, genitourinary was 28%, GI tumor 20%, and others lung and carcinoma breast. Cancer status was 60% was metastatic disease, and locally advanced disease was in 40%. History of chemotherapy, more than 6 cycle was got in the 56%. Indication for ST route was acute pain for 76%. Vomiting GI intolerance was 12%. Pain plus vomiting 12%. Medication we use tramadol plus metoclopramide in 68%, metoclopramide only in 8%, Zylocard in 8%, and tramadol plus metoclopramide plus Dextrona in 8%, haloperidol in 4%, and morphine in 4%. Volume we use is 0.5 ml to 12.5 ml. There was no side effect in any patient. Recorded data, we then find pain and vomiting score fall down 50% in 15 minutes, and after 30 minutes it was only 20% pain and vomiting remains in patients, and there were very satisfied patient was 64%, and 68% was not complaining of any pain in injection site. Conclusion of our study was subcutaneous drug administration is simple, safe, efficient method of rapid symptom relief in busy outpatient setting with better patient acceptance. It can avoid a costly admission for symptom management. Thank you, sir. Open for questions. Thank you, ma'am.
Yeah, thank you. That's a nice study that you've done. My question is, like, did you give these medications in combination, as in like together in one syringe, or did you give them separately?
Separately, ma'am. After because after metoclopramide we wait for 10 minutes because in one bolus we can't give a 4 ml volume or 3 ml volume, so we wait for 10 minutes and give separately.
And the volume you mentioned was 0.5 to 12.5. Did that mean that you included all the injections?
Drugs, because the Zylocard be given by subcutaneous infusion pump, so the volume was 12.5.
Yeah, so you would have given that separately, different from a different site from the other medications, right?
No, ma'am. Most common visible site was upper arm. So
no, what I mean is, if you had to give 2 injections, did you give Zylocard separately in another arm and then the other injections in the other arm?
Yeah.
Okay. Now, okay, for this, you manage in the outpatient setting, but when the patients go home, supposing they are unable to swallow, how would you send them home with these injections?
Ma'am, we can give them injections, tramadol, but can't give them morphine at home. If he's not able to swallow, we can put rice tube.
You put a rice tube. Supposing there is difficulty putting rice tube, do you teach families how to give the injection?
Yes. Main purpose of our study is to minimal technical assistance, so we can teach the family and the caregivers. So there will be required minimum hospitalization. It will be reduce the cost of family.
So
repeated admission.
So you teach the family after you've given this injection.
After the given. Yes.
Okay. Thank you.
And
Dr. Rupesh, you're muted. Sir, unable to hear you, sir.
Hello, Dr. Rupesh. Dr. Rupesh, sir. I think Rupesh, sir, are you here? Okay. So back again. So this was the session 1, and now we are beginning for the session 2. So I will repeat some of the things, 2-3 things, like uh, all the participants, please be aware of the time and please take care of that. 3 minutes are for presentation and 3 minutes for the question and answer.
Thank you, ma'am.
Now I would like to welcome Dr. Rajan Iyer. She is working as a consultant pulmonologist and palliative care physician at the Bhatia Hospital, PD Hinduja Hospitals. Second judge for our session 2 is Sister Hanife. She is hospice and palliative care nurse specialist, DNIP Care Delhi. Also, she is the head and instructor, LNEC USA in India. I welcome you both, ma'am. Mohammad Adnan Khan, please start.
Hi, good afternoon. I am Dr. Mohammad Adnan Khan from Sukun Nilaya. I'm the medical officer over here. So I'd like to present mainly an observational study from our center on life-sustaining treatment, withholding and withdrawing life-sustaining treatment, and how do we go about it generally in a nutshell. So to begin with, LST, as we are all aware, life-sustaining treatment is any treatment that serves to prolong life without reversing the medical condition that...
Sorry to interrupt you, Dr. Khan. You need to make it full screen.
Ma'am, it is being shared from there. So just someone could make that from
the somebody from please make it full.
F11. Yes, someone could just press F11 from there. So.
Priya, can you make it full screen, please? Priya C.
Yes, ma'am.
Thank you.
I think just F11 would do.
Hello, ma'am. Hello.
Hello.
Ma'am, can you hear me?
Okay.
Tell me.
Ma'am, this is the full screen only.
Are you sure with all these things you shouldn't be? It was not there the last slide.
Could you just press F11? F11.
Just press F11, Priyasi. It will work, I suppose. Otherwise, Dr. Khan, you proceed.
Okay. Dr. Khan, you please proceed. We are doing it.
Okay. So, LST, life-sustaining treatment, is any treatment that serves to prolong life without reversing the underlying medical condition. And there are different implications in different countries about withdrawing or withholding LST. And so here we are just presenting some experience as well as some literature that was that was found on the reviewing the reviewing of literature. So our aim was to study the practices in a palliative care center in Mumbai that we looking in that looks after both cancer as well as non-cancer cases. So it was an observational study in which we collected data of 9 patients who received LST in our palliative care center, and just a review of some legal rulings in India so far, and just a few tools that were that could be used. And firstly, the LST involves ethics. That is, there are a few 6 core values of ethics in palliative care that we always follow. That is autonomy, beneficence, non-maleficence, and justice, dignity, and truthfulness and honesty. Assessment so a few assessment tools that were there, in which willingness to accept life-sustaining treatment has been used in instrument has been it is a six six questions in this thing instrument that has been used in quite a few studies where they compare cost I mean the impending cost versus the benefit and versus the duration, and according to which the patients are able to choose their uh, advanced medical directive, or whether that they would want to go, of course, after considering the core ethical core values of ethics in the palliative care. And another tool is relatives patient management questionnaire, and there are many other such which that probably measure the burden in the both caregivers and patients that is the surrogates and the patient, as well as if the patient is not kept able to decide. So now, how do we approach to decision making? So first, we check the legality of the ethical and legal considerations in the particular uh, area or state or city or wherever the jurisdiction that is considered, and then the hospital policies, as well as the institutional policies, and as well as, and then the second step is that we could consequences of the whether what would the prognosis, what is the current prognosis of the patient, what would be the goal of withholding or withdrawing treatment, and what would be the outcome of that, and then according to that decision making, so that involves the patient, if not, and if as well as the surrogate or the family, and whether there are any advanced medical directives, whether any conflicts between the team, the multidisciplinary team that is taking after, or and other the legal and ethical certainties that are there. So according to that decision making, and after that we also, I mean, with at the same time we also have to uh, find make a symptoms. So the management, whether to withhold and withdrawing the LST, so what would be the resulting symptoms, and a clear management of that we have to anticipate. So this is a, and then in the Indian scenario, of course, then there are a few things that like initially there is this leave against medical advice um, versus DNR, and then the Aruna Shanbag case that involved passive euthanasia, and then there was a Supreme Court of India ruling in the March 2018 regarding advanced medical directives, and a few other guidelines on the on withholding, withdrawing LSTs. And so the figure one, it shows the patients who required, a few patients from our institution who required decisions on LST. So LST, so the three patients of ours were, we ensured that their nutrition was to be optimized, and the calorific intake and all, and they were also they were given oral RT feeds, as they were not able to feed orally, and there were three patients in that, and there were around three patients who needed who were admitted in the palliative care center, and they needed referrals to tertiary hospitals. One was one needed a blood transfusion, which was not available at our center, so we had to transfer him to that. And that was and then there was a patient, there are two other patients who needed uh, uh, higher care, so we had transferred them from our center to the tertiary hospital. And there was a patient with CA lung who had a recurrent UTI, so whether to, and it was a progressive disease, so we had to take two decisions in him, of course with the medical oncology team, hand in hand with their decision. So we had to withhold the oral chemotherapy that he was getting, since it would not benefit him further, and we had to also treat his UTI with IV antibiotics. So this is also a part of LST, the treatment with IV antibiotics and with. So then there was another patient whom we had considered starting her on oral chemotherapy, just for symptom control. That was again a case of CA lung with bone mets. And then there was a patient a patient of stroke who was a poor GCS3 right from the time of admission to our center, and it was a poor prognosis. But just to the son and the daughter of the patient staying with the patient were not really willing to let go. So though after immense counseling and be making them prepared for the thing that the patient will eventually pass away, we had to, on their consideration and I could say emotional grounds, maybe for them, and we had to just attempt a CPR at once. And the second time, uh, of course, the patient was revived, and but then eventually the patient succumbed. So the conclusion is that discussions in withholding and withdrawing LST is a multidisciplinary approach, and it involves a lot of decision making from, of course, from the legal part of our the ethics, lots of legal and ethical implications into it, and then as it involves the patient as well as the families, and of course it is a difficult situation, and it does differ from sometimes within each member of the multidisciplinary team, and as well as the patient and maybe the surrogate, and so it is a
Sorry to
something that
interrupt,
is.
Dr. Khan.
Yes,
Uh,
ma'am.
the 3 minutes are over for the presentation.
Yes, so
Can we
yes.
start with the question and answer, please?
Yes.
Please, ma'am.
Hanife, do you want to go first? This is Rajam.
Hi. Well, I am interested to know what you guys did about the quality of life of these patients. How did you monitor? How did you observe quality of life?
The quality of life of the patient. So I would like to tell the 9 patients, all of them were inpatients. I'm not just a few inpatients over here. The inpatient in the inpatient department. So we ensured. So they were on their medicines, and they received. They had. We have a counseling over here, and they were able to do their whatever maximum daily activities that they were able to do over here. Some of them did get discharged, and they are at home now, and they are continuing with, we we are in constant touch with all our patients even after discharge, and we ensure all sorts of support, of course, considering all the 4 dimensions of palliative care, that is social and psychological, and so we ensured the best quality of life for the patient, and as well as maximum support to the family as well, by various methods, ma'am, helping in all 4 dimensions.
Okay. Thank you.
So, Dr. Khan, my question to you is, you are talking of life-sustaining treatments to patients admitted in Sukoon Nilaya.
Yes.
Is it too late to start the conversations?
Ma'am, not too late to start the conversation, but
patient is already in Sukoon Nilaya. What do you mean? From what I understand about Sukoon Nilaya is really it's a hospice, right?
Ma'am, a palliative care center.
Yeah, so I know Leena well, and I know Dr. Mary Ann Mukhadan.
Yes, ma'am.
My question to you is, okay, let me flip it the other way around.
Yeah.
When should you start having these conversations? I feel after admitting to Sukoon Nilaya, it's too late. So you and me, both of us need to do efforts differently. So what do you understand about when to do conversations?
Oh, ma'am, so I believe, if we are talking about that, so ma'am, at the time of diagnosis, ma'am, that is what we prefer.
Yeah, but that's not going to happen in this country
so
soon.
Yes, ma'am. So that is something that we have to
next
really work on with the other specialities as well, ma'am. So that is what we are focusing on. So because the concept of palliative care, ma'am, even I am not a palliative care resident, but I am, since I have been into this, I have realized this thing too, ma'am, that wherever you go, even while our networking visits and all, people are much more into, cancer palliative care, and for the other conditions, they are not even aware that something like that, is really. So that is what we are focusing on, ma'am. And this has been, of course, it would have been much better if the patient at the time of diagnosis is, That is what we.
That
we
is too
want.
realistic, and it doesn't even happen in the West. So
Yes,
ideally
ma'am. Yes,
speaking,
ma'am. Definitely. Because
have you read the document of the from Manipal, the blue maple document?
no, ma'am. I
Read that document. That will give you criteria
the blue
for
maple. Yes.
referral to palliative care in every chronic condition, and
Yes.
the gold standard framework, which is also a brilliant 2-page article which tells you when to refer in hepatitis, dementia, COPD, cardiac, Parkinson's, motor neuron. So this is what we need to communicate to our colleagues. And the
yes.
second most important thing which I got out of your poster, when you
Yes.
said that the stroke patient's relatives wanted a CPR, where
Yes.
do you think we as doctors have failed when, despite communication, families are expecting CPRs to keep their loved ones alive forever?
Yes, ma'am. So,
what is the introspection thought from your team?
ma'am, the same thing, ma'am. Okay, to be very honest, ma'am, the patient had come from a municipal hospital, and
we are all trained in municipal hospitals.
Yes, ma'am. Yes, ma'am. I agree that, and
I think the best medicine happens in a municipal hospital.
Definitely, and the best residents come out from there, ma'am.
Example,
So,
I mean, I don't mind talking that about myself.
Ma'am, the workload, ma'am, is a lot. I believe that is the only thing that I believe would have led to that. The relatives were not so well
No,
aware
I don't
of
want you to pass the buck to the municipal hospital. What is your introspection?
Okay, so I was only there at the time of admission, and from day one, looking at the patient and the condition of the patient, it was, ma'am, she was GCS 3 right from the beginning.
Fine.
So from day one, me and our counselors as well as our team had been.
No, I want only one point. Where do you think? Okay, now that you said you were at the receiving end, where do you think your training should focus on?
Ma'am,
one word. We have a very wise and intelligent lady here with us who has seen a lot of palliative care. And there's just one thing that I feel, if you hit it on that, you know what your shortcomings are. See, nobody's perfect. And it's not, I'm not trying to find faults or anything with you. But
Definitely.
What is the thing? Because I know my shortcomings. So I'm trying to get that out of you.
I could say educating the patient about
communication.
Communication, exactly. Yes, ma'am.
Right? Palliative care is narrative medicine.
All about,
you need to know how, when, what. You say your topic is when, what, where, na? Communication is also when, how, where. Hanife, you want to say something?
Yes, I want to say something because Dr. Khan, when you are giving this kind of a presentation and this kind of a talk, which is really commendable that it has started, at least to make all of us more aware, I would like to hear more about the word goals of care. You see, because goals of care at one point might have included the patient when he or she was more alert and oriented, and the communication goes with the goals of care. You see, so then there comes the most important aspect, which includes the nursing team as well, which is advocacy.
Yes, ma'am. Yes, ma'am.
And you need to include goals of care and advocacy for these patients in order for these studies to be more sustainable and more productive.
Yes.
Otherwise, it's a great start. At least we are waking up to the need, but we need the goals of care and how are we advocating for this patient.
Yes, ma'am. So, yeah, we do have a presentation on that, ma'am. A nursing present that will be tomorrow probably. So our team.
I will listen to that. I will listen to that.
Good on you. Thank you for this.
Thank you so
we can
much,
move
ma'am.
on to the next. Thanks, Hanife.
Thank you.
Thank you.
Priyasi, can we have the next?
Yes, ma'am.
Thank you.
Suhana Sulfikar.
Yes, ma'am.
Yes,
Can
please
you
start.
share the screen? Okay. Can I start?
Yes, please start.
Okay, thank you. Good afternoon, everyone. I'm Dr. Suhana Sulfikar. I'm doing residency at the Department of Palliative Medicine, AIIMS, New Delhi. I'll be presenting a study on the evaluation of preferred place of death among terminally ill cancer patients in a tertiary care hospital in India. Place of death is considered to be an important aspect of end-of-life care. An individual achieving their preferred place of death is usually considered to be a good quality marker of good end of life. We evaluated the preferred place of death among terminally ill cancer patients, the reasons pertaining to their preferred place of death, and the congruence between patient and the family primary caregiver regarding the preferred place of death. We did a questionnaire-based cross-sectional observational study at a palliative care unit in AIIMS, New Delhi, and the study duration was 2 months. We found out that out of 81 patients who participated, only 34 patients had a preferred place of death. 62% chose home as a preferred place of death, and their reasons were they want peaceful death without any intensive procedure. They want care only by their loved ones. They are fed up with long hospital stays, and they do not want to financially overburden their family. A few told they want to spend the remaining time with the family in familiar surroundings. They want to spend last moments near loved ones, and they think unknown hospital staffs won't care for them. 32% chose palliative care ward and 6% chose nursing home as a preferred place of death. And the reasons were they want a pain-free death, they fear lack of accessibility to medical care in case there is an emergency, and they do not want to depend on family for self-care. A few told that there will not be anyone at home to take care of them, and seeing their death will be painful for family, and they do not want to waste the time of their loved ones taking care of them. Only 8 patients has discussed their preferred place of death with the primary caregiver. And among 4 patients, there were congruence between the patient and the family primary caregiver. We concluded that 2/3 of the patients chose home as a preferred place of death. However, there are discrepancies regarding the preferred place of death between the patient and the family caregiver. Therefore, the treating physician should address this issue and encourage effective communication regarding the place of death between the patient and the family primary caregiver. Okay. That's
Excellent.
all. Thank you.
Excellent. Hanife, please start.
Okay. Hello. I would like to know.
Good afternoon.
Hi. What was the further steps taken for the discrepancies? I'm curious about this. You see, there's a lot of discrepancy between what the patient's caregivers and the families wanted and what the patients wanted. So what did you guys do about that?
In our due course of study, we found out that the topic of death was not discussed because the patient is not willing. And initially, we took a sample of 81, and in that 81, only 34 had a preferred place of death, and the rest were thinking that talking about death is not important to them. Like that, situations were happening, and we found out that death was a topic that they don't discuss at homes. In our full study, only 8 patients has discussed regarding death. Not even the preferred place regarding that death, they don't discuss the death. And when we asked about the reasons, they were telling that I will become sad if I talk about death. And the caregiver was also telling the same, because this is not a topic to be dealt with, because like my son or my daughter or my father will become more sad if they talk about death. So then during our course of study, we found out that this is a topic which needs discussion, and we encourage patients and the caregiver to discuss about this topic. They should sit down and discuss regarding like what they want. Actually, a good death is one which is free from any avoidable distress and suffering of both the patient and the family caregiver, and which is in general accord to the patient and the family. So both their decisions should be same. Should be in the same lines to ensure that they're having a good death. So we encourage them to have communications on this topic, which was very unwilling, because many patients and the caregivers, mainly from the caregivers, they were like unwilling to discuss the topic of death because they thought their loved ones will be more sad discussing about death. I think So we encourage them, like this should be a issue that we should be dealt with. We should have open discussions about
So,
that.
Dr. Suhana, these patients you interviewed were in the outpatient or the ones admitted in AIMS palliative care?
No, ma'am. We interviewed those patients because we almost a 12-point questionnaire were there. So we interviewed those patients which were admitted in our palliative care ward. Even at that point of time,
age range, you have put an age range. I cannot see it.
Yes, ma'am. The median age range was 51.23. That more than 18 years, we took all the patients who were more than 18 years and not having who were not amenable to any therapy. Because
any relationship with A, stage of cancer, and B, socioeconomic status to not consider home as place of death?
Yes, ma'am. We found out in our due course of study that people who are educated and having a high socioeconomic class, like those patients would actually tell that I don't want to spend my last days of life at a hospital. I want to go home. But those patients who were uneducated, illiterate, they preferred home. They preferred a hospital as their primary place of death because the concerns were that many people won't be there at home to look after them. Or in case any emergency arises, I won't be able to come to hospital. Nobody would be there. That type of situation happened when it comes to the low socioeconomic class. That is one finding which we got from the study.
And you're saying only 8 patients talked about death with their caregivers, and had only 34 patients had thought about where to die, correct?
Yes, ma'am. And the rest were telling they don't have a preferred place of death.
So what do you think we can do to improve this?
Ma'am, actually, we should like introduce the concept that death is not something we should be scared or feared of. And like a lot can be done to improve the quality of life in case of like end of life care and other things. A lot can be done for that. Initially, like a talk should be there between the patient and the caregiver regarding like what they want. Like
how can you do it in the crowded AIMS OPD?
Ma'am, we have only done that with the who were
Inpatient.
admitted to our inpatients ward.
Sure.
Actually, we did the like 2-3 patients we started in the OPD, but like patients were not able to. We were not able to communicate that much with the patient because of the crowd. Only limited time we have now, because death is a very sensitive issue that many caregivers were not ready to talk about this topic. They were not willing to like participate in the study because they thought their loved ones would be sad talking about death. So we limited it to just inpatients after that.
Sure. Hanife, you want to say something?
Dr. Swana, I have a little thinking
yes, ma'am.
About the conclusion, the last part.
Yes, ma'am.
Treating physicians should discuss more, or I don't have it in front of me, but discuss about the preferred place of death or something like that. Would you, when considering AIMS Delhi, the overload, the OPDs, the inpatient, the time of the residents and the doctors being so limited, I would like to see, especially coming from AIMS Delhi Palliative Care, that not only treating physician, but the nurses as well.
Yes, ma'am. Obviously, we have.
Obviously, I mean, I would like this to be more in black and white, because they are the ones who make this more possible, given the limitations of time and responsibilities of all the residents and the doctors. And you're already used to me talking about all these things, but this is something that we truly have to consider, being AIMS Delhi Palliative Care, the back support, the backbone of palliative care nursing, really, that we would like to see, right?
Yes, ma'am. Seriously.
So what Hanife is trying to say, you can't forget, you cannot afford to forget the role of nursing in every aspect of palliative care, or for that matter, medicine, because I don't think we can do anything without them.
Yes, ma'am. Sorry, I forgot to mention that.
Don't worry about it, but next time, please don't forget.
Yes.
Just put it in your
Okay.
mind and in your practice. That's all. Thank
Okay.
you. Very
Thank you,
nice.
ma'am.
Bye.
Bye.
Dr. Shweta,
Yes, hi.
please start.
Yeah, I'll just share my screen.
Yes, ma'am.
Can you just introduce yourself also, Dr.
Yes.
Shweta? Thanks.
Yes, hi everyone, and thank you so much for this opportunity. I am Dr. Shweta Chawak. I have just recently graduated and completed my PhD in psycho-oncology. So the topic of today's study is part of my PhD work, where we looked at developing and testing the feasibility of a question prompt list. I hope the screen is visible to all.
Yes.
Yes, thank you so much. So, so today I'll be, so this is part of my PhD work. So I'll be talking about a pilot study that I conducted to test the feasibility of a QPL. The QPL was developed for the patients and caregivers separately. And these are the patients who were undergoing radiation therapy, and they were there for their first consultation. So we carried out a non-randomized controlled trial, and here we had two groups: the intervention group, where the QPL was introduced, and the control group, where no QPL was given. This study was conducted in 3 phases. The first one was pre-consultation, during consultation, and a follow-up. In the pre-consultation, both the intervention group and the control group were given a questionnaire on state anxiety. And further, the researcher carried out carried out the observation during the first consultation, and the first consultation was audio recorded. Further, in the follow-up group, where we carried out, we conducted questionnaires on consultation satisfaction and state anxiety. We also obtained qualitative feedback on the QPL and their experience of the consultation. Further, considering, sorry, I hope the result section is visible. Considering I have limited time, I'll be focusing on 2 main results that we saw. The first one is that people who used the QPL were likely to address more questions. They were also likely to ask more prognosis-related questions. And also we saw that the participants had, like in the intervention group, had shorter consultation time as compared to control group. Further, we also saw that the researcher who acted as a patient navigator, where majority of the questions were addressed to the researcher, and we realized that the QPL was not only addressed to the medical staff or the physicians, but they were also addressing it to the researcher. They wanted to know more information. Finally, some of the implications of the study is also, sorry, one more point that I would like to highlight is we also looked at various issues that we came across while conducting the pilot study, and we provided some solutions for the same. And we also, we believe that this needs to be considered when a large scale intervention needs to be carried out. So one of the main implications of the study is that there is a need for a large scale intervention. And secondly, there is a need to include a physician and or the nurse as a physician or a nurse-led QPL that will help in endorsing the QPL for the patients and encourage the patients to be more involved. This will not only help the patients to be more involved, but also help them address the questions during the consultation. Finally, one last thing we also believe is that there is a need for a patient navigator who can help the patients and the caregivers to address their concerns as they go about in their consultation process. Thank you so much.
Dr. Shweta, very nice.
Thank you so much.
My question, this is very good work. This is very useful work. And what I would like to know, how are you going to implement this?
Okay. So in the beginning, we believe that there is a need for QPL in every section. So we are, so this is one of the initial studies that we have carried out. So further, we are planning to carry out a large scale interventions where we would like to translate this QPL into different languages. So for this current study, we had developed it in Hindi, Marathi, and English, but we are looking forward to translate it into different languages and introduce it to different hospitals. And from there, we are hoping to keep it rolling and continue the research and encourage the hospitals to use this particular intervention.
in their multidisciplinary team, we hope.
Yes, yes.
Yes, very nice. Thank you. Thank you very much.
How long does it take to do QPL per patient?
Okay, so QPL is a process. So basically, QPL consists of a list of questions. So during this study, we carried out during the before the consultation, these participants had like half an hour to 15 minutes in with them. So they were given the chance to read up on the QPL. They could reflect on it, and they were asked to address 3 questions. So in talking about in a times way, it takes about 15 to 20 minutes, but overall this can be used in every consultation. The participant can go back home, they can read up on it, and also address the questions as they go about with their treatment process. So there are some questions that they want to address in the first consultation. There would be some that may come up later. So every consultation they have to think of 3 main questions that they want to talk to the doctors.
Now you said one of the things that QPL includes is prognosis.
Yes.
So did you follow up these patients later to see what happened to them?
So we were unable to follow up because it was part of my PhD work, and I had time constraints. So I could only carry out a 15 days post consultation follow-up, but beyond that, I was unable to carry out the follow-up sessions.
Okay, fine. And do you work in India now or in Australia?
No, in India itself.
You're in India now.
Yes.
Okay, fine. And you work in Hyderabad?
Yes, so I'm part of the team in IIT Hyderabad under Dr. Mahati Chittam. So Dr. Haryana Dhillon and Professor Phyllis Bhutto were one of the people who helped us to develop these QPL, because it was founded by Phyllis Bhutto, and we adopted the concept and developed it for the Indian patients. So all the questions were developed basically for the patients in India, and people who like if you are interested, I'll be presenting how I developed the QPL tomorrow in one of the presentations.
Okay. And are you planning to use it? Are you using it now in India?
Right now, we are not using it in any specific centers, but we are looking forward to translate it in more languages and carry out a large-scale intervention.
Sure. What time is your talk tomorrow?
It is around the same time, 3:15.
And which hall?
I'm not sure. I'll have to check on that.
Okay, fine. But before this session ends, just put it on the chat box.
Okay, I'll do that.
Yeah.
Thank you so much.
Good luck. Hanife, you want to add something?
Oh, this was very interesting. Thank you. Best of luck. Let's hope it works very nicely.
Thank you. Thank you so much.
Good luck. Dr. Pooja.
Very good afternoon, ma'am.
Excuse
Good
me.
afternoon.
Excuse me. Sorry to interrupt.
Yeah.
We are running 45 minutes late. So I request the judges and the participants please to stick to the time. Thank
Sure.
you.
We will try.
Yeah, thank you.
Yes, Pooja. They already took
Preeti,
1 minute
can I
of
have
your
my
time.
poster? Preeti, can I have my poster, please?
Yes, ma'am, please.
I will start the introduction. Meanwhile, very good afternoon, judges and dear participants. I am Dr. Pooja Mongia, working in Bhagwan Mahavir Cancer Hospital, the IAPCON 2022 organizing team, and I'm working as an assistant consultant here. The topic of my poster is collusion in palliative care setting in a tertiary care cancer hospital. Collusion is an act of love and protection for a close relative from knowing the bad news with regard to diagnosis and prognosis of her illness, which can lead to poor doctor-patient relationship, psychological distress for patient as well as caregivers, and a constant patient anxiety regarding symptom control. In such a scenario, we aimed to study collusion in our oncology palliative care OPD and to analyze the reasons behind it and to explore the needs and expectations of these unaware patients as well as caregivers, for which we prepared a semi-structured questionnaire and included patients visiting the oncology palliative care OPD. We did not include patients who were younger, less than 18 years of age, mentally disturbed, and whose caregivers did not allow the patients to be interviewed. We found out that in our hospital setting, 34% collusion was present. That is 34.7% patients did not know about the disease. Out of this, 32% patients did not know about the stage of the disease. And it was associated significantly with increasing age and with less literacy status. And majority of the patients' caregivers thought that who did not tell the patients about the disease thought that they will not be able to take the pain and bear the emotional distress of the disease. And out of the patients, 34% of the patients in which collusion was present, only one patient, only 3.6% of the population of the caregivers allowed the palliative care OPD to disclose and break the news to the patient. We concluded that collusion is high, irrespective of good literacy status, even in a private cancer hospital, and the numbers will be higher in unlettered patients seeking treatment in multi-speciality hospitals. Patients' relatives actually rely on a recovery plot which focuses on treatment and recovery issues and not addressing prognosis or any long-term disability. This acts as a coping strategy for the relatives to deal with their psychological distress. And the relatives and the caregivers create an experimental aura. For example, we had a patient who was undergoing multiple chemotherapies to maintain the facade and to protect the patient from the disease and the emotional distress. Also, in the family autonomy model that exists in India, in our hospital settings, this burden of non-disclosure for the healthcare workers leads to a very stressful situation for managing patients and their work. So we concluded, and the clinical implication that we could relate to was that every family is different and their acceptance level of the disease is different. The response to bad news is different. So we cannot actually generalize the thing. Every family handles the consequences of full disclosure differently. And we as healthcare professionals need to listen to the family and understand exactly what they need. And also, a good communication strategy needs to be developed, not only for the patient and the caregivers, but also for the healthcare professionals, maybe with the assistance of mental health care professionals and psychological interventions. That's all from my side. Thank you.
Great. Hanife?
Very nice. Very nice. But
Thank you, ma'am.
how do you you know,
I'm not able to see your image. Is it my mistake? Okay, sorry.
Okay, so you are saying exploration of the needs and expectations of these unaware patients. How do you do that?
Ma'am, can you repeat? I was not able to see your screen.
For the aims and the objectives, there is a point that says exploration of the needs and expectations of these unaware patients.
Correct. So actually,
how do you go about that?
What do I do about it? So I mean to say that in the OPD, when we have patients who we need to first analyze, which we actually interviewed the patients and the caregivers separately. So initially we interviewed the caregivers and we got to know that actually which caregivers know about the prognosis of the patient and if they know whether they've actually told the patient or not. When we get an idea of whether the patient knows about it and also if they don't know and whether the caregiver wants us to break the news or he doesn't want us to break the news, the questions to the patient automatically decreases. We will not ask the patient that, do you want to know about the stage of the disease? Do you know about the stage of the disease or not? Also, apart from the questions of the explorations and the needs was, we separately asked the caregivers and the patients about their frequency visits, their emotional and their issues that they are facing. So we could actually relate to that what are they, whether they need any intervention, whether they need any help from mental health care help, or also whether they are actually expecting our department to break the news to the patient, whether they are having the problem to do that and whether they need our help to do that. So in such a questionnaire sort of a setting, we analyzed and we recorded that what they actually want us, whether they don't want us to do anything, just give them medical help, or they actually need us to help with them to disclose or disclose the bad news, or they don't want us to disclose the bad news. So in every patient and the caregivers, the questions were asked, and that's how the recording and the questionnaire and answers were prepared.
Pooja, I don't think we have much time, but I have one question. From what you're saying,
ma'am.
Is it the onus of caregivers to give us permission to talk to patients?
Definitely.
Is it? Or is it
No,
the
I
basic
mean to
right
say-
of every individual to be aware of his diagnosis? What is medical ethics?
So actually in our setting we have the family autonomy model that we are
I
that we
appreciate
undertake in
that,
India,
but
not in
no. I don't think you can generalize saying in India. I know
That's
it
absolutely
is the
right.
problem of the subcontinent about collusion. In the
I
West,
understand.
Yes.
Yes.
You will be in jail for talking to the family and not talking to the patient. So,
patient, yes, ma'am.
So there is no permission required. It is clearly two things. One is
Okay.
education in the undergraduation about communication. So in India, the curriculum has 0 hours in communication. So by the time you finish your MD, you still don't know how to talk to patients. You might know 50 causes of headache and 200 causes of chest pain, but you still don't know how to talk to patients, including me.
Ma'am,
I also came like that. The second thing is the zero lack of medical ethics. Medical ethics says the first pillar is autonomy. We don't need. So it is how you talk to your patients. And when you talk to your patients, that gives you the liberty to ask your patients. To route it via the relatives is not necessary. Am I right, Hanife?
You are right.
And the other important thing is, yes, you cannot obviously brush the relatives the wrong way. But the way to solve collusion is only to explore why they don't want to
Dr.
say
Rajam,
what are the
sorry,
issues.
Dr. Rajam, sorry, I have to interrupt. We're running late in this session.
I know. Anjum,
Yeah.
yes, we'll definitely tell. Go ahead. So that is what I'm trying. I want to change this mindset. It cannot be family run.
Absolutely, ma'am.
Yeah, so that's an important point. We have to improve ourselves in communication. You and me. That is important.
Absolutely.
Yeah. Next,
Right, ma'am.
please.
Right, ma'am. Thank you, ma'am. Thank you, ma'am. Have a great day.
You too. Good luck.
Thank you, ma'am.
Ruparna Khurana.
Do we have Ruparna Khurana?
Cannot see her. Next.
Dr. Chaudhary. Mustafa Kamal Chaudhary.
What about Neelima Sharad?
Ma'am, she has been shifted to the last session because of her quiz.
Okay.
Leon
Mustafa.
Yang. Can we go with that?
Yeah, of course. Do not waste time. We're already 45 minutes late.
I cannot see Mr.
There you go.
Yang.
Next is the last.
Sandhya Sham Shankar Rajhans.
Hello.
Yes,
Yes.
Dr. Khan.
Yes, ma'am. Can they share the thing I'm presenting on behalf of Sandhya?
Okay.
Yes, ma'am. Thank you. P18.
So, Hanife, till they set it up, people who have not presented have just written as no show on the thing. Is that okay?
I think so. We try. Ah.
Dr. Khan?
Yes, ma'am. So can I start?
Yes, please start.
Okay, so this poster is just our experience on starting the center amidst the pandemic. So again, I'm presenting on behalf of Ms. Sandhya Rajhans, our manager at Sukoon Nilay Palliative Care Center. So, okay, so as we all know how COVID-19, how the pandemic has just put everything to a hold. So just setting up this entire non-cancer palliative care center, mainly focusing on non-cancer palliative care, was started uh, from January 2021. I mean, so just the challenges that were faced, and we just want to talk about that. So the reasons for setting up the center in the city was mainly the very uh, actually there are no similar centers having inpatients and in our city. So mainly to start a non-cancer palliative care center and to focus on supportive care facilities, and especially for these palliative care patients in neurological, respiratory, cardio, and nephro and other conditions. So the recognizing the hurdles in setting up the center during the COVID pandemic. So this is just a few questions asked to our the members or the people who are involved in setting up this center. So their inputs mainly. So the hurdles that we faced were in form of construction, that is getting the labor in that pandemic, and getting the material and all that, and the approvals and all, and then the logistics in transport and all those um, movement of the laborers. And then there was a shortage of laborers as well that we faced, because many of them had moved to their native places. And then the meetings especially. So of course these online platforms have helped a lot since the pandemic, ever since the pandemic has set in. So that was a blessing that our video meetings were going on with for
एक चीज
everything. And
बताओ,
then
इसके अंदर जैसे ये है, मुझे ये डालने के 30 seconds left.
Somebody please mute.
and the recruitment of staff and the especially was a very challenging uh, uh, was a challenge that to find out the medical team, the administrative team, the nurses. So that was also the interviews and all were mainly conducted via Zoom meetings and all. And of course ensuring the safety of the people who are working around, the laborers, the people, even when we were visiting and all that, and following all the protocols that were just keeping on, that kept on changing because of the different guidelines every few days. And
Dr. Khan,
yeah.
time is over for the presentation. Can we start with the question and answer?
Yes, definitely.
Ma'am, please go ahead.
Hanife, you can start.
Well, Dr. Khan, all I want to know is that you built this great facility.
Yes, ma'am.
And it's there, and I'm sure you helped a lot of people. Now, what's to follow up?
We are doing great, ma'am. I mean, so far we have had more than 300 patients, that including both OPD, IPD, and teleconsultations. Just we are facing a lot of issues due to net, because we are not because of the networking, and especially the protocols that we need to follow to maintain the safety in this center and of the patients and all, because we are strictly following a no COVID policy over here. So when we and when we get inpatients, we are testing them for COVID, and only if negative we admit them, as well as of course, ma'am, as in palliative care, it is always better to get a relative as well, who the one an informal caregiver who's usually there with the patient at all times. So we try to get them as well, just to educate, and as well as to counsel them, as well as provide support to them, and of course to teach them how to take care of the patients, sort of. So many people are sometimes not ready, for that same reason, because they have their schedules, they have their work, and they have to keep coming and going. But that thing has still been a challenge that we are facing. And so far we are going quite well, and of course partners around, everyone, they have been very, very, very helpful, and I just hope that this thing just goes on and picks up very well. So
hopefully real person home care someday soon.
yes,
Yeah.
ma'am. Yes, ma'am.
Yeah.
Definitely.
Thank you very much.
Thank you.
I have only one question, and that is, do you have end of life in Sukoon Nilaya?
Yes, ma'am. Yes, ma'am.
We
have
can admit
recently.
patients?
Yes, ma'am. Yes, ma'am.
Okay.
Recently we have started, ma'am. I think it's been a month, a little bit more than a month, ma'am.
Okay, fine. Thank you.
Thank you, ma'am.
Thank you.
Thank you.
I think that's the end. Now there is nobody else.
No, we're done.
Yeah.
Thank you, Priyasi.
Yeah. So what are we doing, Priyasi? We are sending the stuff back to you by email.
Yes, ma'am.
Okay,
Thank you so much, Sister Hanife and Raju ma'am. Thank you so much.
Thank you.
So,
We finished on time, Hanife, thanks to the 3 no-shows.
Thank you.
Well
Yes,
done.
ma'am.
Well done to you.
Thank you, Dr. Raju.
Okay. Good luck to all of you. Nice seeing the bunch of young people. Hi,
Thank you so
Sridevi.
much, ma'am. Okay, so now I would like to invite our next two judges, Dr. Sri Devi and Dr. Chandni Sinha. Dr. Sri Devi is the head of the Department of Education and Clinical Training at Pelham, India. Also the honorary tutor at School of Medicine, Cardiff University, UK. Welcome, ma'am. Dr. Chandni Sinha is the additional professor, Department of Anesthesia in AIIMS, Patna. Welcome, ma'am.
Hi, Dr. Shantanu.
Good afternoon, ma'am.
So, Priyasi, you will be keeping the timer for 3 minutes, right?
Yes, ma'am.
Okay.
Abhinav Mishra. Can we have Abhinav Mishra, please? Hello. Is there anyone from his team? Okay. Shreya Rena. Dr. Shreya Rena.
I can see her name in the icon.
Anyone from Dr. Shreya Rena's team?
Hello, hello. Am I audible?
Yes, yes, you are, ma'am.
Okay. Good evening.
Good
So I
evening,
have
ma'am.
to share my screen.
Yes, ma'am, you have to share your screen.
Okay. So I hope I'm audible. My internet connection is a little
Yes, ma'am, you are audible. Please start.
Okay. Hello, good evening, everyone. I'm Dr. Shreya, working as a pediatric palliative care physician in CanKids, Delhi. And I would like to start by thanking everyone here to be present for my very first poster presentation. Thank you all. So under the background, I'd like to mention that in the study, we have described the role of our pediatric palliative care center and the expansion of its services in Delhi NCR and North India to support children suffering from cancer and their families during lockdown. So this was an attempt to ensure access to cancer treatment. Our major interventions were providing medical support to the patients, which includes drug support, and delivery to the patients, drug delivery to the patients who could not come to our care center. So we delivered the medications to their homes. And our doctors and nurses provided medical care to our patients constantly. All of our care centers ran 24/7. We helped in providing transportation to our patients so that they could continue going to their respective hospitals. And we also sent end-of-life patients back home to spend their last days with their families. So this also includes one Afghani patient who was sent by air to meet his mother during his last days. We increased our bed capacity in our palliative care center, and we inaugurated a new home away from home to accommodate families stranded in lockdown. We provided shared care for patients whose hospitals were converted into COVID care centers by shifting them to hospitals in Delhi to continue their cancer treatment. At our center, we ran an ambulatory clinic every day in which patients came on OPD basis for receiving antibiotic injections, and we also provided psychological support to families. So on the right side, under the results, you can see that I've mentioned the total bed capacity. So we increased our bed capacity from 32 to 50. This includes the bed capacity at our center, the palliative care center, and the home away from home. Then the number of patients supported with end-of-life care were 12. So this includes providing bereavement support, which includes providing conveyance to patients, then providing psychological counseling, and providing medical care to the patients. Then number of families that we supported under the shared care were 10. And the total number of families that we accommodated in all our care centers, the home away from home and our palliative care center during the lockdowns, was 901. Then you can see the number of the quantity of morphine that we had used for pain management during the lockdown. Then
Dr. Shreya, hello, can you hear me? The
hello, yes.
time is over for the presentation, ma'am.
Okay. So yeah, so I just like to conclude. And
Sorry, ma'am, we are over for this presentation, and now it's time for question and answer.
Okay, sure.
Thank you, Dr. Shreya. Dr. Shantini, would you like to start?
Please. Dr. Shreya, okay, what is the conclusion? What are the implications of this study? What do you want to convey?
Ma'am, actually, from this study, I would just like to convey that even though we are an NGO, but we are a national level NGO. So by coordinating with various healthcare facilities and various physicians working in palliative care, so we can all work together and manage to provide comprehensive and integrated palliative care service to all patients, even though we were in an emergency situation in dealing with the pandemic.
Right, commendable job. Ma'am.
Yeah, so Dr. Shreya, what was one most challenging part of this whole resetting when the pandemic came? What was the just one point?
I'd like to say that ensuring patients that even though this is a pandemic, so there is a lot of distress in patients already because of cancer. So when they know that they are dealing with pandemic along with cancer, so it is very difficult to console them, to make them understand that they will always be provided support, and no matter what, we will help them to whatever extent we can in managing both the situations.
And just one more question, what would be one thing that you would like to improve in such a situation next time?
One thing that I would like to improve would be, I think, better coordination would help in the various aspects of care that we provide our children. So, yeah.
Thank you, Dr. Shreya.
Thank you.
Yasi, can we move on to the next participant?
Yes, ma'am. Dr. Diptanshu Daga.
Yes, I'm present. Good
Yes, sir,
afternoon,
please
all.
start.
Is it visible? Is my
Yes.
screen visible?
Yes, sir.
Good afternoon, respected judges and participants. The COVID-19 pandemic changed the world economically, medically, and psychologically. Disappointment, stress, and irritability in isolation added to dental anxiety. We conducted this study at Pacific Dental College in Rajasthan to see was dental anxiety very much different from the previous COVID-19 pandemic, before the COVID-19 pandemic. And if so, we want to identify the anxiety and then change our treatment plan accordingly. Also with dental anxiety, another aspect was mask of anxiety, that is the fear of taking off your mask at a public place, which was significantly heightened when you were going for a dental examination. For this study, we used Dental Anxiety Scale Revised, or DASR. This is an established tool which has been used all over the world in several different languages to assess dental anxiety. This tool was digitized with the help of Google Forms. A QR code of that form has been given in the poster. Or the response of 566 willing individuals were recorded and divided into 4 subgroups according to their age. Now, in this chart, you can see that we have written about the questions and the individual responses to each of the options to that questions. I will be going straight to the results. We conducted this study to see the change in anxiety levels so that we could alter our treatment plan. In DSR, if you have a score of less than 9, it indicates mild anxiety. 9 to 12 indicates moderate anxiety. 13 to 14 indicates high anxiety. 15 to 20, a severe anxiety. The mean score, according to our study, was 9 on this DSR scale with a standard deviation of 3.66. We also calculated the mean anxiety for very anxious patients, and it was found to be 15.8. Thus, we can say that for the general population, it was on mild anxiety, bordering on the moderate. The most anxious age group was found to be 31 to 45, and women were more anxious than men. The present study indicated that after the pandemic in the country, the levels of anxiety were mildly affected, but an eye on anxious patients will help in the total outcome and quality of life. Simple counseling, listening to the patient's concerns were done to alleviate their distress. They were given information and practical advice. Behavior modification techniques such as a questionnaire were used to alleviate their stress. Thus, we seek to do more than merely cure a physical illness. Thank you.
Thank you, Dr. Diptanshu. I think you finished well on time. Dr. Chandni?
No, that's okay, ma'am. You go ahead.
Okay.
Alas.
So I have a question. So this dental anxiety scale is a standardized tool for measuring anxiety of patients coming to dental practice, right?
Yes, ma'am.
So I mean, even without COVID pandemic, I think every one of us will be very anxious to go to a
Yes, ma'am.
dentist.
Actually,
So,
dental anxiety
yeah.
is more specific and more distressing than general anxiety. So that is why we wanted to know whether the pandemic had just added on to it, thus making treatment even more difficult than it already was. Because if patients are not treated, as I have listed, there are multiple problems like avoidance of treatment, poor dentist-patient relationship leading to delay in treatments, which can lead to multiple complications.
Yes, very true. I'm trying to understand how it is specifically related to COVID, because even otherwise, people are very anxious. Like if you do the dental anxiety scale now,
Yes, ma'am.
right now in this group, we'll
Yes,
get a
ma'am.
good number of score. So
Yes, ma'am.
it's not very clear how, I mean, it is specifically related to COVID. I
Ma'am, it
understand there
is,
is a increased level of anxiety, but
yes,
in
ma'am.
this particular study design, it's not very clear.
Ma'am, it is not directly related to COVID. It is the measurement of anxiety before and after the pandemic. So, so that we can change our approach, give more importance to counseling of the patient, along with taking away their fear, so that they come for their appointments and they are not afraid to get dental treatment done after the pandemic.
Thank you. Like that's a very important area also, because as I said, everyone is anxious about this
Yes, ma'am.
procedure. So it's a very, very important area. Thank you.
Yes.
So did you compare your results with any pre-COVID anxiety, other studies which focus
Yes,
on
ma'am.
dental anxiety?
Yes, ma'am.
Okay.
This scale DASR, this is the revised scale. The original DAS, that is the dental anxiety scale, has been in existence since 1969. This is the revised scale that was used from 94. So the scores of previous, before the pandemic, multiple articles are there where the score has been listed as less than 9. So after we did this study, we saw that it was at the border, that is mild to moderate, if we consider the standard deviation. And severe anxiety score, that was 15.8, was also mildly higher than the scores that were reported before the pandemic.
Also, your results show that women have more anxiety scores. So
Yes,
could
ma'am.
you just justify the findings, or did you try to find out the reasons why you found such a result?
Ma'am, this was directly from the study that was done. A direct reason or a particular reason cannot be isolated why women were more anxious, or why the age group of 31 to 45 had the most number of anxious patients rather than the other. But this was seen that women and that age group was most anxious.
Thank you. But as a follow-up, we have only 10 seconds. But I
Yes,
think
ma'am.
it's important to reflect on the findings. Like, you know that women are higher chances of anxiety. Then why it is very important when you
Sorry to interrupt, ma'am,
Yeah,
but the
that-
time is over.
Yeah.
Okay. So the
Thank you, ma'am.
next
Thank you, ma'am.
participant, please, Dr. Himanshu.
Hello. Hello.
Yes,
hear
Dr.
me?
Himanshu. Yes, we can hear you. Please start.
Just a second. I need to share my screen. Okay, is it visible? Hello.
No.
No, your screen is not visible, Dr. Himanshu.
Now?
Yes, it is visible now. Please start.
Okay, thank you. The topic, myself, Dr. Himanshu Prince. I'm assistant professor in a super specialty cancer institute, which is emerging institute in Lucknow in Uttar Pradesh, India. So my topic is awareness and perception of the palliative care at a tertiary care oncological center in India. It's a random cross-sectional observational study. So we know, I need not to tell that how much people are requiring palliative care nowadays. It's in millions. It's data from WHO and world data. So the current healthcare education focuses mostly on the cure, but palliative care somewhere it's lacking and compromised. So the aim of this study was to appraise the level of awareness regarding different aspects of palliative medicine among doctors who are working in this emerging institute. So we took a 22-point questionnaire via Google form. Total 75 doctors are working here. Out of them, 25 are faculties, rest are residents. So when I saw the results, so it says that in your clinical practice, when do you incorporate palliative care in your patients? I think it is the most common and basic question which a person who is practicing in a cancer institute should know. So you can see that 37% says only for the advanced cases, and 13.13% they say that they do not have an idea regarding. So that means at an oncological center, specialty center, 50% people don't know when to incorporate palliative care. Next, when you came to know about palliative care, so as I am talking awareness regarding this, so it is 51% says during graduation, other 50% after graduation. So even if we are having courses like MD palliative medicine, if 50% of people they are not aware at the level of graduation, then I don't know how they are going to fill or take, or how do they show an interest in selecting or opting for the MD palliative medicine while they're counseling.
It is a real-time issue, I think, and it should be there. And do you think that you are trained and oriented enough to deliver palliative care, terminal care to your patient? So 25, that means 46% people says no, and 42.6% people say partially. That means 88% people, they are not confident enough to deliver palliative care in a terminal care patient. Then next question was that what is your opinion about hospice? So 33% they don't never heard of it. What is the hospice care? And then have you ever been involved in the palliative care of your terminally ill patients? So 37% no, and 63% they are involved, but they don't know that how to go for it. And when the last question was that, do you feel that more and more people will be requiring palliative care in the coming days? So 96% people, sorry, doctors, they are saying that yes, the patients will be requiring palliative care in coming days, but 88% people, they are not confident enough to deliver the palliative care to their patients. So to conclude, the awareness regarding palliative care among doctors, even at a tertiary center.
Dr. Himanshu,
Yeah.
3 minutes for the presentation are over. We have to start with the question and answers. Ma'am, please start.
Thank you, Dr. Himanshu. This is a very interesting study. And I feel this is quite promising too, because the number seems to be much better than I think years back when we all did this kind of study. So that's a quite promising thing, because many of them are aware of, at least at the time of graduation, they have seen some terminal care happening. Yeah, but still we have a lot more to reach to get what we are aiming at. So one question, depending on this findings, what do you propose to do? What is the next step?
Okay, so next step, ma'am, I talked with my management that when the Department of Palliative Care was not here, we have started just 2 months back. All other departments were running since 4 years. So I made a proposal to the management and higher authorities that we'll start the department, and after 6 months we'll give an audit that how many patients who are turning up at this center are requiring palliative care, and what all requirement we have to establish, and what all support we have to get from management to establish and make aware of the people regarding this thing. And ma'am, it is a center, like it's in a Lucknow. We have a population of approximately 30 lakhs in this city. So it is a center which is it will be delivering it will be covering this eastern UP and the peripheries of Bihar. So I think awareness will be spread throughout.
Yeah, I think you have a fixed plan also, maybe to do I think you mean to say a survey than an audit. Yeah, but this is very good, because the moment you joined, like 2 months, you have some data around the awareness among the colleagues that you're going to work with, so you know where you're starting from.
Right.
Good. Thank you, Dr. Chandra.
Ma'am, same. I also wanted to know the measures you would be taking to increase the awareness. One small question is, you said you have around 50 residents. So these residents mean these are all MCH or DM candidates? Or
no, ma'am. The institute is in establishment phase, so we don't have MCH or DM courses here. We have non-academic junior residents and senior residents department wise. Like my base is anesthesia. There is no senior resident in anesthesia, and I mean, MD palliative medicine. It's quite difficult to get senior resident here. So these all are junior resident mostly, and few are senior residents.
And around how many cases do you, as in a month? How many cases do you have?
Ma'am, we are running only one OT, and we are.
No, I don't mean specifically anesthesia, but
okay. Overall. Overall, in a month we have almost 600 to 700 registrations of new cases, and including follow-up, the number goes up to 10,000.
Okay. That's quite a few for a new setup.
Yeah.
Anyways, congratulations, and please the next candidate.
Okay, Dr. Amit Jain. We have Dr. Amit Jain. Dr. Amit Jain. Srikant, Mr. Srikant.
Yes, I am there.
Yes, sir. Please start.
Okay, I'll share my screen. Good evening. Can you see the screen? Madam?
Yes, sir, we can see your screen, please.
Okay, ma'am. This cross-sectional study was done in a private medical college in Pondicherry. This study was done during the process of setting up a palliative care unit in this private medical college. Most of us know that non-communicable disease program by Government of India as one of the strategy as palliative care. In that particular thing, capacity building at community and tertiary facility levels have been mentioned as a strategy. But however, if you see our medical curriculum, even though post-graduation palliative medicine has come, undergraduate curriculum does not have a clear-cut palliative care teaching. Even though palliative care teaching is done under integrated manner, still there seems to be a lacunae. So in this context, this small study was done as a cross-sectional study among 265 students. Using a semi-structured questionnaire. The questionnaire was prepared on from existing literature. There was no standardized questionnaire, so questions were selected from already published studies. It includes questions on purpose of palliative care, pain management, communication skills, and perceptions. The data was analyzed using SPSS 23. Coming to the results, 97% were of students had heard about palliative care. This was because during this initial process of setting up of the unit, we had put some flexi boards outside the college premises. So probably that could be the reason. However, when we came to the individual questions, to the question on diseases needing palliative care, we found cancer to be among the leading, with 88% of students mentioning that which needs palliative care, followed by AIDS. Then coming to purpose of palliative care, we noticed that only 43% of students mentioned that it is used to improve quality of life. Even though there were other responses like treating pain, there were few responses saying that palliative care is given to quicken the death and prolong life. Coming to in which setup it can be provided, this tertiary facilities, home and hospice, about 44% of students said that it can be provided in all these three places. So that means the remaining 56% were not aware that where it can be provided. Coming to when to start palliative care, the answer expected was from the time of diagnosis, but we found that only around 15% were able to tell it is to be given from the time of diagnosis. Then the question on during communication, which is the most important strategy we have to follow. Only 1/3 of patients, only 1/3 of students said that we have to listen actively to the patients. Then to the question on oral morphine is given to relieve. We found that about 1/3 of students were able to tell it is really able to relieve cancer pain. Coming to other knowledge gaps, we found that students were not able to mention the quality of palliative care as the main aim. Then services provided includes all either
Dr. Srikanth?
Yes, ma'am.
Sorry to interrupt, sir, but the time is over for the presentation. We are going to start with the question and answer.
Okay, I'll conclude, ma'am. The findings conclude that there seems to be knowledge gap. So,
sir, please, the time is over.
Okay.
We are running late already. Ma'am, please start with the question and answer.
Thank you, Dr. Srikanth. This is a very, I appreciate the fact that you have touched all the areas, the misconceptions on morphine regarding the communication skills, the illness spectrum, the scope, everything you have covered. And most of them have answered that they think that palliative care can be included in the undergraduate curriculum. So again, what is the next step? Now you know that there is a gap. There is a huge gap in every areas that you have explored. But it is quite promising. At least some of them have identified HTR-TB and coma and spinal cord injury as that comes under palliative care. That's something that you can look forward to improve. But what will be the next step?
Ma'am, after this particular study, sensitization programs were conducted through medical education department because they were these students were in the pre-final and final years. So small sensitization programs were conducted for them, and when they became interns under community medicine department, they were also posted in the pain and palliative care unit of this private medical college.
That's wonderful.
That's quite nice that during internship they were posted in pain and palliative. So you use this universal sampling technique. What does that mean?
Madam, actually, that I have included all the total number of candidates in that particular 7th, 8th, and 9th semester. So I didn't go for any specific sampling techniques. So all the students were included. So it's considered as universe.
Also, what are the advantages of semi-structured interview?
Semi-structured interview, in case we don't have any standardized questionnaire, semi-structured interview can give us more responses from the participants, which the researchers would not have thought about it. And it also gives the participants to come out with many answers. If you have a structured questionnaire, the choices are limited to the participants.
That's all. Tracy.
Thank you, ma'am.
I think ma'am wants to say something.
Yes, ma'am.
I was just telling, thank you.
Naina. Hello. Can we have Naina? Garima. Garima Rawat. Okay. So, Damini Butola. Damini, ma'am?
Yes, I'm here.
Yes, ma'am. Please go ahead, ma'am.
I'll just share my screen. Is it visible?
Yes, ma'am, it is visible. Please start.
Okay. Good evening, everybody. I'm Damini Butola. I have just completed my master's in clinical psychology, and this is my very first time presenting an abstract. So the title of my study is Burden and Coping Mechanisms Among Caregivers of Cancer Patients. So cancer caregiving can be extremely intense and taxing, and this can have a negative impact on the caregiver's own health, well-being, and quality of life. Caregivers are defined as persons assisting individuals with at least one activity of daily living, and coping is defined as activities or thoughts that are utilized in an unpleasant situation to modify our reaction to it. Now, coping has been further classified as problem-focused, emotion-focused, and avoidant coping. And the aim of this correlational cross-sectional study was to assess the relationship between caregiver burden and coping strategies adopted by the cancer caregivers. The sample consisted of 91 caregivers of cancer patients aged between 19 to 65 years, and 81 of these fulfilled the criteria. So the data collection was done online using standardized questionnaires, and the statistical analysis found that the average caregiver burden was highest in the oldest age category, that was above 50 years of age, and it was comparable in the other two age categories, that was below 30 years and 30 to 50 years. And however, no statistically significant relationship was found between the two variables, but problem-focused coping was the most utilized strategy among all three age groups, and avoidant coping was the least utilized among the three age groups. And these findings are corroborated by studies done earlier. However, future research is recommended with larger samples, with qualitative data on the Indian population, so that we are able to help caregivers better. Thank you.
Thank you, Damini. Can you just take 10 seconds to explain problem-focused coping and avoidant quickly?
Sure. So problem focused coping focuses on trying to see where the problem is coming from, trying to modify the situation. It is a more practical approach to problem solving. Avoidant would include trying to escape or deny the problem, avoid the problem, and emotion focused would is focused more on how we are reacting, what our emotions towards that problem is. So usually there is no maladaptive or adaptive coping as such, except for avoidant coping. In problem focused and emotion focused, there are a variety of coping mechanisms that we use, and I think the best way to go about it is to be flexible in our approach.
Okay, you mentioned correlational study, right? What are the various types of correlational study you know of?
I'm sorry, I wasn't able to hear you. What
You
types of?
mentioned in methods, you mentioned correlational study. So what are the various
Yes.
types of correlational studies you know of?
I am not sure about that.
Okay, so basically there are three types. So it could be a positive or negative and a zero correlational research. Okay.
Oh, okay, that way, yeah.
Yeah. And also you mentioned purposive sampling. Now, what does that mean?
Purposive sampling is when it is up to the researcher to rely on their judgment about who should be a part of the sample.
Right.
That's all from my side. You mentioned that there'll be like you need further studies in a larger population. Do you think these coping mechanisms can vary depending on the illness, whether it is cancer,
Yes, ma'am. I
non-cancer?
think so.
Because
Depending on the stage of the illness, the type of cancer, and also what the age of the patient is, I think it would vary according to that.
that's all from my side.
Okay, thank you so much, participants, and Dr. Sridevi and Dr. Chandni ma'am. Thank you for this.
Thank you, everyone, and everyone has done a wonderful job. It was good to hear about your studies and your presentation, and thank you so much.
Ma'am, you will share your results with me
Yes.
through mail or on WhatsApp.
I'll just send it in an email within 2 minutes.
Sure, ma'am. Dr. Chandni ma'am?
Yeah, I'll send a mail. And thanks a lot. And what was the good part was we had people from all over the country. As in we had somebody from South India, North India, and East India also. That's quite nice.
Yes, ma'am. Thank you so much, ma'am. Thank you, ma'am. On behalf of the organizing committee, now I would like to invite the next judges for our next session. Dr. Anita Bansal. Ma'am, are you there?
Yes, Priyasi.
Okay. And Dr. Sanjay Dhiraj. Sir?
Yeah, I'm here.
Yes, I welcome you both. Dr. Anita Bansal is an additional consultant, Department of Anesthesia and Palliative Medicine at Bhagwan Mahavir Cancer Hospital, Jaipur. And Dr. Sanjay Dhiraj is a professor in Department of Anesthesiology at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Welcome both of you, ma'am and sir.
Thank you. Thanks a lot.
Okay, so now we can start with the session. Dr. Kahek Shah. Dr. Kahiksha?
Yes, I'm there. Am I audible?
Yes, ma'am, you are audible. Please start with it.
Okay. Good afternoon, everyone. I'm Dr. K. Kasha. I'm faculty in Shri Krishna Medical College and also palliative care physician at the Tata Memorial Hospital, that is Homi Bhabha Cancer Hospital, which is in the premises of the same medical college. The topic of my poster is caregiver burden of COVID-19 patients admitted in a tertiary care hospital in North Bihar during the second COVID wave. The second wave of severe acute respiratory syndrome caused by coronavirus 2 infection in India started around mid-March and lasted till about 3 months with a peak incidence of more than 4 lakhs per day. And known to all of us is we were running out of supplies of medical grade oxygen. There was prescription, left, right, center prescription of untested expensive therapeutic drugs. And the overall situation in the country was of distress. So with this scenario, we undertook this with the aim to study the caregiver burden of attendance of hospitalized COVID-19 patients during the second wave. The method employed was we prospectively enrolled primary caregivers of COVID pneumonia patients who were RT-PCR positive. The interview tool we employed was the short version of the burden scale of family caregiver. Along with that, out of which we took out very relevant socio-demographic, disease-related and financial burden information. And with that, we also did the rapid antigen testing of the primary caregivers. And all of this data was analyzed using the SPSS version 26. As a result of the analysis, we found out that out of the 50 patients whose caregivers we had analyzed, the median age of the caregivers was 33.5, out of which 2/3 were approximately males. This tertiary care center caters to approximately 3 districts, with patients traveling from around 60 kilometers, maximum of 60 kilometers, with the mean distance of the patients that were admitted at the center was approximately 41 kilometers. And we found that each patient was usually accompanied, so the duty of taking care, the logistics so worked out that 2 family members or the 2 caregivers would alternate between the duties of staying with the patient and catering to his or her needs. The most common caregiver in 50% of the cases we found were sons, and in 40% were spouses, either husband or wife. The mean income turned out to be around 14.
So, sorry to interrupt, ma'am.
Yes.
Ma'am, the time is for the presentation is over. Now we can start with the question and answers.
Can I just take half a minute?
Sorry, ma'am, we are already running late with the sessions.
Excuse me, doctor, can you conclude your study?
Okay, ma'am. The main thing we want to highlight in this is that what we found was that the mean burden of caregiver burden turned out to be a score of 16 out of 30 with a range of 6 to 24, and 1/3 of the caregivers as a result of the hospital stay tested positive during the course of the study. The burden reported is multifactorial. That was not caused by just one single thing. The males, migrant worker and unemployability, they were found to be statistically significant in contributing to higher burden scale. And females somehow had a lesser burnout as compared to male caregivers.
Dr. Kayakasha,
Yes, sir.
Could you just let me know in the BSFC score,
Yes.
which question was mostly asked, which percentage was the most agreed upon? Suppose there are like 10 questions, so there must be one question which was strongly agreed upon. So could you just let me know that?
So most agreed upon. So sir, I'm not sharing the screen now, but I have it here. The thing they were most worried about was I am worried about my future because of the care I give. This was the question that was most agreed upon, sir.
Okay, and the least one?
Least one was my relationship with other family members, relatives, friends, and acquaintances is suffering as a result of the care, because they said that they were mostly connected through phones, and so more or less that did not affect them much.
Okay, and I am worried about my future. In what sense about they were talking about?
So some of the caregivers were breadwinners. Some of them, because when we undertook the rapid antigen test, we also disclosed the result to them. So 1/3 of them tested positive. So they were worried that way as well. And overall, because we were getting such news, the overall scenario was so depressing.
Okay, thank you. Thanks a lot.
Thank you, sir.
So was it any different from the normal cancer patients you see? Was there any difference between this score and the scoring you do for cancer patients in the questions, or you haven't done till yet that the scoring?
Sir, I have not personally done. I have gone through a couple of my colleagues who do this. But because here, to be very honest, the things were mostly financially related, in the sense that though it was a government medical college, they had to spend so much for oxygen arrangement, for traveling in that lockdown period. So and obviously that is true in cancer also, sir. But because Tata somehow has been able to get so many funds from so many different sources, that any patient who turns up for cancer care in that center, we somehow will make arrangements for their treatment. But this the patients that were admitted for COVID, so they're working out the finances per se. It was a tertiary care non-cancer teaching medical college and hospital. So they didn't take up, at least I know there have been compensations and all later on, but at that point of time they didn't know how to get along the financial burden.
Okay, thanks a lot. Thanks a lot.
Thank you, sir.
Okay, so I'm repeating the instructions for the sessions. So all the participants are given the total 6 minutes, 3 minutes for the presentation and 3 minutes for the question and answer. So I think we should adhere to the time. Okay. So the next participant is Namita. Namita ma'am, are you here?
Yes, yes.
Ma'am, please start your.
Good evening. I'm Dr. Namida from the Department of Radiation Oncology, AIMS Rishikesh. I'm the junior resident from the Department of Radiation Oncology. My topic for presentation is symptom management and palliative treatment in pediatric cancer patients. Childhood cancers are relatively rare. However, it is the second leading cause of death among children. As children are not able to convey their symptoms, they are usually diagnosed at advanced stages. For these patients, physical, psychological, social, and spiritual quality of life can be improved by providing supportive treatment. Our aim is to assess the outcome after palliative chemotherapy and radiotherapy in pediatric cancer patients. The materials and methods include, this is a single institutional retrospective study conducted between July 2018 to 2021. All pediatric malignancy patients requiring palliative treatment were included. Following parameters were assessed: age, gender, tumor types, stage treatment. We have total 25 patients. Out of this, age is 8 months to 15 years, and the mean age is 5.8 years. The most common site of metastasis is lung, and which constitutes about 20%. And the most common symptoms observed and managed were pain, breathlessness, spinal cord compression. At present, 20 patients are alive and are on treatment, and the median survival is 11 months. This is a graph showing primary diagnosis of the patients. Out of this, most of the patients are in Ewing sarcoma. The second is Bill's tumor, then the rhabdomyosarcoma, then the medulloblastoma, then osteosarcoma and hepatoblastoma. This is the figure showing the one for a patient lung bath showing the embryological rhabdomyosarcoma. And out of this, we have given palliative chemo, palliative radiotherapy, and both chemo and radiotherapy. Out of this, 12 patients, 12% received palliative chemo and 9 palliative radiotherapy, and 4% received both palliative chemo and radiotherapy. And coming to the characteristics, out of this 10 patients is in the age group of 0 to 5 years, and 5 to 10 years, it is 12 patients. And the primary site is out of 5 patients is having sarcoma, followed by Wilms tumor, then germ cell tumor, then rhabdomyosarcoma, glioma, medulloblastoma, and hepatoblastoma, osteosarcoma, and neuroblastoma. And the metastatic symptoms, out of 4 patients, they have pain, and 3 patients, they have breathlessness, and 3 patients, they have spinal cord compression. And the palliative treatment, 12 patients received palliative chemotherapy, 4 patients palliative radiotherapy, and 9 both RT and chemotherapy. And the outcome is 20 are alive on treatment and 5 are expired. And the conclusion is pediatric populations are not diagnosed at an early stage as their symptoms are not identified early. However, with palliative treatment in the form of chemotherapy and radiotherapy, their survival can be prolonged.
And Dr. Namita.
Yes, sir.
So I would like to know that the final conclusion you have given, like, however, with palliative treatment in the form of chemotherapy and radiotherapy, their survival can be increased. So how did you come to the conclusion? I could say that the symptomatic treatment that you are giving in the form of pain management, other than palliative chemotherapy and radiotherapy, would have resulted in their increased survival, not radiotherapy and chemotherapy per se. Did you get my point? Yeah.
No, sir, actually, I didn't get your point.
So for pain management, you must be giving radiotherapy and chemotherapy, but you must be also giving other drug management in the form of analgesics or anti-neuropathic agents. So they must have also helped in increasing their lifespan, and not this radiotherapy and chemotherapy per se, only that alone. So how did you come to that conclusion?
Sir, because the pediatric babies are not able to convey that they have having pain. So basically, by their parents or who are with the babies or be conveying their symptoms. So most of the time, the patients will be presenting at an advanced stage. So that we'll be giving both either palliative chemo or palliative radiotherapy. By only giving analgesics, we won't be able to treat the patients per se.
Okay. Dr. Anita, hello.
Yeah, I'm not happy with the answer.
She's telling that she's not only with radiotherapy and chemotherapy.
No, but there is many analgesics which we are using in pediatric patient. They also make them comfortable. Not only
yeah.
I also want to ask how they manage the pain or how they assess the pain.
Yeah. Basic, ma'am, and that I didn't mean that only we can give analgesics, but analgesics that
sorry to interrupt, but we can give. We even give analgesics.
We are giving analgesics
with adjuvant as in a palliative chemo or radiation.
Yes, ma'am. Yes, ma'am.
So your conclusion could have been that you can increase the life expectancy of the patient by both chemotherapy and radiotherapy, and also the other symptomatic treatment you are giving to the patient. That is what I am saying.
Okay, sir. It is not only that. Topic, the symptom and treatment.
And yeah, you have also mentioned in your
conclusion is not completed without mentioning those symptoms and the management, no?
Yes, ma'am. Yes, ma'am.
Okay, thank you so much.
Okay, thank you. Thanks a lot.
Yes, thank you. Thank you.
Okay, Dr. Rabia?
Yes, ma'am, I'm here.
Yes, ma'am. Please start.
A very good evening to one and all. Today I will be presenting to study the clinical correlation between CIPN and vitamin deficiencies. For my introduction, chemotherapy-induced peripheral neuropathy is the most common dose-dependent adverse effect of chemotherapeutic agents. The prevalence is estimated to be 19 to 85%. It is seen that 68.1% after taking chemotherapeutic agents develop CIPN symptoms in the first month, 60% at 3 months, and 30% at 6 months. CIPN has led to a dose reduction or discontinuation of treatment and has severely affected the quality of life of cancer patients. So my aim of my study was improvement in CIPN symptoms through selective nutritional supplementation. So I have conducted the study in AIMS New Delhi from a period of January 2018 to July 2020. A total of 50 patients were being enrolled into my study. All the clinically diagnosed CIPN patients were being taken and enrolled into the study. A baseline workup of vitamin B12 and vitamin D3 was being done. They were being broadly classified into the non-deficient group and the deficient group. The non-deficient group was given only gabapentin, and the deficient group was given gabapentin and vitamin B12 and vitamin D3 or either of them. And they have been followed up with the help of VAS scale and SLAN scale at 3 months and 6 months respectively. My intervention groups are as follows: 46% received gabapentin alone, 34% received gabapentin and vitamin B12, and 20% received gabapentin, vitamin B12 and vitamin D3. The symptom assessment was being done by the using SLAN scale. So around 46 patients had a complaint of tingling and pins and needle sensation, 36 patients burning pain, and 26 patient electric shock like sensation, and around 2 people had allodynia, weakness, and skin discoloration. A comparative statistical analysis was being done of VAS scale at 6 months between gabapentin alone group and gabapentin and vitamin B12 group. Likewise, gabapentin alone and gabapentin alone with vitamin B12 and vitamin D3. As you can see, the p-value is less than 0.05 and it was considered to be statistically significant. Similarly, a comparative statistical analysis of SLAN score was being done at 6 months between gabapentin group and both of the groups. So this results were very much similar to the results done by Scholas et al. In 2017. They said that a patient taking B group vitamin perceived a reduction in sensory peripheral neuropathy. Likewise, Grimm et al. In 2017 also said that in selected risk nutritional factors for CIPN, there was significant improvement in the CIPN symptoms after taking vitamin D supplementation. So I would like to conclude that gabapentin with nutritional supplements in CIPN shows significant improvement in reduction of neuropathic pain compared to the gabapentin alone cases at 6 months follow-up. Therefore, we can always recommend the use of nutritional supplements with gabapentin to mitigate the CIPN symptoms in cancer patients. Early diagnosis and prevention of permanent CIPN symptoms needs to be a priority in extending the quality of life in cancer patients.
I want to ask one question, ma'am. Which chemotherapy drugs you mostly used in your patients? Because there are few drugs which leads to deficiency of these vitamin B12 and D3. And initially you have divided in 2 groups, deficient and non-deficient. So I want to ask you, which chemotherapy drugs in all patients, same chemotherapy drugs are used or different?
Yes, ma'am. Ma'am, I have actually used the most common chemotherapeutic agents were 6 antineoplastic agents. I have taken platinum groups. I have taken taxane groups. So platinum, you have the cisplatin, and taxane, you have the doxytaxel, ma'am. So mostly I only took these cases and who have been treated for CA breast and CA ovary, ma'am. So I have taken only these cases, ma'am.
But this cisplatin, paclitaxel, they all lead to deficiency of these B12 and D3 alone themselves. So how you can justify that in a non-deficient group we are using only gabapentin, because these chemotherapeutic drugs itself causing deficiency of this B12 and D3. You can understand what I want to say.
Yes, ma'am. Initially, when I was enrolling my I was enrolling the patient, I was taking the samples for all the patients, and only those patients who had a deficiency in vitamin B12 and vitamin D3 were being enrolled into my study, ma'am. So that's why I had an equality between all the patients who had only this deficiency were being enrolled, ma'am. And then I broadly classified them. I gave them one gabapentin alone and the other one gabapentin or like gabapentin ME with a methylcobalamin, and vitamin D3 were also being supplemented, ma'am.
Okay, after chemotherapy,
and then I followed them up with
then you check the vitamin B12 and D3
yes,
levels. You want to say this? Okay.
Yes, ma'am. Yes, ma'am.
Is there any level of evidence for this B12 and D3 role of in prevention of CIPN?
Yes, ma'am. Scholas et al., Grimm et al. There are a lot of studies done, ma'am, in CIPN, and there are some studies of omega-3 fatty acids also, and calcium and vitamin E. They're all in a phase 3 trial, ma'am. So I just took only vitamin B12 and vitamin D3 because it was easily accessible in our institute to get it done for all the patients for free, ma'am. But I will be continuing ahead with omega-3 fatty acids and vitamin E, ma'am.
Dr. Rabia,
yes, ma'am. Yes.
I just wanted to ask your second conclusion that you have drawn.
Yes, sir.
Could you just let me know whether the patients who had a normal level, normal
Yes, sir.
baseline level, and
Yes,
you
sir.
administered them only gabapentin?
Yes, sir.
So then did you compare their land score? You had
Yes, sir.
compared these three groups, but have you
Yes, sir.
compared the land score of patients who had a baseline
Yes.
normal value, and when you gave gabapentin, then did you find any difference between the pain scores of between these patients?
Yes, sir. Yes, sir. I did gabapentin alone cases as well as who had normal values, and then gabapentin with the deficiency
No,
component.
so
So
when
there
you
was
compare,
significant. Yeah.
no,
Yes, sir.
between the groups they were significant, but
Yes,
when
sir.
you are taking the patients who had a normal value
Yes.
and you are giving
Yes,
gabapentin to
sir.
them, these
Yes, sir.
group did they show a decrease in the land score?
Hello, sir.
Okay,
Okay.
Priyashi, we can stop this thing and then we'll take the next candidate.
Yes, sir.
Yeah,
Thank
yeah.
you so much, sir.
Okay, thank you. Thanks a lot.
Dr. Bahaja Kareem. Dr. Bahaja? Dr. Bahaja, are you here? It's okay. Dr. Varun? Dr. Ruth?
Yes, I'm here.
Please start.
If you can, you were going to put on the slide for me. Thank you. So my name is Dr. Ruth Powis. I'm a palliative care physician working in Nepal, and I'm speaking on behalf of my team from Green Pastures Hospital in Pokhara about a novel intervention of low-dose menthol application for neuropathic pain. So topical cold-induced analgesia is elicited by low-dose menthol, and this is helpful for managing neuropathic pain. Menthol selectively activates the TRPM8 receptors in sensory neurons, which show increased expression after nerve injury. But we know from previous clinical studies at our hospital that our spinal cord injury patients, our leprosy affected patients and others have had a significant burden of neuropathic pain. So the objective, this is to explore the effectiveness of topical menthol in either mustard or sunflower oil. This is a case series using 2% to 5% menthol applied to the area where patients are experiencing the neuropathic pain and the related spine areas. It's applied twice daily for 6 weeks. Data collected was using the brief pain inventory short form and the Leeds assessment of neuropathic symptoms and signs at baseline, 2 hours after the initial application, after 2 weeks, and after 6 weeks. A significant improvement is more than 30% improvement in scores. We have currently 308 pain episodes, which have come from 178 individuals. 133 of these are leprosy affected, and the others are spinal cord injury or stroke. Looking at the maximum severity score as part of the BPI, more than 30% improvement from baseline was found in 18% at 2 hours, and then increased up to 82% at 6 weeks. And 2.9%, so that was 9 of the 308 episodes, it reported total relief. For the total BPI, which is normally a score out of 10, more than 30% improvement from baseline was 13% at 2 hours and increased up to 87% at 6 weeks. For the Lance, which is a score out of 24, more than 30% improvement from baseline was 25% at 2 hours and up to 71% at 6 weeks. And you can see from the graph there. So even though this is just a case series, there's certainly a strong indication that low-dose menthol is actually quite significant in the management of neuropathic pain. And further controlled trials to test the effectiveness of this novel intervention are required to confirm these results and the number needed to treat. Thank you.
Sir, ma'am, please go ahead with the questions.
Yeah, this is a good one actually. This is a good study. So did you care? Hello.
Hello. Yep.
Hello, Dr. Ruth.
Yes.
Yeah. Did you carry out this study? You have taken more patients now after that, or the study has been stopped?
So because low-dose menthol, it needs to be between 2 and 5%, the menthol. If it's a higher percentage, you actually get hyperalgesia. So that's totally unhelpful. Locally, we don't have any 2 to 5% menthol available in the market. So we've continued the case studies because our patients are collecting the case studies because our patients are getting very significant relief and are asking for it. We've been keen to join in a larger randomized controlled trial, but because of COVID, those thoughts and plans got put to one side. But our hope is that we can actually be involved with a proper randomized controlled trial because this is just case series. We're seeing some nice results, but it needs a lot more evidence.
Okay, and then how you are making the concentration? So how you are making that preparation? The menthol preparation?
Yeah, so we have menthol crystals, and then our pharmacy is actually putting that together. So to make 2% is our first line, and we only increase to 5% if the 2% isn't effective. So for all patients, we usually start with 2%, give them a 6-week trial, and if they're not getting adequate response, then we then move to 5%. It's quite interesting with our leprosy affected patients. Our observation is that the 2% is actually highly effective, which is very interesting.
And how much you are applying? Like you are applying it, they are applying daily for only once, or they are applying it 2 or 3 times a day?
So it's twice a day after washing, applying it twice a day and being very careful not to get it into eyes, mouth, or perineum, of course, because it's very irritant.
Yeah.
And for 6 weeks. So yeah, people have to, and the idea is you apply it and you leave it on for up to 6 weeks. We're finding that we get response, as we saw, even after 2 hours, you get quite a significant response, but these are only case studies. And so we need better evidence.
Okay, thanks a lot. Thanks a lot.
Thank you.
Excuse me, ma'am.
Yes, please.
Ma'am, is there any precaution you want to advise your patient before applying these menthol gel?
Yeah, the main thing is just to be careful because they use their own hands to apply it. They need to wash their hands after they've applied it because the menthol, if it gets anywhere near the eyes or the mouth, is actually quite irritant. We've had almost no side effects. We've had a few patients who don't like using the mustard oil because the skin goes a darker colour, but they're reasonably happy with sunflower oil. But we really haven't had we haven't picked up any side effects from using this. So it's a very simple, cheap, effective treatment, particularly for our context.
Sorry to interrupt, ma'am. The time is over. 6 minutes are over.
Okay,
Thank you very much.
Thanks a lot. Thanks a lot.
So, Dr. Varun, are you here?
Good evening, ma'am. Yes.
Yes, please start.
Yeah, Dr. Varun, you may start, please.
My study was utilization of the intravenous lignocaine infusion as a multimodal analgesic for chronic refractory cancer pain management. Background of the study: pain accommodates more than just an unpleasant experience and has been recognized as the fifth vital sign by the American Pain Society. Patients with advanced cancer experience the chronic pain from progressive illness and with increasing at terminal stage of the disease. Generalized definition of the chronic pain was pain that extend beyond the expected period of the healing. Conventionally, cancer pain is treated adhering to the WHO analgesic ladder, but some patients continue to suffer persistent pain and they are frequently unresponsive to escalating opioid dose. Lignocaine, which is a amide type of the local anesthetic and also class 1B antiarrhythmic, and has also the anti-nociceptive, immunomodulator, and anti-inflammatory property. Lignocaine inhibits the voltage-gated sodium channel, gated calcium channel, various potassium channel, and block the NMDA receptors and uncouple the G protein pathway. Lignocaine attenuates the peripheral nociceptor sensitization and central hyperexcitability through its sodium channel blocking property. Because of this property, lignocaine appears to promising approach in the management of the chronic pain in cancer. Aim and the objective of the study to evaluate the effect of the intravenous lignocaine infusion on the chronic cancer pain and to evaluate the short-term efficacy and safety of the 4 mg per kg lignocaine infusion for the 5 days. Methodology: this prospective analytical study conducted at the Palliative Medicine Department GCRI. Inclusion criteria are cancer patient with chronic pain and on opioid therapy who have no pain relief or partial pain relief, and the age between 18 year and 60 year, patient having the neuropathic
Dr.
pain.
Varun, sorry to interrupt, but you are not sharing your screen.
Slide, yeah. Could you just share your screen, please?
I think
Yes,
this is poster presentation, so you have to present your poster.
One minute. Sorry.
Dr. Varun, time is running.
Ma'am, there is something error. Can I get some time after 1 or 2?
Priyasi, excuse me, Priyasi, can we continue with next candidate till Dr. Varun can solve his issue?
Yes, ma'am. We are running late already with the time. So, Dr. Varun, you please resolve your issues. We are going ahead with the next participant.
Okay, ma'am.
Yes. Dr. Dhanshri.
Yes, ma'am, I'm here.
Yes, ma'am. Please share.
Is my screen audible?
Yeah, your screen visible.
Oh, sorry. Hello, everyone. You might have heard and learned about interstitial lung diseases, which is a chronic chronic lung disease consisting of progressive fibrosis and scarring of lung parenchyma. It usually presents with symptoms like cough, dyspnea, and ultimately respiratory failure. Currently, only approved drug for this treatment of interstitial lung disease is pirfenidone, and in some trials we have encountered other antifibrotic agents like nintedanib. And what if these don't decrease the disease burden and symptoms persist? What is the next for symptom relief? Good evening, everyone, respected judges and dear colleagues. This is Dr. Dhanashri from Department of Palliative Medicine from Tata Memorial Center, Mumbai. Topic for my today's presentation is Breathe with Ease, that's palliation of dyspnea in interstitial lung disease. Aim here stands as to how opioids and non-pharmacological management helps in dyspnea related to interstitial lung disease in advanced ovarian cancer patient, leading to improved quality of life and decreased oxygen requirement. Case description of my study: 67 years old woman with advanced ovarian cancer presented with complaints of dyspnea, dry cough, and later diagnosed to be due to interstitial lung disease. She had dyspnea of grading MMRC grade 4 with and with numerical rating scale NRS, it was of 10/10, and her oxygen saturation in room air was 88%. On chest auscultation, bilateral crepitations were revealed. She was treated with intravenous antibiotics, perfenidone, prednisolone, and high flow oxygen at 10 liters, but with no symptom improvement. She was then started on oral morphine 2.5 mg q 6 hourly, and with non-pharmacological measures such as propped up positioning, pursed lip breathing, distraction and relaxation techniques, cool ear over face, and chest physiotherapy. Her CT scan showed fibrotic changes in the lower zones with progressive reticulation and honeycombing pattern. Pulmonary function test and diffusing capacity of carbon monoxide revealed restrictive lung disease. On above course of management, after 1 week, she had significant relief in dyspnea with NRS of 3/10 with reduction in O2 requirement to 2 liters. On her follow-up further visits, she needed lower doses of morphine as well and did not need supplemental oxygen. Her X-ray after management showed decreased in ground glass opacity. Hence, we concluded that a comprehensive breathlessness management plan with low dose opioid and non-pharmacological measures improved dyspnea and decreased hospital stay of the patient in interstitial lung disease in an advanced cancer ovarian patient. Thank you.
Thank you, Dhanashri. Just let me know that did you do a total leukocyte count in this patient? Because I can conclude that the antibiotic you are giving had that effect, and now the patient is good.
Yes, sir. Actually, this patient was under parent unit, that is under thoracic and gynecology. They did the total leukocyte count. There was like no signs of infection present in the patient initially.
So you were starting, you had the patient was on IV antibiotics, I suppose you have told. So there must be a signs of infection.
That was like before diagnosing whether she was having any interstitial lung disease or any pneumonia or any other like lung metastasis. They were giving they have started generalized treatment of antibiotics, but after that they concluded that there was no infection along with ILD, so they started with perfenidone and steroids, low doses of steroids.
Okay. And the other thing I wanted to ask you is that when the patient improved, did the saturation also improve?
Yes, sir. Her O2 requirement after 1 week, like she was requiring only 2 liters of O2. Then she was like sent on home-based O2 therapy, and was followed up with her relatives as well. And at later, like after 2 months, she was not requiring O2 support at all.
No, what was the saturation? It was 88% beforehand.
No, that saturation improved above 90%, like 90 to 93%.
Okay, thank you.
Thank you, sir.
Dr. Anita, would you like to ask any question?
Actually, time is running.
You can ask. 1 minute is there.
I want to add only one thing. When we are giving palliative treatment for any patients, for any symptom in cancer patients, first, in case of breathlessness, it is a rule: don't give high flow oxygen, either through mask. You can use nasal prongs because if you give oxygen through mask, it leads to choking. As patient is feeling distress, respiratory distress, in air hunger, and we are giving high flow oxygen, it will lead to dryness only. No improvement in her saturation or anything. And you are advised her PFT also. I don't understand what is.
No, that was done for routine management by the parent unit. That is the thoracic and ovarian, like gynecological.
This patient is cancer patient, advanced CA ovary with interstitial lung disease. You already said. And second diagnosis, we can also think about METs, lung METs.
But there were no lung metastases.
With PFT, we have not, did it change our plan of management? No.
That was, PFT was used for diagnosis of interstitial lung diseases.
Actually, her PFT value is also not reliable in this case, and she's in distress. She's not able to do spirometry in proper way.
Yes, ma'am.
Okay. Nice presentation.
Thank you, ma'am.
Priyadarshini, ma'am.
Yes, Amara. I'm
Yes,
here.
ma'am.
Is my screen visible?
No, not in.
I'll try again. I'm so sorry. From my side, it shows screen.
Yeah, it's visible now. Priyadarshini is visible now.
Yeah, thank you, sir. Good afternoon. My name is Priyadarshini. I'm a clinical psychologist by profession and a PhD scholar at the Department of Psychology, Punjabi University, Patiala. The title of my presentation is Post-Traumatic Stress Associated with Providing End-of-Life Care Services to Intensive Care COVID-19 Patients, Stories of Fright, Fight, and Freezing Among Healthcare Professionals. The aim of this study is to highlight the post-traumatic stress and associated psychopathology among healthcare workers who served actively during the COVID-19 pandemic second wave in India. I would quickly jump on to the methods. So the research design that I have utilized is a multiple case study design. Total cases here we have taken n is equal to 3, out of which 2 were doctors and 1 was a nurse aged between 26 to 34 years, and 2 were males, 1 was a female. These are the doctors who have Indian healthcare workers rather, who served actively during the COVID-19 second wave. For analysis, we have utilized qualitative method of analysis and thematic analysis for that matter, for the simple reason that we had lesser number of cases and no other statistical analysis could have been performed. Coming to the cases, case 1 is of a doctor, Miss S, 26-year-old doctor, who lost her father to COVID-19 while serving her duties in a COVID-19 ward, but she could not visit her father for the last time and could not attend his last rites. She had massive guilt and unprocessed grief, so when she came for counseling, she was having multiple nightmares. She felt that she was not an effective daughter. She also felt an aversion towards a profession and questioned herself constantly if she was doing the right thing by even continuing in this profession. Case 2, Mr. Yu, 32-year-old MD medicine second year resident who lost his wife to COVID-19, again had a lot of guilt, depression, and was angry at himself. He was referred to therapy or psychotherapy by the treating psychiatrist. He also reported that he had a lot of sleep disturbances, loss of appetite. He was suffering from a moderate depression and severe anxiety. Case 3 is of Mr. L, who was a 34-year-old doctor, had nightmares, disturbed sleep and appetite. He reported distress coming to him due to the frequent images of mass deaths and cremations, because he had not only served in the COVID-19 wards to treat patients, but also arranged for cremations. Coming to the results and discussions, the following themes emerged out of the thematic analysis: loss associated to guilt and grief, unprocessed traumatic experiences, questioning one's professional worth for not being able to save a patient or a loved one, psychopathology, which majorly revolved around PTSD, which is post-traumatic stress disorder, depression and anxiety, diminished socio-occupational functioning. Now, coming to the critical review, of course, the limitations for this study remain that it's a small sample size and the generalizability remains low. However, there are significant implications. The applied value of the findings that we have are immense, because we need to look at the healthcare workers who have served during this phase, and we need to probably assess
Priyadarshini?
Yes, ma'am.
Ma'am, sorry. Presentation time was 3 minutes and it's over. We are starting with the question and answers.
Sure.
Ma'am, sir, please go ahead.
So, Dr. Priyadarshini,
Yes.
after having this is a nice presentation,
Thank
and
you,
after having all these things, what things would you like to put in place so that you can reduce this post-traumatic stress in this group?
Sure, sir. So this particular case report that I made was, I think, about 4 months back. So I've already started going to the hospitals that I'm associated with and talking to the healthcare professionals about their stress and if they are carrying any trauma. The beautiful thing that I found was that most of them didn't even realize that they had a trauma or traumatic experience. They thought that it was a part and parcel of their job. So we did some sort of maybe a screening assessment and stuff, and we started working on the traumatic experiences. Most of them have been under therapy for some time now. Other than that, I think we need to start putting in place certain therapeutic experiences for trainee doctors. I don't think MBBS or MD students do get their therapeutic assessments done while they are serving or getting trained itself, so that they start taking care of their own mental health. I think healthcare workers are really harsh on themselves, given that their duty hours and training is in itself very, very harsh. So somewhere I think these two things would be very important. One, trauma assessment for healthcare workers, and two, training for the trauma that they might get and they might carry, and then taking care of themselves. So allowing them to seek help for themselves, I think that's the one skill that we need to teach them for. If that answers your question, sir.
Thank you. Thanks a lot.
Thank you, sir.
You have very good. You did very good job, but the only limitation is small sample size.
Yeah,
Yes, I only had three
Please study on more number of patients, not only doctors, including nurses.
Yeah.
Every person who have lost somebody they close during this.
Yes.
And nice presentation.
Thank you so much, ma'am. I'll keep the suggestion in mind. Thank you.
Dr. Priyadarshini, is it over?
Yeah.
So next participant, Maxi and Dia.
Yes, that's correct. Hello, can you hear me?
Yes, ma'am. Your voice is echoing.
Can you hear me? Okay, I will try to share. Oh my God, I think I have some technical issues in operating the sharing. So I'm not sure how can I actually do this.
No problem, ma'am. Please start with your presentation.
Okay. Sorry about that. Good afternoon, ladies and gentlemen. Greetings from Tirana, Albania. My name is Andja Meksi. I'm a clinical psychologist and a psychotherapist, and I work at the National Institute of Public Health in Albania. I'm pleased to be present today at the annual conference of Indian Association of Palliative Care. Without further ado, I would like to present briefly my research topic on nurses' perception and experiences related to stress as a result of patient care in palliative care services. Palliative care in Albania initiated in the beginning of 2000, and as a necessity for providing home-based.
Excuse me, sorry for interruption.
Yes.
Please show your poster.
No,
Yeah, but I have issues. I have issues sharing. I have some technical issues sharing the poster, ma'am. So I'm afraid that would take time because I'm so sorry about that. Do you understand me? Can you hear me?
Dr. Varun?
Okay, Dr. Varun, are you ready with your PDF?
Yes, ma'am.
Please share your screen.
Dr. Prishi, could you just tell Andy that she has to share her screen, so she should get ready within 5 minutes or so.
Okay, sir, I will.
Is it okay, ma'am?
Yes,
Varun,
please
we are able
start.
to hear.
Okay, good evening, sir. Good evening, ma'am. I am Dr. Varun Yadav, resident doctor in GCRI, Ahmedabad. Presenting the poster on subject of utilization of the intravenous lignocaine infusion as a multimodal analgesic for the chronic refractory cancer pain management. The background of the study was pain accommodates more than just an unpleasant experience and has been recognized as the fifth vital sign by the American Pain Society. Patients with advanced cancer experience the chronic pain from the progressive illness and with prevalence increasing a terminal stage of the disease. So conventionally, cancer pain is treated adhering to the WHO analgesic ladder. Some patients continue to suffer persistent pain and they are frequently unresponsive to escalating opioid dose. Lignocaine, which is a amide type of the local anesthetic and class 1B antiarrhythmic and has also the anti-nociceptive, immunomodulator and anti-inflammatory property. Lignocaine inhibits the voltage-gated sodium channel, calcium channel, and various potassium channel, and also block the NMDA receptor and uncouple the G protein pathway. Lignocaine attenuates the peripheral nociceptor sensitization and central hyperexcitability through its sodium channel blocking property. And because of this property, lignocaine appears to a promising approach in the management of the chronic refractory cancer pain. Aim and the objective of the study to evaluate the effect of intravenous lignocaine infusion on the chronic cancer pain and to evaluate the short-term efficacy and the safety of the 4 milligram per kg lignocaine infusion for consecutive 5 days. Methodology is a prospective analytical study conducted at the Palliative Medicine Department GCRI, included the patient with chronic pain and on opioid therapy who have no pain relief or the partial pain relief and age between 18 years to 60 years and having the neuropathic pain according to the DN4 questionnaire and pain duration greater than 3 months. Patient with severe cardiovascular or cerebrovascular hepatic dysfunction or allergy to lignocaine and not filling for the consent are excluded in this study. After obtaining the informed consent, 10 patients selected for the study and all the patients received the injection lignocaine 4 milligram per kg in 100 ml NS for consecutive 5 days and the pain score was assessed by the visual analog score. Vitals also monitored prior, during and after the infusion and side effects were noted if any of them occur. Result, this prospective analytical study included 10 patients meeting all the inclusion criteria. Mean VAS score of all the patient on the day 1 before the infusion was 7.9, which is reduced to 2 after the 5 consecutive day of the lignocaine injection on the 5th day. And on the second week follow-up, mean VAS score was 3.1, and on the 4th week follow-up, the mean VAS score was
Dr.
4.1.
Varun,
Yes,
Dr. Varun, the 3 minutes of presentation are over. Sir, go ahead with the questions. Ma'am, please.
Dr. Varun, you have used xylocaine infusion for 5 days, for consecutive 5 days.
Yes, ma'am.
So you did this study in only IPD patients in ICU setting?
No, ma'am. OPD based and indoor patients both are involved.
But how to conduct this study, xylocaine infusion in OPD patient? Because as I remember, I studied xylocaine, it will be given only under monitoring because it leads to many, it has many side effects, mainly cardiovascular. So
when we given the infusion under monitoring in OPD, like
admitted that patient
OPD, daycare, like
okay.
before infusion we monitor all the vitals during infusion, and after the infusion we patient have to stay at the hospital for 2 to 3 hours, and if no complication occur, then he can go and then for the next
used only
day.
4 milligram per kg dose
Yes.
for 5 days, not 4
Yes.
milligram per kg per hour. I thought 4
No,
milligram per kg per hour infusion you have given.
No, ma'am. 4 milligram per kg for one in 1 hour.
Bolus dose.
Bolus dose
In
in
100 ml NS.
100 ml NS.
Okay. And after 2 to 3 hours, you discharge the patient.
Yes. Or some patient who are consecutively on like radiation, taking radiation or etc. like daily
IPD
visit.
patients. And they are also under a monitor now.
Yes. Whole vitals and pulse, blood pressure, oxygen saturation.
Did you notice any side effect of related xylocaine in any your patient or withdrawal of study?
No, ma'am. No side effects were noted in our 10 patients.
Okay.
Dr. Varun, what side effects did you note basically?
Sir, lignocaine mainly causes the cardiac side effects like bradycardia or circulatory shock, edema, or something like that. And
no, you had the proforma, na? So in which in that what side effect did you tick or untick? You must be having a proforma so that this side effect is there or not. So what side effects did you put in your proforma?
Mainly respiratory, cardiovascular, any side effect like decreased respiratory rate, bradycardia.
Okay. So Dr. Varun, what was your cancer patient's profile? So they were like all of the same group, cancer group, or they were different, like each one had a different type of cancer, these 10 patients?
Mainly patient of head and neck cancer, and other ones are from bone cancers
Okay. And what did they were they on any other anti-neuropathic drugs like gabapentin, tryptoma, or something like that?
Yes, yes,
Or
sir.
all of them
Opioid
were
and it's an adjuvants like for neuropathic pain.
okay? All of them were on that, or some
Yes,
some
yes.
of them were there and some of them were not there.
Most likely all the patients who are on weak opioid or strong opioid and not pain relief.
Sir,
Okay, Priyashi.
Sanjay sir,
Yeah.
the time is over.
I know.
Okay.
Okay.
Thank you,
Thank you.
sir.
So, Dr. Andy, are you here? Yes, ma'am. Please.
Yeah. Okay. Dr. Andy, you may continue, please.
Please unmute.
Yeah.
Dr. Andy? Hello?
Hello. Yeah.
Dr. Andy, ma'am, please start.
Dr. Andy, please unmute yourself.
Dr. Andy, we can't hear you. Please unmute yourself and start with the presentation, ma'am. We can't hear you still, ma'am. Sorry, ma'am, we can't hear you.
Can you hear me now?
Yes, ma'am, we can hear you now. Please start.
Yeah, I think there is a problem with the sharing, and when I share my screen, then you cannot hear me. I don't know. There is an
Ma'am, we
issue.
can hear you and we can also see your poster.
Okay.
Our technical team have shared.
Good.
Please.
Okay, good. Thank you. So, as I said, the palliative care was established in 2000 as a necessity to provide a home-based specialized treatment for cancer patients in advanced stage of their illnesses. Currently, only cancer patients in terminal phase of their illnesses can benefit from palliative care services, and the treatment is mainly focused on pain relief and other physical needs treatment. Nurses in palliative care are an important component and a link between patients, their family, caregivers, and the medical services. Nurses in palliative care faces considerable professional, technical, and personal challenges related to providing palliative care at patients' home. In order to understand the psychological burden related to home-based care of dying patients for palliative care nurses, I conducted a semi-structured, in-depth individual interviews with 15 palliative care nurses from 3 different palliative care services in the country. For the interviews analysis, I used an interpretative thematic analysis and particularly the interpretive phenomenological analysis approach, meaning that I looked at for the both manifest and latent content of the experiences that nurses shared in regard to work-related stress, and then complementing their perceptions and declaration with research and evidence that is conducted in this particular topic. From the analysis, 3 main components or themes came up. One of them was related to good teamwork, where work-related roles, expectation and results were well defined from both treatment staff and patients and family members, and team approach to patient treatment was regularly carried out and planned treatment regularly revised. Difficulties related to working hours, geographical coverage of patients' home, daily transportation to patients' houses, and workflow was other components that influence nurses' stress. Nurses who provided psychological support to their patients and family members and who were engaging with communicating with them outside the medical intervention reported that didn't feel stressed out due to providing this psychological support. They felt that their work was meaningful in assisting their patient during this critical phase and patient's life. Providing physical and pain relief for the patient who is dying in a family environment in the presence of the loved one was considered a satisfactory professional task for the nurses, which give them motivation to work in this specific field and not feel psychological burden by it. On the other hand, a few senior palliative care nurses who had more than 15 years of experience on palliative care
Dr. Indi,
reported. Yeah.
Sorry to interrupt, but the 3 minutes for the presentation are over. We can begin with question and answer.
Okay.
Ma'am, how will you help those nurses who feel stressed in treating with terminally ill patients?
As I mentioned, this is the first study conducted in the country about the psychological aspect of nurses in total. So there's not a previous study done in the country about the psychological burden of nursing care for all the disciplines. So this is the first one which is focused specifically with palliative care nursing. And as I mentioned, there are many aspects related to psychological psychological stress of the nursing regarding to many aspects, but most of them they referred that one of the way for them to let's say take off the stress, the daily stress related to work, is mainly to communicate with their peers and their colleagues particularly, and spend some non-work related time together. So spending some non-work related time together with the staff, talking about different things, particularly things they liked or shared, was considered as a good positive aspect for let's say manage stress. On the other hand, psychologists didn't understand what were the let's say the triggers that could trigger them to and be aware of the situation that could trigger their stress and in order to manage. So they didn't had any training or professional skills in order to identify those triggers and how to manage them on individual level. So for me, this could be let's say how to say recommendations for which are part of the conclusions as well. So helping the nurses to understand what are the symptoms and the signs, and particularly the triggers related to their specific work and daily work, and then how to manage those daily stresses and those triggers in order not to overburden themselves. As for the nurses, for example, who had much more years working in the palliative care, and they explicitly said that they actually not only feel stressed, but they were burdened by this workflow and the experience they had with patients, which because most of the nurses would provide treatment, and they would meet the patient during their terminal phases that would last like weeks or even 2 or 3 months. So this was a really short period where they would lose their patient constantly, and which was a burden for those senior palliative care nurses. And so one way they found it in order to still work there but not be so frequent was
again,
to
interrupt,
do more
ma'am.
technical work.
Sorry to interrupt, ma'am. Time is over. Time is over.
Dr. Priyashi, thank you. Thanks a lot.
Most welcome, sir. Thank you, sir. And thank you, ma'am, for being with us and giving your precious time. Thank you so much.
Thank you. Thank you.
So now we are beginning with the next session. So, Dr. Tushti, ma'am, are you here?
Yes, I am.
Dr. Apeksha, ma'am?
Yes, I'm present.
Thank you so much, ma'am. Thank you. So on behalf of the organizing committee, I welcome you both. And Dr. Toshti is the Associate Professor, Department of Social Work at Dr. B.R. Ambedkar College, University of Delhi, India. Also associated as the senior lecturer with Cicely Saunders Institute, King's College, London. Dr. Apeksha Modi ma'am is the consultant in pain and palliative care at Bharat Cancer Hospital and Research Center, Surat. Welcome both of you, ma'am. We can start with the session.
Thank you so much.
The participant D. Bhupati. Are you here? D. Bhupati? Okay, Nimish Singh. Dr. Pratyasa?
Yes, ma'am, I'm here.
Okay, Nimish Singh, ma'am is here. Ma'am, please start with your presentation. Share your screen.
Okay, just a second.
I would like to repeat the instructions for all of you who have joined recently. Participants are given total 6 minutes, 3 minutes for the presentation of the poster and 3 minutes for the question and answer which judges will ask you.
Okay, ma'am.
Okay. So if it goes beyond 6 minutes, I will interrupt.
Ma'am, is my screen visible?
Yes, your screen is visible. Please go ahead.
Okay, just a second. Okay, ma'am. Very good evening to everyone. My presentation is on the preoperative symptom burden among cancer patients, a prospective observational study. Patients experience a multitude of symptoms which can negatively impact their quality of life and function, and it increases the caregiver burden. So one of the most critical aspects of symptom management is the routine symptom assessment and reassessment, which allows symptoms to be recognized, diagnosed, treated, and monitored over time. So our knowledge of the types of symptoms affecting the patients and their effective management can go a long way in not only improving the outcome of patients, but also improving their quality of life. So the aim of our study was to assess the presence and severity of various symptoms among the cancer patients presenting at the PSC clinic. So our method, how we went about it was that data from adult patients who were more than 18 years of age with known or suspected diagnosis of cancer, who presented to the pre-anesthesia checkup clinics, was collected. Are self-reported or those patients who could not report it by themselves because of their educational background or any other problem, their caregiver or caregiver assisted assessment of symptoms was done using Edmonton Symptom Assessment Scale, that is the ESAS scale. This was done at the time of the patient's presentation to the PSC clinic by an independent physician or nurse who was unaware of the nature of the study. So our results were that there was the average age of patients who presented with cancer to the PSC clinic was about 51.9 years, out of which 69.9% were females. And genitourinary cancers were the most common cancers among females. 46% of patients had moderate to severe pain symptoms with a mean pain score of 3.6 on the ESAS scale. The mean scores reported by patients for anxiety were also 3.6. So these two scores were the highest, that is the pain scores and the anxiety scores. The ESAS scores were were similar, that is 3.6. The ESAS scores were highest in terms of well-being and restriction of movement, that is 4.38 each. Nausea and shortness of breath were the least important symptoms reported by the patients who presented to us. So to conclude, we found a very high symptom burden among cancer patients.
Dr. Nimish?
Yes, ma'am.
Sorry to interrupt, ma'am. The time is over for the presentation.
Okay.
Ma'am, please begin with the question and answer. Tushti ma'am and Apeksha ma'am.
Ma'am, please go ahead. Tushti ma'am.
Okay.
Thank you. Thank you, Dr. Nimish. My question is, you did not tell us what was your sample size, one. And my second question is that you have used Edmonton scale. Do you think that this scale, which is yet not been adapted to Indian setting, is wise to use?
Ma'am, sample size, we chose to take a convenient sample size of the number of patients any number of patients who were presenting to the PSC clinic. So we had decided that we take a sample size of 100. Ma'am, and the ESA scale, this is what we noticed, that the Indian population, they are not the problem we noticed was they were not aware of all the like they were not able to anxiety, depression. They were not aware of such problem that such problems can also be associated with cancers. They were only worried about the functional incapacitance, which like if they presented they present us very late. So they present only when they start having a disability or they're unable to carry out their usual work. So anxiety, it becomes secondary for them.
Okay, thank you for my answer, and over to Dr. Apeksha.
So from your study, do you think palliative care physician should be consulted from day one?
Yes, ma'am, definitely. Palliative, when as soon as a cancer is suspected or it has been diagnosed, palliative care physicians should be they should be consulted, because patients in India, especially in Indian setting, that's what it was very difficult to get answers out of them, to make them to ask that do they actually have anxiety, do they actually have depression, do they have a feeling of well-being, how much is the pain. So so I think they
in
should
your
be.
hospital this is being followed. Are they being consulted?
This is the whole idea of carrying out this study, carrying out this ESA symptom study, is that we create such a program, or we create such a protocol that any patient who comes with a cancer should also go through the palliative care clinic for a very wholesome management.
Nice, good presentation.
Thank you, ma'am.
Priyasi?
Yes, ma'am. Ma'am, can we go ahead with the next participant?
Yes.
Dr. Pratyasa.
Hello, I'm there. I'm Dr. Pratyasha. Can I start? Splendid evening to one and all. This is a basic effort to present a study done as per assessment of depression and anxiety in patients attending palliative medicine outdoor patient department. As we know, prevalence of depression in cancer patients ranges from 4.5 to 58%, and even anxiety disorders are very commonly detected in cancer patients. However, there is often a high correlation between patients having depression and anxiety in cancer patients. Many cancer patients also experience mental health problems that are clinically significant, and they have to be pharmacologically as well as psychologically treated. So in this study, we have used a well-known tool, that is Hospital Anxiety Depression Scale, which has two parts: HADS-A, that is for anxiety, and HADS-D for depression. There were 7 questions each in HADS-A and HADS-D, with the score ranging from 0 to 3 for each question. So as per the rating, 0 to 7 was rated as normal, 8 to 10 was rated as borderline, 11 to 21 was rated as a case of anxiety or depression accordingly. Now, the aim and objective of the study was basically to assess depression and anxiety in patients in attending the palliative medicine OPD. So the secondary objectives were to find a correlation between depression and anxiety. And the secondary objective was to assess the correlation between the primary disease diagnosis as well as depression and anxiety. So the including criteria was all the patients who attended palliative medicine outpatient department, and the excluding criteria was who refused to take part in the study, or patients who had cognitive impairment, or patients who were unable to comprehend the questionnaire. In this, we have taken 50 patients who were included in our study, and they had diagnosed cases of various malignancies, like that ranged from CA ovary, multiple myeloma, CA breast, CA lungs. So we didn't do it in a particular group, rather we took patients who had different malignancies. All of them had, however, cancers. And the age range of the study was from 20 to 72 years. And we found out that the prevalence of depression in our sample size was 30%, while that of anxiety was 14%. We found that borderline cases of anxiety and depression were respectively 34% and 28%. We noted the highest value of both depression and anxiety in a patient of multiple myeloma, while the least values were seen in a patient of carcinoma cervix. We found a correlation coefficient which is close to the coefficient of determination, which we found R square, which was positive, and it was 0.6, which showed that anxiety and depression correlated among each other. We also found correlation between the ECOG performance status, which designated the patients as per their performance status, and we compared that with the values of anxiety and depression. So as we can see, we had 50 patients. There were 25 male and 25 female. The average age was 47 years. These were the various diagnoses that we had taken. And we can see that anxiety and depression, they were quite much prevalent in the patients, and we also see that they correlated with each other as we see the scatter diagram. Also the figure 6, which shows the ECOG performance status. We had PS1 patients as 16, PS2 patients were 19, PS3 patients were 12, and PS4 patients were 3. So we saw that in PS4 patients who were almost bedridden patients, in them the scores of anxiety and depression were pretty much high. So coming on to the discussion, the study has been done to include 2 core psychiatric disorders which are quite prevalent in the patients of chronic diseases. And as we see in this, all the subjects had cancer. HATS, as we had discussed earlier, is a well-accepted study tool for assessment of depression and anxiety. And as we have discussed the results were pretty much not surprising. So at last, I would like to say, being palliative care physicians, we are responsible for ensuring good quality.
Dr. Pratyasha?
Yeah.
Ma'am, the time is over for the presentation. Please switch to the question and answer. Ma'am, please go ahead.
Thank you, Dr. Pratyasha. My question is, one, which version of HATS did you use? Was it the Hindi validated version, or did you use the English version? This is one. And second question is, you have a particular sample size, and I would like to understand how did you determine that this sample is good enough for you to get the statistical findings which are within the particular confidence interval range?
Yes, ma'am. Ma'am, I've included the English version only, and I translated them to the patients as the Hindi version was not available. But I've seen that this HATS has been done in Indian setup also. In NIMHANS, there was a study done in which HATS was used in the Indian patients, and they had significant results. Ma'am, considering about the sample size, we had actually decided to take all the patients who would come to the OPD, and since we had started the study a month before, we could take only 50 patients who comprehended well and took part in the study, ma'am.
If Dr. Apeksha may allow me just to have one more quick question. So you said that the depression scores were higher than the anxiety scores, which was not surprising to you, but it came as a surprise to me that the patients had less of anxiety than more of depression, and it has come more in case of multiple myeloma. Is there any previous evidence which suggests that the cases of multiple myeloma are high on depression scales?
Ma'am, what I correlated was that multiple myeloma patients often are diagnosed late, and in our setup we see many patients who present with spinal cord compression, like they get paralyzed, they get paraplegia, which probably adds to the psychiatric or psychological burden that they have. So I
Thank
felt
you.
that
Thank you. Forward to Dr. Piksha.
What are the add-on messages from your study?
Ma'am, the add-on message is that since we are responsible for ensuring good quality of life, and depression and anxiety form an important determinant of quality of life, we should frequently assess the prevalence of depression and anxiety in patient, and we should take adequate measures, both psychological counseling as well as if the patient comes as a case of depression or anxiety, he or she should be treated pharmacologically as well, as psychological counseling does not always help. So we should take a psychiatrist's help, and we should start the pharmacological treatment as well, so that we can ensure good quality of life in our patients.
Thank you. Thank you so much.
Thank you, ma'am.
Can we move forward?
Yes.
Participant? Can you hear me?
Yes, yes.
Ma'am, can we go ahead with the next participant? Dr. A. Latha.
Yes, joining.
Yes, ma'am.
Is my slide visible?
Yes, your slide is visible.
Okay, I'll start.
Yes, ma'am, please start.
During the holistic palliative care of patients, psychosocial issues also play a vital role in increasing the quality of life of our patients. In this context, I wanted to present 2 case studies where psychosocial issues were more than physical issues. The first patient is Mr. X, a 70 years old person with a CA lung metastasis, came to a hospital and got admitted. And when we are coming across his family history, and his family was separated for 30 years. There was a misunderstanding between husband and wife, and he was living alone. And he had the psychosocial concerns, like he did not meet his second daughter for a long period, and feeling guilty that he has not done anything to his daughter, even though he has enough money. And he wanted to see his wife after 30 years of separation. Then the palliative care team contacted his wife and apprised his situation. Initially, there were a lot of reluctation from her side. She didn't want to come, and the palliative care team did not give up, and continuous request. And she and her daughter came and met with her father, and they talked to them. They ventilated a lot of their issues, and then he was also able to see his daughter. The one more issue he wanted to see is that he wanted to see his younger daughter's marriage, but it was not possible because within 3 days of their meeting, he lost his life. The next case I would like to explain to you is Mrs. X with hypopharynx cancer came to a palliative care OPD asking for euthanasia. And she had hypopharynx, and she was on PEG tube for feeding. And both she was taken care by her daughter who was studying 10th standard, and she became a school dropout because no one was there to look after her mother, and both were looking so depressed. So then the palliative care team made arrangements for her daughter's schooling, and she was on palliative tracheostomy. The patient died peacefully after 2 months of palliative care, and later her daughter was completed her +2 education. The same patient, after sorting out her issues, daughter's schooling and all those issues, and she was asking us for a Mysore Pak. So we also able to provide. So what I wanted to tell you is that not when we are carrying a patient, only physical issues we take care, but we need to pay more attention for resolving the psychosocial issues. The relief and suffering is a central goal for palliative care. Achievement of this goal can be difficult if psychosocial
Ma'am, sorry to interrupt.
not addressed.
Can you hear me?
Yes, ma'am.
Ma'am, the time is up for the
Yeah,
presentation.
completed. I have finished.
Okay, ma'am. Please, ma'am, please go ahead with the question and answers.
Thank you. Thank you so much, Dr. Ilata.
Yes, ma'am.
My first question is about, yeah. So my first question is that you have talked about the terminology of euthanasia with regard to the case number 2.
Yes,
and
ma'am.
since recently our country has also enacted this policy, how would you relate the cases where the patients are coming to OPDs and asking for this right to the practice level? This is one, if you can reflect a quick glance on this. And second is, ma'am, you have bring out two different kind of practices with reference to your two cases. What
Yes, ma'am.
kind of theoretical perspective of putting psychosocial interventions to different cases did you bring so that the followers, the coming budding scientists, can also take up into their own approach in future?
Ma'am, I wanted to, I brought this cases to say that there are, every patient has a psychosocial issues more than their physical issues. But this first patient, the second patient, when she came, no, she came with a brassy cough. Nobody could stay near her. That much was, the coughing was there. And after, but she came, asked us about euthanasia, like the question you asked is how to go about it. So we explained her that it is this case when we took care in 2015, I think 15 or 16, we were in Pondicherry. So that time we explained her that first we will sort out her issues, then we will discuss later on. Like that we went about it, ma'am.
Any response to my second question?
Second question, ma'am, can you?
Okay. So I wanted to know, since we have already existing theoretical perspectives which take us to our guided psychosocial intervention. So the kind of interventions you have already undertaken with these cases, can you relate any of the existing theoretical perspective to your intervention so that same can be later transferred to the budding scientist?
I'm not sure, ma'am.
Never mind. Over to Dr. Apeksha.
Hello, ma'am.
Yes, ma'am.
So what conclusion do you draw from your review of your two case studies?
Ma'am,
conclusions.
This one, we need to pay more attention for psychosocial.
Your voice is not clear.
Cannot be improved. It is part of one of the very
Hello. Yes, you are not audible.
Hello.
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 Hello. Ma'am, the time is over for the question and answer. Can you hear me, ma'am?
Yeah.
So the next participant is Dr. Tanvi Shinde.
Hello.
Dr. Tanvi.
Hello, ma'am. Can you? Hello.
Ma'am, Dr. Tanvi Shinde is going to present the poster next.
Okay.
The time for Dr. A. Latha is over.
Okay.
Yes, ma'am. Dr. Tanvi, please start.
Can you hear me? Hello? Can you hear me?
Okay. My name is Dr. Tanvi Shinde. My topic is anxiety and depression in adult advanced cancer patient admitted in respite palliative care center. We have our
Sorry,
hospital
ma'am,
respite.
your poster is not showing.
Sorry,
Your poster is not visible.
poster is not visible.
Yeah. First, you open your
Uh,
poster.
yeah. I have shared the screen.
Screen is visual, but poster is not visual. Please open your PPT.
One sec, I'll just check. It's a single slide poster is there. I don't know.
I am sharing my screen.
Okay. Not this one. Yes, sir.
Please start.
Yeah. So my poster name is Anxiety Depression in Respite Palliative Care Center. These are the adult advanced cancer patient. Basically, our hospital Respite Palliative Care is the first of its in India. Patients who are here in respite care, we admit patient for a brief period just to symptom control, psychosocial support, and empowerment of caregivers. Our study is focused on the presence and change in the anxiety depression in advanced cancer patient from admission to discharge. So it's a retrospective observational analysis. We have a standard protocol for each and every patient. We record our GAD 7 and PHQ 9 for anxiety and depression. We have medical records of admitted patients for at least 7 days at a respite palliative care unit for 3 months, that is August 1 to October 30, 2021. We have analyzed all these records, and we studied for the longitudinal changes and influencing factors were determined using the relevant statistical analysis. During this period, we admitted 57 adult patients. Out of that, 30 patients met the eligibility criteria. The median duration of stay in the respite care was 9 days. If you see demographic data, age below 60 was 23 patients, above 60 was 7 patients, male 7 patients were admitted, female 23 patients were admitted. Number of days less than 9 days, 18 patients were stayed in the respite facility. Greater than 9 days, 12 patients were there. So type of cancer, hematological cancer, 1 patient, and solid tumors, 29 patients. Approach like early palliative care, there were 8 patients were admitted, and best supportive care, 22 patients were admitted. Descriptive analysis, when we look at the GAD score, there were on admission to discharge, mild category, 7 patients were admitted. On discharge, only 7 patients, the same number was there. In the moderate category, there were 7 patients on admission and 11 at the on discharge. Moderately severe category, there were 12 patients on,
Hello?
and on discharge, 9 patients. Yes?
Ma'am, can you hear me?
Yeah.
Ma'am, 3 minutes for the presentation are over. We can go ahead with the question and answer.
Dr. Apeksha, please take over first.
My question is, are there any comparison study with the home-based care?
No, madam, this is particular single center study. We have a respite palliative care. The patient who are admitted at respite palliative care, only that patients have been taken for this particular study.
Okay, you have not compared it with home-based care?
No, ma'am.
Okay. Thank you.
Thank you, Dr. Tanvi. I am very curious to know, you said that this is an observational case study, but later on you said that the medical records of these patients were screened. So is it, do we understand that when the patients were discharged, then this data was collected from their records file? Or do we understand that the patients were there at the time of your study, you take consent from the patient and then the data was gathered?
No, ma'am. I mean, we have a standard protocol to take a GAD and PHQ on admission on discharge for all the patients. This was after patient discharge, we have collected the data.
Okay, so which means this is not the observational studies, this is secondary data analysis.
Oh, yeah.
Because the data was already collected for a particular purpose.
Yeah, means some patients were end of the, there were like, when we started, it was 1 month, those were discharged, and there were some patients who were admitted and then we collected. So it is 3 months time we have started.
Okay, and you have used 2 different questionnaires. I would like to understand the logic of using these 2 questionnaires, and were they available in Hindi language, the Indian language, or you use the foreign language questionnaires?
GAD and PHQ, ma'am, using this particular is that they both these tools are available in our Hindi and Marathi languages, ma'am.
So which version did you use? Did you use the Marathi one?
We use all the 3 versions. Whoever patient, like Marathi patient, we use Marathi version. So it was like that. For Hindi, we use Hindi.
Okay, thank you. Thank you.
Okay. Thank you, ma'am.
Ma'am, can we begin with the next participant? Is it okay? So the next participant is Dr. Manoj Kamal. Dr. Manoj? Dr. Manoj, are you here? I think he is not here. Next participant, Dr. Amit Jain. Dr. Amit? Dr. Sri Harika Prakash. Dr. Sri Harika. Okay, so can we have Dr. Nidhi Adarshi?
Yes, ma'am.
Dr. Nidhi?
Yes, ma'am.
Ma'am, please go ahead with your presentation. Share your screen.
Am I audible? Am I audible? Hello, this is
Dr. Sri Harika here?
Yes, yes.
Yes, ma'am. Please go ahead.
Just a second, I will just share my screen.
Okay.
There is a technical problem. Can you please upload my poster?
Sure, ma'am. Sure.
It's uploading. It's uploading. Yeah.
Is my poster Sri Harika?
Yes. Can I start?
Please begin.
Good evening, everyone. Myself, Sri Harika Jutta, and I'm a professional therapist from Sukunavya Palliative Care Center, Mumbai, India. There are various non-cancerous conditions in palliative care that demand rehabilitation. Considering the holistic approach of palliative care, occupational therapy involves identifying and providing a patient-centered and goal-oriented approach to obtain a satisfactory quality of life in spite of the prognosis. So our aim of the study was to assess physical and functional limitations and provide various adjunctive, occupational, adaptive, and adjunctive therapies to intervene and thereby evaluate the results, and also to describe the socioeconomic and architectural barriers that hinder adherence to the rehabilitation. The study included 28 patients and their caregivers from a single unit urban setup. To evaluate the patient, I have used a paper-based version of UK Functional Independence Measure and Functional Assessment Measure Scale, that is FEMPAM. As we can see in the table 1, the FEMPAM scale includes 7 components like self-care activities, sphincter control, mobility, locomotion, communication, and psychosocial components. The scale was assessed during the admission as well as during the discharge to see the change in the patients. And also demographic, a socioeconomic assessment was taken by the medical social worker on the day of admission that included various demographic characteristics like gender, the employment of the patient, and also the residency of the patient, whether the sanitation is present at home, whether the patient has family support, and if the patient requires any assistive device. So depending on the data collected on the admission, the FEMPAM scores and the demographic data, an interventional program was made for the patient. So to train the patient for physical, functional, and also to train the caregivers, like after discharge, how they are going to carry out their daily activities at home. So, and after that, during the discharge, again, the FIMPAM scale was taken. This scale ranked from 1 to 7. Like 1 is total dependence and 7 is complete independence. So the change in the UK FIMPAM scores during admission and during discharge, the most significant changes were seen in communication and the least was seen in self-care activities. So like to conclude, like whenever we plan an interventional program for the patients, we should always take the consideration of their socioeconomic status and also from where they are belonging, so that like to adhere to the rehabilitation at their home level.
Should we go on with the questions?
Yes.
Okay. So thank you, Dr. Shri Harika. You said that this study consists of patient and caregiver diets, but I'm still wondering the purpose of taking caregivers, one, and second, we do not see any information about the caregivers in your poster. So I would like you to just reflect on that. And another thing which I would like to understand, that you are saying about occupational therapy which might have been administered or might have been given to the patients for the time being they were admitted, because you are calculating pre and post scores. So we would like to understand what therapeutic module did you deliver and what it consists of.
The therapy consists of like physical training, depending on on their range of motion, the muscle strength, and also the functional, depending upon their ADL activities that include their self-care, and in self-care activities like grooming, dressing of the upper and lower limb dressing, their bowel and bladder sphincter control training. And also their cognitive and psychosocial functioning, like cognitive, which includes memory,
and what about my first question?
For the first question, like caregiver training, by training the patient, we also train the caregiver. That helps like for transfer training of the patient, like how to handle the patient by transferring from bed to wheelchair, because a proper transfer is required to avoid any kind of
Okay, so I understand they were not part of your sample, they were part of your therapy. Okay, over to you, Dr. Apeksha, please.
Actually, there is inconsistent understanding of the contribution of occupational therapists in palliative care. So what do you say on this?
Sorry, I didn't get your question.
So what are the recommendations for out of your study actually?
Like every patient requires a proper rehabilitation at every stage of the diagnosis.
And it was in non-cancer patients, and in cancer patients, what is the role of occupational therapist?
The role of occupational therapist in cancer.
Yeah, cancer patients.
In cancer, like for the pain management, like by providing relaxation techniques to the patient, and also like training the patient for the aerial activities.
Okay, thank you. Thank you.
Can we have the next participant? Dr. Nidhi Adarshi.
Yes, ma'am.
Dr. Nidhi.
Yes, ma'am. Yes, ma'am. Hello, ma'am, can I start?
Dr. Sneha or Dr. Nidhi?
Dr. Nidhi Adarshi. Ma'am, can I start the presentation?
Ma'am, please start your presentation.
Okay. You matter because you are you, and you matters to the end of your life. A very good evening to all the respected panel members presented here. Here I am presenting a case where a 40-year male patient came to our department of the palliative care clinic with a chief complaint of food lodgement in the left side of the palate. Patient gives the history of post-operative squamous cell carcinoma on the left side of the buccal mucosa, followed by the partial hemimaxillectomy and the partial hemimandibulectomy. And the patient was mainly concerned with the defect present on the palate. Patient was emotionally unstable. He was mentally disturbed, and because of which the patient, the quality of life of a patient was hampered. So to treat the orodental communication, we have fabricated a palatal obturator as an interim prosthesis. The patient was very happy. He was well satisfied and well adapted with this prosthesis. And later on, we have convinced the patient for the implant-supported fixed prosthesis. This is the image where we have fabricated. This is 3D model of a patient. And this is a 3D model where we have placed the 2 implants in the zygoma and 1 implant in the pterygoid plates. And this is a 3D image, a 3D model of a patient on which we have planned the mock surgery. And finally, we have given a patient fixed prosthesis, implant prosthesis. This is a magnetic abutment implant. So by this, we have improved the patient's quality of life. Now the patient can eat the food properly. And through this presentation, I would like to conclude that there is an end to cure, but no end to care. Thank you, ma'am.
Thank you, Dr. Nidhi. The implant which you have given to the patient, is it a new device which you have invented specifically for this patient, or this is already available?
Ma'am, this was already available.
And this is not routinely used in practice for patients in.
Ma'am, this is an implant which we use routinely in a patient.
Yeah. So that's why I'm keen to understand that what's the novelty behind this study then?
Ma'am, we have rehabilitated the jaw that was completely removed during the surgery, and the patient was very conscious because of that. He was very worried about the defect which was present on the palate. So we have just improved the quality of life of a patient by rehabilitating the processes.
Okay. And the patient was the patient measured at different intervals to monitor the quality of life, or this is the responses from the patient through which you could understand?
Yes, ma'am. We have just taken the responses from the patient. Earlier, the patient was very emotionally depressed. He was, when he came, he was very worried that what will happen to the later age. Then we have given the palatal obturator, and he was very happy with that processes. And later on, we have convinced the patient for that permanent processes, that is implant supported processes, and later on he convinced with that treatment, and he have then after that we have planned the mock surgery on the patient.
Okay, so I just wanted to understand it more scientific language. When you say that the patient was very happy, patient was content, so these responses from the patient, were they being measured on some scientific scale, so they are coming up as the thematic or the expressions of the patients?
Ma'am, we have carried out by the patient's response.
Okay, okay. Over to you, Dr. Apeksha.
Is this done routinely in your clinic, or this was the first case?
Ma'am, it is done routinely. We have a palliative care department also in our department.
Okay, and what about in palliative patients? This is done in curative patients or palliative also?
Ma'am, we do all the patient, all the palliative patient, such as in case of we have also treated the MICOR patient or the malignancy post-operated malignancy patient.
Okay, thank you.
Thank you, ma'am.
Dr. Manoj Kamal, are you here?
Hello.
Dr. Manoj
Hello.
Kamal?
This is
Madam, Mamta is presenting instead of Dr. Manoj. Mamta Parigar is presenting.
Okay, okay. Start with it.
Would you please share the screen?
Yes, madam. Dr. Mamta is presenting on behalf of me.
Okay, okay, okay. Please share your screen.
Yeah. Can you share it for me?
Start with it.
Would you please?
Okay, the technical team, can you hear?
Yes, I am sharing. Please wait.
Yes, sir. Please share.
Okay.
Please start.
Not this, not this.
That is from Nav Chetana. Actually, due to some problem, I cannot share that poster.
This is not.
Nav Chetana poster.
Ma'am, sir, we are running out of time, so we have to start our next session. So, can you please?
Technical team, please share Dr. Manoj.
Technical team, poster 42.
Okay, just wait.
Yeah.
Sorry, we don't have poster 42.
Dr. Manoj, you can share your poster. We, Vinod sir, can you please check of Dr. Manoj Kamal one more time?
I can check, but we have not received Dr. Manoj poster 42.
Dr. Manoj,
He did not share with us. So please start.
Dr. Manoj, have you shared your poster with us? Hello, Dr. Manoj. Dr. Mamta.
Yeah, I am here, but actually I cannot share that poster. If you,
Ma'am, have you shared your poster with our team?
Not share. So I request you please start the other session also.
Sorry, ma'am, we have to go ahead with the next session. If we don't have your poster, you have not mailed us.
Okay.
Sorry for the inconvenience. So, Dr. Tushti ma'am and Dr. Apeksha ma'am. Ma'am, can you hear me?
Yes, yes, please go on.
Thank you, ma'am, for being with us and judging our sessions. So, on behalf of our organizing committee, I thank you, both of you. Ma'am, please share your results and to my mail or my WhatsApp.
Okay.
Okay,
Thank you.
thank you so much,
So much
ma'am.
for
Thank
having
you,
me on the
Apeksha,
board.
ma'am.
Bye-bye.
Yes,
Thank
Thank
you.
you. Bye-bye. Thank you.
okay. So beginning with the next session, now I would like to invite Dr. Richa Madhvi, Associate Professor, Department of Radiation Oncology and Pain and Palliative Care, State Cancer Institute, Indira Gandhi Institute of Medical Sciences, Patna. Welcome, ma'am. On behalf of our organizing committee, IAPCON 2022. So the next judge for our session is Dr. Sunil Kumar, Additional Director of Pallium India's Trivandrum Institute of Palliative Sciences, also a national faculty in palliative medicine. Sir, Dr. Sunil, sir, are you here?
Yeah, good evening, Presi. I am here.
Good evening, ma'am. Dr. Sunil? Okay. Okay. Ma'am, can you give me just 2 minutes so that I can connect to sir? Thank you so much. Am I audible?
Yes, Presi.
Okay, ma'am, Dr. Sunil is joining us soon.
Hello.
Yes, ma'am.
Yeah.
Ma'am, Dr. Sunil is joining us. So Sunil sir have joined. So once again, I welcome you from the organizing on behalf of organizing committee of IAPCON 2022, Dr. Richa Madhvi ma'am and Dr. Sunil Kumar sir. Dr. Richa ma'am is Associate Professor, Department of Radiation Oncology and Palliative Care, State Cancer Institute, Indira Gandhi Institute of Medical Sciences, Patna. And Dr. Sunil is the Additional Director of Pallium India's Trivandrum Institute of Palliative Sciences, also a National Faculty at Palliative Medicine. I welcome you both. We can begin with the session.
Good evening, Tracy. It's big congratulations that you are organizing event very timely. So hope we will stand on this.
Thank you so much, ma'am. Yes, ma'am. Together we can.
Thank
So
you. Please.
participant.
Yeah, we can start.
Good evening, sir.
Yeah. Good day. Please start.
Okay. So Divya ma'am, are you here?
Yes, I'm here.
Yes, ma'am. Please share your screen and start presenting.
Oh.
So give me 1 minute just. I would like to repeat the instructions for the participants and for the judges both. So there will be total 6 minutes allocated. 3 minutes for the poster presentation will be given to the participant and 3 minutes for the question and answer round. Questions will be asked by the judges, Dr. Sunil and Dr. Richa.
Oh.
Over to you, Divya. Please start.
Yeah, thank you. Is my screen visible?
Yes.
Yes, your screen is visible.
Thank you. So, good evening, all. Myself, Divya. I work as a counselor in Karnashraya, Bangalore Hospice Trust, Bangalore. So, today, my poster presentation topic is my study was under diversional activities at hospice, helping terminally ill patients to cope with their overall well-being in palliative care setup. So, just a brief of the background. In hospice setting, the role of holistic palliative care delivered to relieve suffering can also provide in form of diversional activities and diversional therapies. Previous research evidence demonstrated that individuals with cancer who participate in the creative arts receive an opportunity to learn more about themselves, regain a sense of control, and develop stronger social bonds. So my aim of the study was to understand the patient experiences and coping after involving in a diversional activities while in hospice care. So the material and the method I was used was I conducted a qualitative study which used a semi-structured interview method with 5 patients, that to advanced cancer patients. The interview scheduled was based on the themes of healing, positive destruction, branding, disinstallation, distressor, and way of finding. So overall, with all these things, the conclusion what I got from the result was the diversional activities in form of music, creative art, craft, board games, and comedy shows which were organized for the patients in hospice care had a positive benefits and positive outcomes too. The outcomes were in the form of improved coping, reduction in distress, improved quality of interactions, which helped them engage meaningfully when living with their life-limiting cancer. And even there were a lot of outcomes which came from the patients, and the patient responses are also noted in my results. So most of my patients told me that the diversional activities should be the part of hospice care. It should be a part of the palliative care also. That was the outcome I found from this study. Thank you.
Thank you, Divya.
Thank you.
So, just want to ask you, how long or how many sessions did you do with these patients on music therapy or some other distressing methods or something like that?
So I took 5 to 6 sessions, sir. 5 to 6 sessions I cooperated and took this survey.
How long each session lasted for?
Each session lasts for 40 to 45 minutes.
Okay. So how did you record? Was there a scale to record the previous
Yes,
score
sir.
and then? Yeah, what was that scale?
Yeah, so I had formed 5 questions taking from these 3 like 5 themes which I have made. These themes are taken from other Miller, MF and Karwitz in 2019. They had done a research from the nursing side. So that things I have taken it for a counselors, and the same thing I have arranged 6 questions in that, and I interviewed the patient before and after, and then from that I got it the answers, like what are the responses, and I found the results.
Thank you, Dr. Richa.
Thank you.
Yeah, the same. What questionnaire tool or what assessment tool you have used in this session?
The team was not my own this thing, madam. I have taken from Karwitz and 2013, Miller, MF and Karwitz K has done a survey, that too from the nursing side. The same theme I have taken and the same questionnaire I have taken, and I did it for my patients. General well-being questionnaires. That's
okay.
it. Good. Yeah. Thank you.
We can move on to the next candidate.
So the next participant is Dr. MS BG. Dr. MS BG.
Shall I start my screen sharing?
Yes, ma'am. Yes, please.
Can you see my screen now?
Yes,
Preeti.
Yeah. So my topic for my poster was returning to work after curative cancer therapy and the barriers associated with it. So returning to work after cancer therapy is a very challenging thing for our survivors after the completion of cancer treatment, because there are several barriers to this. There are multiple studies on return to work internationally, but very few. In fact, we can say there are no studies actually from India on this regard. That is the intention for my study. And the objective of my study was to estimate the proportion of individuals returning to work after completion of the cancer treatment, to assess the various barriers which are associated in preventing them from returning to work, and whether there was any association between the returning to work with the other demographic characteristics. So after the Institutional Review Board and the Ethical Committee clearance, we did this prospective cross-section study starting in March 2021. With the inclusion criteria of survivors between 20 and 65 years of age, those who were employed prior to the diagnosis of cancer, and they had completed at least 1 year of follow-up following the anti-cancer treatment. And they were all enrolled after getting the informed consent, and they were interviewed by the investigators. So a result we found was that there were 114 survivors who participated in the study with a median age of 50.4 years. And more than 3/4 of them were males. And they were all in, most of them were in stage 1 or 2 of the disease. And the most common malignancy was head and neck malignancy, 57%, followed by hematological malignancies. And we found that around 55% of our survivors, they returned to work after completion of their treatment. And the mean satisfaction score in working for them was about 7.6, a range of 3 to 10 now. And around small percentage, it was 13% of our survivors, they had to change their occupation following their cancer treatment. And the barriers which we found for the return to work, the most common was the physical barrier in 56% of the survivors, and a combined physical and psychological barrier in 21.5%. And there were statistically significant association of this return to work with gender. That is, we found that the male gender and the absence of another earning member in the family and age less than 50 years. These were all related to the patients returning back to their work. So the conclusion that we found was that the overall rate of return to work was 55%, and this was comparable to the other studies from Asia. That is, between 15 to 65 was the international level. And so there is a need to address the physical and psychological barrier which our survivors face in order to promptly improve the chance of them returning to work. So what is the way forward for this? We need to have a good occupational counseling, pre and post occupational counseling. psychosocial support, vocational rehabilitation. In fact, in our institute, we are planning to start a big department. My director is going to start a department called rehabilitative oncology, so which will include all these aspects in that. Now, the limitation of my study was that the recruitment was slow because of this COVID situation. So though I had started on March 2021, we could get only 114 patients. But this is an ongoing study, and definitely I'll be collecting more patients.
Ma'am, the presentation time is over. The question answers are beginning.
Dr.
Yes, Dr. Biji, there are different cancer and different physical limitations. So what are the physical limitations you have used for all kind of cancer?
What are they, madam? I couldn't get it. What are the physical?
There are different cancer, there are different kind of physical limitations. So which kind of physical barrier you have taken in your study?
Physical barrier in the sense is that anything like physical symptoms, it could be the symptoms which they're saying about any breathlessness or cough or movement related thing, or because of pain they have, what is preventing them from going. That was a physical thing which we had taken into account. They're symptomatic physical problems.
Okay, so post-cancer patient also have some rehabilitation problems. So do you consider that also, or just related to pain and physical current problems only related?
No, all problems, any problem they have, whether it is because of their movement, they are not able to move because of that, or because of any fibrosis of thing, they're not able to lift their arm, whatever it is, any physical problem which they were telling us, which is based on the patient's complaint, we have taken all those patients.
Okay. Dr. Sunil.
So, Biji, what were the main physical barriers that work for them?
Yeah, physical barrier, which they said that they were not going to work because they had this fatigue. They were saying that it is because of fatigue, one. Second thing was that they were saying that they are not able to use their arm. Most of the head and neck patients were telling that they were not able to use their arm after surgery to do some strenuous work. So that was the second thing which we found mostly in these patients.
With this study, you told that there is not much study in India. There is not much study about this in India. So, yes, what could be the implications of this study for other institutions?
So one study which I found one was from Tata Memorial, but they had taken only one subset of patients, that is head and neck malignancies. That was one survey that I did. I could find that case alone, but in our study, we have taken all the patients. So I think we'll have to come up with more and more such studies, because we are, cancer centers are very much tuned to cure the disease of our patients. And by the improvement in the technology, we are doing absolutely wonders in that. But what happens to our patient after they have been cured? They have to be productive for the society. They should feel they are useful. They should feel that they are becoming an earning member, because that gives them not only financial support, their quality of life also will be increased. So definitely we will have to take care of this return to work of our survivors. And we have to do more and more research on this thing and get a very good result out of that. In fact, after our department is going to be established, my plan is that with the available data of my study now, my return to work was 55%. I want to see after the department is established and we do some work on that, what would be the return to work after that. So that could be a comparative study which I can do in the future also.
Okay.
Thank you, Vijay.
Thank you, sir.
Okay, can we go ahead with the next participant? So, ma'am. Okay.
Please.
Dr. Kanchan Malawat. Dr. Kanchan?
Yes, ma'am.
Yes, ma'am. Please start sharing your screen.
Yes.
We can see.
Can you see, ma'am?
Yes, ma'am. Please start.
Okay. Good evening, respected judges and all listeners. Today I'm going to speak on holistic dentistry and its role in palliative care and spiritual healing. Now, as we are all aware that palliative care is a very novel approach to improve quality of patients with life-threatening illnesses. Palliative care includes all aspects of life, that is physical, emotional, social, and spiritual well-being. Now, the question is, what is holistic dentistry and how it is more favorable for palliative care? Holistic in general means considering body and mind together as one unit. So holistic dentistry is a relationship-based dentistry which believes that relationship between a dental professional and the patient is very important in treatment and believes in approach of integration of body, mind, and spirit. to serve as a holistic dentist, we should be aware of dental growth hierarchy. It is said that most dentists are pragmatists, that is, a person guided more by practical considerations. In words of Stephen Muller, president of Johns Hopkins University, we are mostly skilled barbarians as we focus on physical aspect of treatment, completely ignoring the psychological and spiritual aspects. The dental growth hierarchy explains this as follows. It includes of 5 levels. The first is surgeon or engineer level, which deals with physical achievements, biological or medical level, which deals with preventive dentistry achievements, holistic or humanistic level, which deals with achievements of relationship-based treatment. For becoming holistic dentists, we need to evolve to at least holistic or humanistic level. Next level is in spirit of caring, which deals with achievement of caring for spirit or life force residing in every physical body. Next level is a question mark, as there is always another next stage to appear. Now the question arises, why exactly there is a need of holistic dentists in palliative team? Many dental problems like xerostomia, halitosis, mucositis, etc. are encountered in palliative patients. Also, nutrition, which is most important aspect of health, is compromised in palliative patients due to dental problems. Since holistic dentists solve dental problems with a spirit, mind, and body approach, they can care better for palliative patients. Now, concluding, it clearly seems that palliative care by dentists requires holistic and humanistic mindset rather than reductionistic and pragmatic one. Holistic dentists cater best to the needs of palliative patients as they unify scientific approach with spirit and mind. It is empathy towards the life force or spirit of patient that connects both palliative care and holistic dentistry. Hope we never forget that doctors are considered as form of God as they heal and care, and it could be best done by keeping in mind physical, emotional, and spiritual aspects together. Thank you.
Thank you, Dr. Kanchan. So, you were talking about holistic dentistry. So, from my practical point of view,
Yes,
what is your experience?
sir, actually, holistic dentist exactly is a approach which will, along with the treatment aspects, physical treatment aspects, it will focus on the psychology of the patient also. And from my practical aspects, I have seen that in one of the few cases that are really memorable for me, there were some patients, like a particular case I'll talk about. That patient was a very lean patient and she was roaming from one place to another. And when she came to me, she told me this thing that she is failing to complete her treatment. So I was really empathetic towards her. And it was her anxiety and severe gags which could not let her root canal treatments, multiple root canal treatments got completed. So I would just talk with her for 5 or 7 minutes about her family or just anything, like make the environment little light. And then I would tell her that this treatment, I'm there throughout this treatment. Don't worry, we'll go slow, whatever counseling I could do. And to my surprise, she was really improving with every session, and I could complete her treatment.
Sir, ma'am.
Sorry, my video was not working just now. I just got connected by other mobile. So in this, I think I could not able to listen. So you can go ahead.
Okay. D. Bhupati, the next participant. D. Bhupati, are you here? Or anyone else from the team? Okay. Praneet Suvari.
Hi, I'm sharing my screen.
Yes, sir, please start.
Are you able to see?
Yes, sir.
Yeah. Hi, good evening, everybody. I'm Dr. Praneeth. I'm working as a consultant in Onco Anesthesia, Pain and Palliative Medicine Department from Basavatarakam International Cancer Hospital, Hyderabad. The topic I'll be presenting today is indwelling tunnel catheters for the management of malignant ascites and malignant pleural effusion with the experience of a tertiary cancer center in Indian scenario. So all of us are aware that malignant ascites poses significant symptom burden at the end of life in patients with advanced neoplasms. There have been various treatment options like repeated paracentesis, diuretics, tunnel and non-tunnel indwelling catheters, peritoneal venous shunts, which have been tried previously. But tunnel indwelling catheters are designed to remain in situ indefinitely for the remaining lifespan of the patient. And the one-way valve, which is there, which is specific for this tunnel indwelling catheters, permits drainage of ascitic fluid of the catheter, which can be opened and connected to the drainage devices when needed. It can be easily performed at home, permitting home drainage. So this is an observation thing which we have presented data from 9 patients for whom we have performed this procedure. Out of them, 8 had malignant ascites and 1 had malignant pleural effusion. The data is here. So patients and caregivers are initially counseled on how they should be draining the fluid at home. They were shown videos prior to the procedure on how to take care of the catheter at home, and they were prepared and they were counseled. And the procedure was done in an operation theater in our setup. Left lower quadrant was usually selected as cecum is relatively fixed on the right side. So this is the table which shows the details of the patients with indwelling tunnel catheter. For the first patient which we have done is a case of CA stomach. The patient expired immediately on the next day. It was a very bad outcome. The patient had ARDS, which was unexpected. And as already the patient was for end of life care, the patient did not pursue for further treatment and he expired the immediate day in the ICU. Next patient was a CA lung, which was relapsed, and he lived for 43 days. The complications which he reported was he had slight discomfort on sleeping on the same side of the catheter. There was a CA pancreas patient who lived for 57 days, and he had pericatheter leak on day 7, which was managed with suturing by a surgeon. And there was a CA stomach patient who lived for 23 days. He also had mild pericatheter leak. We did not do suture, but it was managed with dressing alone. There was a patient of hepatocellular carcinoma who lived for 28 days. There was a dilator and tearaway sheath damage during the insertion and penile and testicular swelling, which was noted during the procedure. The penile and testicular swelling was actually managed conservatively by elevation of the testis and penis during sleep by the pillow underneath. This was a complication which we were not expecting during the catheter insertion, why the patient should have a penile and testicular swelling. But we noticed this.
Dr. Praneeth.
Sorry, madam.
Dr. Praneeth, sorry to interrupt.
Yes, ma'am.
Can you hear me? Am I audible?
Yeah, you are audible. Please tell me.
The time for the presentation is over.
I'll just wrap it up soon.
Is there a question and answer?
Can you give me 2 minutes? I'll just finish in 2 minutes, please.
Already late.
I'll finish in 2 minutes, please.
Please, we can begin with the question and answer.
Okay, Dr. Praneeth, this was Okay, Dr. Praneeth, this was a good presentation. I just want to ask what will you like to conclude?
Yeah, my conclusion is that though it is a costly procedure, it would be giving more comfort to the patient because we have tried tunnel catheter without tunnel catheters. We used to do this peritoneal catheters, which was done by pigtails. But the problem with pigtail is there will be skin sharing. There will be a lot of complications with infections and pericatheter leak, which was significant than with our tunnel catheters. So we are now planning to do a comparison trial between the normal catheter, which will be done like pigtails, which will be done by the radiologist, and the indwelling tunnel catheter, which we will be doing. So our catheter, we would be confirming its position even after placement with a fluoroscopy. We'll be confirming its position in the most dependent area of the pelvis. So, and it is actually very much comforting for the patient that the risks of infection are very less. The procedure to drain is very simple. And like we also have a home care team who would be following up the patient. So it is comfortable, but the cost of the catheter is the only factor which limits its usage. It is almost 38,000 per catheter.
Okay. Okay, Dr. Praneeth. Is there any trial comparing pigtail catheter insertion procedure and your ITC tunnel procedure? Because you have shown that two of the lung patient which has undergone pleural effusion drainage for this have complications. So what would you like
one
to
patient only we have tried for pleural effusion, madam, but the patient developed pneumothorax after the procedure. And we tried to drain it through the catheter, but the catheter's bores are not very sufficient to drain, because most of the catheter was lying inside the pleural cavity. The pneumothorax was up in the upper part of the chest. So we had to ultimately go for a chest drain insertion later. That was the major complication which we noted. This was our data. Later on, we tried to, and as we have gained expertise, now we try to do a comparison study between the pigtails and this tunnel catheters. Pigtails we usually place in the abdomen also in our setup.
Yeah, but in pleural effusion, this is well established that we can do this. So we need to compare both of these.
Definitely, we are in the planning to do that, but we don't have enough numbers.
Dr.
So we are definitely will be doing it.
Yeah. So is this done from the palliative care department or from by a surgeon?
No, we manage a pain and palliative department, sir. We are only doing it. I am only doing it actually in our hospital.
And what was the main difficulties that the caregivers usually comes to you?
Caregivers, the dressing of the pigtail, the dressing of the indwelling tunnel catheter was initially explained to them. Even after explaining, sometimes they have certain queries, so they call up to us. We do video call based explanation if the patient is out of station. But if the patient is in station, we'll ask them to come again to the department, and then we will do a dressing. So the main problem is sometimes the patient says that the catheter, the flow is not coming. So we say that wait for 2-3 days, and the patient says that okay, now the flow has started coming. So it depends from patient to patient. So usually it is like the pericatheter leak or dressing, and that the flow is not coming. These three are the main complaints which I noticed.
Thank you.
Thank you, sir. Thank you. Thank you very much.
We can, PSC, shall we move on to next person?
Alice. Dr. Alice, are you here?
Dr. Alice might take a few minutes. Her laptop just got crashed. She's arranging. Can you call the next participant till then? She can call the last.
Maybe
Okay,
Dr. Neetu.
Neetu, Susan?
Yes. I will start my sharing my screen. Is that visible?
Yes, it is visible. Please start.
Thank you. I'm Dr. Neetu. A very good evening to one and all. This is a prospective observational study to assess the quality of life and symptom burden in patients with hematological malignancies receiving hematopoietic stem cell transplantation. So we come to the background first. Hematological stem cell transplantation can be considered as a curative and most intense form of treatment modality available for many malignant as well as non-malignant conditions. There are so many adverse effects following hematological stem cell transplantation which compromise the quality of life and survival of patients who undergo it. Only few studies have examined the predictors for quality of life in patients undergoing hematological stem cell transplant. The study can make a change in the future approach to HSCT patients with hematological malignancies to assess their symptoms, including psychological issues. So this study helps to plan adequate prompt interventions to improve the quality of life and make symptom burden less symptom. So let's go to the aims and objectives. The primary aim was to assess the quality of life of hematological malignancy patients at admission to the hospital for hematological stem cell transplantation, also at 1 month and at 3 months following HSCT using FACT-BMT scale. And secondary objective was to assess the symptom burden in them using revised ESAS.
that is Edmonton Symptom Assessment Scales. Let's go into the materials and methods. So institutional ethical clearance was obtained. The study design used was prospective observational study. And duration of study was that the study was carried out for a duration of 18 months. Inclusion criteria: patients with hematological malignancies admitted to our hospital for hematopoietic stem cell transplantation who were more than 18 years and who were willing to participate in the study. And exclusion criteria: patients under psychiatric treatment are not able to come for the desired follow-ups for the study. The instruments which were used were socio-demographic proforma, some semi-structured proforma to assess the clinical details, as well as validated tools like FACT-BMT scale, as well as revised ESS to assess the symptom burden. FACT-BMT was used to assess the quality of life, and ESS was used to assess the symptom burden. And data was analyzed using statistic software Stata 14.0. The results: a total of 68 patients were included in the study, out of which 8 patients expired during the study period, and 1 patient was lost to follow-up. The mean age of the sample was 42.92 plus minus 14.78. There were 44 males and 24 females. Out of the 68 patients enrolled, most patients were having multiple myeloma as their diagnosis, followed by non-Hodgkin's lymphoma. And the quality of life, as we found, were least in the first month following transplantation. In fact, BMT scores have decreased from baseline, that is F0 to first follow-up, indicating the quality of life was less, and then increased in the third follow-up. And this, regarding the symptom burden, this was quite high in patients undergoing HSCT, and all the symptoms peaked at the first month following transplantation. The maximum ESAS mean score was for tiredness among all the other symptoms during the baseline as well as during the first and second follow-ups, as we can see in the graphs. And I'm concluding the quality of life improves with time. Symptom burden was highest in the first month after transplantation, which came down later. It was necessary to have assessment of symptom burden to provide a good quality of life in such group of patients. And further studies in this group of patients can help us with their better management and understanding of the disease course. Coming to the future prospects, the area of quality of life which were identified in the study could be considered targets for the studies. Okay, thank you.
To Susan, ma'am.
Yes.
The time is over for the presentation.
Of course.
Ma'am, please begin with the question and answers.
So, yeah, Dr. Neetu, what was the time of follow-up for these patients?
Ma'am, there were 2 follow-ups after baseline. Patients were followed up in the first month as well as at 3 months.
Okay, so and what was the observation between these 2 timing?
So we have used 2 scales here. One was a FACT-BMT scale to find out the quality of life, and the other scale was ESS, revised Edmonton for symptom burden. So we have found that symptom burden was maximum during 1 month. Also, quality of life was least during the first month, which indicates that symptom burden was increased. Symptom burden was correlating with the decreased quality of life. And during the second follow-up, that is during 3rd month, quality of life was improved and symptom burden also reduced.
Yeah, so this is really happens with the patient, but I just want to know what are the future aspect of this study, because this is a known fact that the quality of life will be like this.
Yes, of course.
Yeah. So what
the future
you can do with this study?
One thing we can do is that we can actually do the palliative care for such patients. Like palliative team can actually intervene. There should be some intervention actually, and we can actually compare that non-interventional and interventional things. We can compare and actually establish that palliative care will improve the quality of life much better than without palliative care. We can do 2 arms a study like that.
Yeah, right. Dr. Sunil.
So, which was the most common symptom scored more in the ESAS scale?
Most common symptom we got was tiredness, sir, fatigue, followed by anxiety.
Okay, so this was just an observational study, and in the future you want to include palliative care intervention into this.
Yes, sir. That is one of the limitation of the study.
Yeah. Thank you, Dr. Neetu.
Okay, can we begin with the next participant? Alice, Dr. Alice, are you here?
Dr. Alice has sent a message that her laptop has crashed. So maybe we will call Dr. Alice at last.
Yes, sir. Thank you so much. I'm trying hard to open it, but I'm not able to. And unfortunately, I haven't saved it anywhere else in any other systems also.
Can we share from our side?
Sure, sir. Please. Yes, sir. Good evening. Yes, sir. I can see the sir. I can see the poster, sir.
Please continue.
Okay, shall I start, sir?
Yes, please start.
Yeah. So good evening to one and all. Today I'll be presenting the presentation of a case report. The title of my presentation is Synchronous Pericardial Effusion and Superior Vena Cava Obstruction in a case of advanced neuroendocrine tumor of lung. And as we all know, the most common cause of one of the most common cause of superior vena cava obstruction in a case of in malignancy is non-small cell carcinoma. So here in this patient, and the studies also shows there are 10 to 12% of patients in which pericardial effusion is the most commonest, and the most common cause is metastasis to pericardium. It can be either direct infiltration or invasion, or because of the lymphatic, if it affects the lymphatic drainage, and it is characterized by accumulation of excess pericardial fluid which causes functional impairment of the heart. And bronchogenic carcinoma is found to be 36%, and CA breast is around 7%, and non-solid malignancy is around 20%, accounts for the primary sites of malignancy. And echocardiography is imaging modality of the choice. And stenting, radiotherapy, and chemotherapy are considered the first line of treatment based upon the etiology of the primary malignancy. And in this particular case, as we can see, I have encountered two oncological malignancy in the same patient, that is SVCO obstruction as well as pericardial effusion, to be more precise, an impending cardiac tamponade. So I had a 47-year-old male from rural India. He was a reformed smoker, and he presented with complaints of swelling in the right side of the neck and a shortness of breath for 9 months. He initially developed a swelling in the right side of the neck, which progressed rapidly to the size of a melon within 9 months. In between, he lost a follower because of the COVID pandemic, and it was associated with difficulty in swallowing, hoarseness of voice, without any pain initially, and later, his shortness of breath progressed to MMRC grade 4 along with 3 episodes of hemoptysis. So at the time of presentation, he was dyspneic, tachypneic, pale. Bandage of clubbing was found with grade 3. He had axillary and cervical lymphadenopathy and facial puffiness with dilated vessels over the anterior chest and abdomen, as you can see in the picture, which can be found below. And the swelling was huge, around 8 centimeter, and it was firm in consistency. On auscultation, I could find decreased entry of breath sounds in the right side and muffled heart sounds. So he was evaluated with CCT neck chest, which showed a heterogeneously enhancing mass around 9 centimeter from the right upper lobe, and it was encasing the SVC and intraluminal invasion. Echo was done, which incidentally found a massive pericardial effusion with diastolic collapse of right ventricle suggestive of an impending cardiac tamponade. As you can see, the ECG, I'm sorry, it's not that clear. It showed low voltage complexes, and you can also see the echo findings on the right side, which showed the increased amount of pericardial fluid. So the patient was started on steroids, dexamethasone.
Sorry to interrupt, ma'am. Alice.
Okay.
Ma'am.
Okay.
The 3 minutes for the presentation are over.
Okay.
We can begin with the question and answers now.
Sure.
Ma'am, please go ahead.
Dr. Alice, you can conclude.
Okay, sir. Thank you so much, sir. So the poster is not longer visible.
Okay, but you can.
Yes, sir. So we managed the case with Lasix and dexamethasone. We initially planned him for palliative RT, but as he could not lie down supine, we couldn't give him that. But as his hemodynamic instability was a bit increasing, he underwent emergency pericardial centesis. Around 150 ml of blood-stained, fluid was removed. He felt symptomatically better for a day, but on the next day he worsened. He had another episode of hemoptysis, and his hemodynamically he became more and more unstable. So all the curative treatment was initially out of the box, and we didn't try for another pericardiocentesis. So in fact, later we gave him the home-based supportive care, and we had to send him home. So I would like to highlight that there are two oncological emergencies which are presenting with almost the same symptoms. Had we not think of this pericardial effusion, or we couldn't do a bedside echo for that part, this could be easily missed. And if this was a young patient, and if he was in a better state, if the cancer was not in advanced metastatic stage, we could actually put a drain and we could give him a palliative RT and even stenting in that case. So this would have been a bit more better ending in the sense a curative ending if it was for another scenario. So that is what highlighted. That is what I would highlight in this case. And there are in fact very few literature studies in this particular aspect, mainly from outside India. That's it.
How common it is, pericardial effusion in patients with?
So SVCO in CA lung.
I'm asking about pericardial effusion.
So pericardial effusion is found around 2 to 10%, but both of them together, and in fact impending cardiac tamponade for that part, the chances are a bit less. So the main highlight of this case was both of the oncological emergencies, that to a neuroendocrine cancer, so CA lung. Sorry.
Dr. Richa?
Sir?
So,
Sir,
yes. Yeah. Hello, Dr.
Yes,
Ellis.
yes.
I want to ask that what was the intervention? Like with lasilectone, does patient respond, or you have to go for pericardial effusion for each case, and they have done better with this?
Yes, ma'am. So initially there was only SVCO was found. So we usually manage superior venical obstruction with dexamethasone. It was given 8 milligram was given, ma'am, and but he didn't have. We rule out any presence of infection, and we did a cystectomy, which only mild peripleural effusion. So, but still the patient was not anyway responding to anything which we gave. So incidentally, we did a bedside echo, which found this. Pericardial effusion, and we did a pericardiocentesis, ma'am. We did a pericardiocentesis, but this is the first case that we did in our setup. And in fact, he responded, ma'am. For a single day, he had symptomatic improvement. He was off oxygen for a day, but the next day he had another episode of hemoptysis, and
what was survival for this patient? And as a palliative physician, what could you do more for these patients? Are you able to explain this patient that these are really difficult situation? And
Ma'am, I couldn't get you. Your voice was
what was the
cracked.
what was the survival for this patient? And as a palliative physician, what could be done for this patient? These are really challenging with the SPCO patient and pericardial infusion, in which any kind of treatment is not possible. So what are the things you can do as a palliative physician? Patient are able to understand the situation?
Yes, ma'am. As I have told in the presentation, ma'am, he was in rural India. His wife was only with him. He hadn't seen his children for long, and this mounts to another psychological domain. He was very much psychological distress, and on top of that, we couldn't give him any curative intent. So, for a brief period of time, he could get the symptomatic relief with the pericardiocentesis, but it was not long. So, we gave him oxygen therapy, and he could arrange it for it.
Okay.
Alice, can you hear me?
Sorry. Yes, ma'am. Yes, ma'am.
Ma'am, can you hear me, Richa, ma'am?
Yes, yes.
Ma'am, the time is
Yeah,
over. Her 6 minutes are. So can we begin with the next participant?
Thank you so much, ma'am.
Yeah,
Thank
sure.
you.
So the next participant is Vishnu Prasad. Vishnu Prasad, are you here? Anyone from Vishnu Prasad's team? Okay. So Lekha, Dr. Lekha.
Yes, ma'am.
Can you begin?
Okay, ma'am. Sure.
Yes, please begin.
Yes, ma'am. Give me a moment. Like, should I share the screen now?
Yes, yes, you have to share your screen.
Yes, ma'am. Give me a moment. Ma'am, I'm not able to share it from my side. Can you help me with that?
Okay, I'm going to share. Please wait.
Should I begin?
Yes, please.
Yeah, yes. Good evening, ma'am. Good evening, sir. I'm Dr. Lekha, second year resident from GCRI, Ahmedabad. So today, like my topic of my post. Hello. Am I audible?
Yes, yes.
Okay.
Please go on.
Yeah. The topic of my poster is the use of indwelling peritoneal catheter for the management of recurrent ascites in patients having terminal malignancy. What we like introduction. As we know that malignant ascites is like poor prognostic sign, and it is seen in it is the main indicator in underlying mechanism can be peritoneal infiltration, liver mets, and causing secondary portal hypertension, lymphangitic carcinomatosis, etc. We don't know the main curative purpose of this curative intent of malignant ascites. Symptomatic management is the main stay of treatment, and chemotherapy is very less chances to improve the symptomatic management. Continuous paracentesis is the only line of treatment. So we include the patient who age above the 18 years and patient who are undergoing not undergoing any systematic chemotherapy or radiotherapy, are having normal coagulation and platelet count. We excluded patients who were not willing for intervention of any kind and having confirmed local or systemic infection, or having loculated or systemic ascites with thick septa in US sonography, ultrasonography. Like after selecting the patient, we prepare the patient patient was indoors, so we prepared the patient on the same day, obtaining written consent and giving all the pre-procedure precaution. We started with we used central venous catheter as a peritoneal catheter, and inserted via Seldinger technique, which we are using for central line. And after confirming both patency, we fixed the catheter with the suture material and shifted the patient to the ward. So in this study, we included total 10 patients. All of them were having terminal malignancy.
Dr. Lekha?
And
Dr. Lekha?
Yes, ma'am. Yes, ma'am.
The time is over for the presentation. We can begin with the question and answer. Sir, ma'am? Please go ahead.
So, Dr. Lekha, what is the conclusion from your study?
So conclusion is that as we know that only means we can only do paracentesis in this kind of patient. For this kind of patient, they used to come again and again for like a paracentesis from home in emergency and everything. So with this, in the indwelling peritoneal catheter, we taught the patient and relative how to remove this ascitic fluid whenever necessary in their home only. And in localized patient, we arranged home visit every week, or within the they'll tell us that they require some help with that. So within a week, within a day or some. So we followed up that this kind of patient regularly. Most patients were localite, and who were not localite, we taught them their relatives and asked them to do paracentesis at home. So I think quality of life of patient and relative, and they did not have to come back and forth to hospital just for paracentesis, especially in the end of life care.
Okay, what was the average life expectancy in these patients?
It was
after
nearly
putting-
20. Ovarian, especially for ovarian gynecological patient, we had 1.5 months, 1.5 months, and few patients had a week or so. So longest was 1.5, average was 21 days.
Thank you, Dr. Richa.
So how do you manage leakage in this patient going to the home and again coming back with the leakage and all this kind of problem, infection?
Ma'am, we had seen only one or two patients having this leakage problem. Most of them were managed by repeated dressing that we applied using cotton around the incision site, and we asked them to change every day, and that was the main only two patients had the leakage.
How many patients had displacement and the reinsertion was required?
Only one patient had this accidental removal, and we reinserted the catheter while she was in the hospital herself. She was continuing her treatment in hospital, and she displaced her catheter. We reinserted next day, and sent her home within 2-3 days.
And what are the difficult cases where you have to manage with this peritoneal carcinomatosis, recurrent ascites? Like you told that ovary was the cases most of the patient has been seen, and if patient has other complication, how did you manage with the peritoneal catheter? Like infection, like home visit was the option, and like
Yes,
infection, how did you manage?
Ma'am, in two patients, we saw this local redness and everything. So we managed it with the oral antibiotic only and local dressing. That's it. And patient improved. There were no.
Dr. Lekha.
Yes, ma'am.
Dr. Lekha, am I audible?
Yes, ma'am. Yes, ma'am.
Sorry to interrupt, but the time is over. Dr. Richa.
Okay.
Okay, thank you,
Okay,
Dr.
okay.
Lekha.
Okay, thank you. Thank you.
Okay, Dr. Vishnu Prasad, are you here? Anyone from Dr. Vishnu's team? So, okay. D. Bhupati? Anyone from D. Bhupati's team? Okay, it's fine. We are going to begin with the next session now. Thank you, Dr. Richa ma'am and Dr. Sunil Kumar sir. Thank you for being with us and judging the sessions.
Thank you, IAPCON, to giving me this opportunity.
Thank you.
Most welcome, ma'am. Yes, sir, please go ahead.
No, I was just saying thank you.
Okay. So on behalf of IAPCON 2022, I thank both of you. So the next session we are going to begin. So the judges for the next session are Dr. Seema Mishra, ma'am, and Dr. Vinita Vipin Chandran. On behalf of IAPCON 2022, ma'am, I welcome both of you. I am Priyasi, your moderator for session. Dr. Seema is a professor of Department of Onco Anesthesia and Palliative Medicine at Dr. B.R. Ambedkar College, also associated with IRCH and AIMS New Delhi. Dr. Vinita ma'am, she is a pain and palliative physician and working as MD resident at Community Medicine in Amrita Institute of Medical Sciences, Kochi. Vinita ma'am and Seema ma'am.
Yes, Priyasi, go ahead.
Yes, ma'am. So we are beginning with our first participant, ma'am, Dr. Ishita Gandhi.
Yes, good evening.
So I'm going to repeat the instructions for those who have joined recently, the participants and both the judges. We have allocated 6 minutes total for each poster presentation. The 3 minutes for the presentation and 3 minutes for the question and answer round. The question and answer will be asked by judges and participants will be given 3 minutes for the presentation. Thank you. Over to you, Dr. Ishita Gandhi. Please
Thank
go
you.
ahead and
Can
share
I
your
share my
ma'am.
screen?
Yes, please.
Is the screen visible?
Yes, your screen is visible. Please start.
Okay. Good evening, everyone. Here is a case presentation of the management of malignant ureteric obstruction with dexamethasone. We know that bilateral malignant ureteric obstruction can occur when a primary or a metastatic malignancy in the retroperitoneal area causes external compression or encasement of the ureters. Pharmacological methods and/or urinary diversion procedures are general mainstay of management. Here we had an 85-year-old female patient who was diagnosed with splenic lymphoma in 2015, and she was on homeopathic treatment for the same. She complained of severe swelling in both lower limbs, decreased urine output, fatigue and constipation for 2 to 3 weeks when she presented to us. On examination, she had grade 3 lower limb edema in bilateral lower limbs, and her modified Australian Konopsky's performance score was 50. The CT scan showed bilateral proximal ureters and right pelviureteric junction inseparable from a mass caused by the coalescence of retroperitoneal lymph nodes and mild to moderate bilateral hydronephrosis. Urinary diversion procedure was not possible for this patient. Her renal function test showed mildly raised urea, that is 62 milligram per deciliter, and creatinine of 1.43. The patient was started on oral dexamethasone 8 milligram, which was given for a total period of 4 weeks. We halving the dose after each week, after the second week, and then halving the dose again after halving the dose after first week, and then again halving the dose after the second week. She was also started on torsemide 5 mg once daily till the swelling subsided. The patient showed significant response within a week itself. After 4 weeks, edema decreased, fatigue reduced, and activity and appetite both had improved. So before dexamethasone, her lower limb edema was grade 3, and after dexamethasone and examination, it was grade 1. Her Konopsky's performance score improved from 50 to 70. Her appetite improved from ESAS-4, Edmonton Symptom Assessment Scale 4 to ESAS-1. Serum urea mildly improved from 62 to 58 mg per deciliter. And serum creatinine also improved from 1.43 mg per dl to 0.9. So in conclusion, dexamethasone was found to be effective in relieving symptoms in patients with malignant urethral obstruction. Thank you.
So Dr. Ishita.
Yes, ma'am.
You are able to hear me?
Yes, ma'am.
Yeah. So, what do you think? How the dexamethasone has really improved the symptoms? What?
Ma'am, dexamethasone has some amount of it acts on the peritumor. It acts on decreasing the peritumor edema. So that might be one of the mechanism of actions in which it would have helped because there was edema encasing the ureters. So that would have reduced, leading to improvement of the symptoms. Also, dexamethasone is known to improve the appetite as well. So the appetite and activity improved.
Is there any change in the urine output? Patient had anything?
Ma'am, the urine output improved.
Have you noted and quantified?
No, ma'am. The patient did not have any catheter, and this was a home-based. I mean, we have a home-based palliative care, so that was not noted.
This is the first kit where you handed this, given the dexamethasone?
For yes, ma'am. For malignant ureteric obstruction, this is the first time we gave a trial of dexamethasone.
Okay, over to Dr. Vinita.
Yeah, hi Ishita. That was a neat presentation. And what a question that I have for you is again, we know that for lymphomas, steroids itself is a treatment.
Yes,
so here you have used dexamethasone for decreasing the peritumor edema. So it is also going to reduce the tumor. So I would just like to know your ideas on what is the generalizability of this finding that you have here. Would you be suggesting it? Have you tried it in other cancers as well?
Yes, ma'am. We have tried dexamethasone in a number of cancers for that matter in palliative care setting.
For ureteric obstruction?
Not for ureteric obstruction per se.
I just want that.
Not for ureteric obstruction per se, but for other cancers to reduce the peritumor edema, we have tried dexamethasone.
Definitely. I just wanted to know this because it's also having a treatment benefit in here. And was this patient given the suggestion of any intervention like PCN, or was it just he was just offered?
Ma'am, the family was not willing to get any intervention done owing to her age and the low grade lymphoma. So they did not want any active intervention.
And how about the survival of the patient? How long did this patient live?
Ma'am, the patient is still alive. So it was diagnosed in 2015.
Oh. Thank you.
Thank you, ma'am.
Thank you, Dr. Ishita. Ma'am, any more questions with her?
No.
Okay, am I audible?
Thank you
to
so
everyone?
much. Thank you.
Okay, am I audible, ma'am?
Yes, you are audible.
Yes, sir.
Okay, so the next participant is Dr. Akanksha. She have already shared her screen. Dr. Akanksha, please begin.
Yes, ma'am. Thank you. Good evening, everyone. Myself, Dr. Akanksha. I am working in the Department of Palliative Medicine, Tata Memorial Hospital, as a medical officer since almost last 5 years. I am going to present a case report, effective strategies to deal with chemical burn wound in an advanced cancer patient in respite palliative care settings. Introduction. Advanced cancer patient with malignant wound experience multidimensional suffering which severely compromise comfort, dignity, and quality of life. We herein report a rare presentation of patient with buccal mucosa cancer with a chemical burn wound which was managed in a respite palliative care setting. Case presentation. A 36-year-old gentleman with a diagnosis of buccal mucosa cancer on palliative chemotherapy was admitted in a respite care facility for a malignant wound myiasis management. The patient reported that this wound had occurred Post-dressing, patient had not received radiotherapy. He did not have bleeding or discharge. Patient and his caregiver were in extreme distress. On inspection and assessment, there was ishar over his upper back covering area up to bilateral mid-scapular region and neck region, measuring around 12 by 10 centimeter and 6 by 6 centimeter respectively, with seeping wound, blister, and very dark to brown to black discoloration of skin. Based on history and assessment, we considered a differential diagnosis of chemical burn. With specialist palliative care nursing approach, we manage a chemical burn wound by applying amnion dressing followed by karaya powder. Amnion dressing was applied alternate day for 2 weeks, followed by karaya powder dressing daily for 2 weeks. The following images shows the appearance of the wound at baseline assessment and after dressing. Patient and caregiver were counseled and empowered. Conclusion: specialized wound care management is cardinally salient, along with the appropriate modification in wound dressing as per the need. Thank you.
So, Dr. Akanksha?
Yes, ma'am.
Yes, thank you. It's very interesting.
Yeah.
Can you just tell me how frequently you have got such type of patient? This is the first case.
This is the first case, ma'am. That's why we do this. We are doing this case report.
Otherwise, what
usually we won't get such patient.
So, can you tell me how you manage the wounds in your setup, other than the chemical burn?
We are using for usual cancer wound. We are using Metrogel for wound dressing, along with the normal saline or Metrogel ointment or the hydroheal, like that we are using.
Okay.
It depends on the wound.
Okay, Dr. Vinita, carry on.
Yeah. Hi, Akanksha.
Hi, ma'am.
It was a very interesting case.
Yeah.
So what exactly was inflicted that chemical burn?
Sorry, ma'am?
What actually inflicted that chemical burn in this patient?
Ma'am, actual chemical we don't know, because he was a very poor patient and he was staying roadside. So means उसने जो हिस्ट्री दिया कि कुछ ड्रेसिंग किया था उसने किधर तो, और वो 4 days lying down position में ही था, and then he developed this burn.
Okay.
So
Was he diabetic?
there were maggots in his wound, so we thought it's maybe due to turpentine. So we are assuming it's because of turpentine.
Okay.
So
All right. Was he diabetic?
no.
Okay. And was any antibiotics given? Was any?
No, ma'am.
Nothing.
Along with the amnion dressing and karaya powder, he improved a lot.
All right. Okay. Right. I think I'm done with the questions.
Thank you, ma'am.
So the next participant is Dr. Pragya Singh. Dr. Pragya? Hello, can you hear me?
Hello, am I audible?
Dr. Pragya?
Hello,
Yes,
am
you
I
are
audible?
Yes, you are.
Hello, good evening, everyone.
Dr. Pragya, please share your screen.
Okay, okay. Actually, I'm unable to share my screen.
Okay, wait. I'll try to share yours.
Yes, sir, please.
Okay.
Is my screen visible?
Now it is.
Yes, yes, visible.
Yes, your screen is visible.
Good evening, everyone. I
Dr.
am.
Pragya?
Hello. Am I audible? Good evening, everyone.
Yes, you are audible. Please continue.
Good evening, everyone. I am Dr. Pragya Singh, Senior Resident in Department of Radiation Oncology, AIMS Rishikesh. I am presenting a poster which is about the symptom palliation in metastatic carcinoma gallbladder patient. This is a retrospective report from a sub-Himalayan high-volume center. The incidence of gallbladder cancer is comparatively high in the northeastern state as compared to the south and the western state of India. And most of the patients of gallbladder, they are being diagnosed at an advanced stage and which shows a poor prognosis, and they are eligible for only poor prognosis and for palliative care. So my aim of the study is to assess the profile and treatment and outcome of these metastatic gallbladder cases. A retrospective record analysis of these metastatic gallbladder patients were those patients who were registered and treated between January 2018 to December 2019 was conducted. The epidemiological profile, ECOG performance status, metastatic site and treatment details were obtained, and the treatment compliance as well as the overall survival were analyzed. So we assess a total record of 169 gallbladder cases, and among them 62 patients were found to be histopathologically proven metastatic gallbladder cancer. And we found that around two-thirds, like 69% were female and 31 were male. The mean age was 54 and maximum were residing in the Indo-Gangetic region. 23% were incidental finding after cholecystectomy for benign disease. And most of the patient, when they appeared to our side, they were in a good performance state. 84 patients were found to be in good performance state. And 1/3 of the patient were found to have obstructive jaundice. And so they underwent procedures like PTBD and biliary stenting, by which their nausea, vomiting, and pain was much relieved, and as well their performance status improved, so we could further treat the patient. Most of the metastatic site which was found to be liver followed by non-regional lymph node. So we planned these patients for palliative chemo, and during the treatment what we found that most of these cases, only 6 among these metastatic patients, only 6% were find to be eligible for basic support, whereas rest of them planned for palliative. But since only 50% around they could turn up for palliative chemo, and rest of the patient they defaulted. And furthermore, patient more defaulted during the first line of chemotherapy, and the overall survival which was observed to be 6 months. So my conclusion is that metastatic gallbladder cancer patients, they are mostly of female preponderance with a poor prognosis. Most of these patients were belonging to the Indo-Gangetic region. Also, we found this to be concurrent with many of the literatures. And the initial performance status of these patients were good, but due to the poor prognosis and rapid progression of these disease, patients were also poor compliance and couldn't complete the treatment, which shows a low survival outcome in these types of patients. Thank you.
Dr. Pragya.
Yes,
Dr. Pragya?
Yes, ma'am.
Yeah. So, do you have a details of how many patients they had a pain and what was the scoring system were there which you use it?
Pardon, ma'am, for which?
For pain. How many patients they had a pain and what all modalities you have used it? Have you documented or you just assess the burden only?
Ma'am, we assessed the symptom which was all over, like nausea, vomiting, and jaundice state.
Not the pain part? You are not assess the pain?
Not specifically, ma'am, pain.
But these patients, they have a very much high incidence of the pain other than the nausea and vomiting, don't you?
Yes, ma'am.
So is there any particular reason not to assess?
Ma'am, we have assessed the pain, but along with we had also assessed the other factors also.
No, like that you're telling about nausea, vomiting, and jaundice.
Yes,
have you
ma'am.
done any scoring system? How much the severity of pain, what are the drugs or any intervention has been required for such type of patients?
Ma'am, we generally give our patient basic painkillers, starting with like according to WHO ladder of pain assessment, starting with paracetamol and tramadol, and then progressing to morphine. But what we have assessed that if we start the patient early on chemotherapy, so the pain and others, and as well as we do PTBD or biliary stenting, so their pain also reduces.
How many patients you found the jaundice and how much the level of the jaundice was there?
Ma'am, around 1/3 of the patient they present with jaundice. So, and they were having more than like what the criteria was above 2 serum bilirubin.
Yeah.
But above patients which were having more like 7, 8, some sort of, so they were around among these what we assessed, so they were hardly 10-20%.
So you mean to say 80% out of your patient was having less than 2% of bilirubin?
Ma'am, 1/3, like 35%, they present with obstructive jaundice.
Yeah.
So
how
for
much the
them,
bilirubin level used to be there, average?
Ma'am, on an average, they were having some around 5 to 6.
Okay, no reason being I'm just asking you because most of the time these patients present an advanced disease.
Yes,
and bilirubin is high, and then we could have the patient for a PTBD. They're not that very frequently they're able to reach that we are able to send the patient for palliative chemotherapy because their target of bilirubin used to be less than 2.
Yes, ma'am.
Reason
Yes,
I'm
ma'am.
asking you, and PTBD is not a very good idea to get it done because it has its own side effects, complications. The patient, they have a leak and all that keep on coming for this thing. So quality of life is not much in such type of patients. So that's the reason I'm asking you. Thank you.
Yes,
And over to Dr. Vinita.
Yeah, hi, Pragya.
Hello, good evening, ma'am.
Hi. What was the outcomes that you studied in this study?
Ma'am, we generally studied the compliance of the patient and the overall survival.
All right. So you told me that there were, you did mention there were a lot of defaulters.
Yes, ma'am. Yes, ma'am.
What was the reason?
Ma'am, generally when we did a retrospective study and then we called the patient telephonically, so what we generally found, either the patient were not affordable or they progressed or they committed to some alternative medicine. So these three were most of the reason. Either they don't have much of the cost to afford or they have gone for some alternative medicine.
Okay, all right. Any of these patients had to undergo any celiac plexus block for pain or something?
No, ma'am. Among these, we didn't send anyone for the blocks.
Thank you.
Thank you, ma'am. Thank you, ma'am.
We have the next participant. Am I audible?
Yes, you're audible.
Okay. So the next participant is Shreyasi Mandal. Ma'am, please.
Yes, ma'am. Yes, ma'am.
Yes.
Hello. Yes, ma'am. Ma'am, should I share my
Yes, you should share your screen.
okay, ma'am.
Shirasi ma'am, please go ahead.
Yes, thank you. So my study is titled the Assessment of Quality of Life in Post-Operative High-Grade Glioma Patients Receiving Post-Adjuvant Chemoradiation. So high-grade glioma is a disease with a poor prognosis, even with the surgery, adjuvant chemoradiation, and the chemotherapy that we give, the temozolomide, for at least 6 months. And also the duration during the course of the disease, it has been found that patients experience alterations in the neurocognitive function, which in turn affects their quality of life. And uh, uh, the alteration is dependent upon the size and the site of the location, and also the effects of the radiotherapy and the chemotherapy. The treatment has been found, the treatment in general has been found to improve the quality of life, but studies have shown conflicting uh, reports regarding the fact that a quality of life improvement has been seen or not. And also there is also not much data that is available for assessment of quality of life in these glioma patients. In my study, I have used the fact brain quality of life assessment for assessment of the quality of life, and the aim of the study was to assess the quality of life in these patients post adjuvant chemoradiation. So I had 15 patients, all of whom were prospectively enrolled and were post operated, and they received adjuvant chemoradiotherapy 60 gray in 30 fractions, and with concurrent temozolomide and adjuvant temozolomide for a period of at least uh, for up to 6 4-weekly cycles. And the pre-treatment quality of life was assessed using the PAC-Brand questionnaire, which consists of 5 domains, namely physical, social, emotional, and functional well-being. And these are part of the common PAC-G score. And for the brain, and because it's relating to brain tumors, we have a separate questionnaire for quality of life, for assessing quality of life of brain specific quality of life. So the total score is given, but there's total score as well as the trial outcome index. And the baseline test was done at the start of RT and was repeated at 3 months of completion of RT. All values are assessed for normal distribution, and paired t-test was used in the assessment. So we found that the median age was 45 years with a male preponderance, and the commonest site was that of the parieto-temporal region, and right and left sided tumors were equally found, and improvement was noted in all domains except the FACT-G total score and social well-being at 3 months, and but the values were not statistically significant. And from our study, we conclude that improvement is noted.
Shirasi ma'am?
Yes.
Ma'am, the 3 minutes for your presentation are over. We can go ahead with the question and answers.
Okay, ma'am.
Ma'am, please go ahead.
Shirasi, can you just conclude? What is the conclusion?
Ma'am, we conclude that quality of life improvement is present post CTRT, but because of the size of because of the small sample size of our study, we are not, and also the short follow up, we cannot conclude as such, and we require a longer follow-up of these patients to actually see the long-term results of the of radiotherapy and chemotherapy on these patients.
So you have taken the quality of life assessment pre-surgery and then post-surgery and then post-chemo, post-RT, like that?
I have taken the quality of life assessment pre-RT, then at 3 months of follow-up when the patient was getting temozolomide, and yes, ma'am.
Okay, so total how long duration that?
Actually, ma'am, for these patients, they have to receive at least 6 months of temozolomide. I have presented the data for 3 months.
Okay. Okay. Thank you, Dr. Vinita. Go ahead.
Yeah. Hi, Shreyashi. That
Yes,
was
good morning.
interesting. I was just wondering, what was your initial sample size? You told me that, I mean, you were just saying that you were not able to get patients further. Did you have a proposed sample size for the study?
Ma'am, it's actually part of my thesis. So,
Okay.
so this is so I have there are rest of the patients who are yet on follow up.
All right.
Who are,
So this was quality of life was your primary objective?
ma'am, the primary objective was for assessment of quality of life. At
Right. Did you have any secondary objectives?
Ma'am, it was progression-free survival, but
All right.
because of the less number of
Less
patients.
time. Okay. And which domain was most affected among the patients that you studied?
Ma'am, we saw improvement in the total score and the brain cancer subscale.
I was saying in the quality of life, there are different domains. So which domain was most affected in these 15 patients?
Ma'am, improvement, ma'am, was seen in the brain cancer subscale and the total
I mean,
score.
like physical, psychological, the different domains.
Ma'am, mostly, ma'am, physical, ma'am, did not show a lot of improvement. And mostly those the brain cancer subscale was the one which had shown improvement. There was deterioration in not deterioration, but it did not show a lot of improvement in
right.
The total score. And
so you think the treatment, because you did take the assessment during the treatment phase of chemotherapy, right? So you think that could have had an impact on the quality of life?
On the treatment?
Yeah.
Ma'am, yes, ma'am, because it has been found that patients with fatty, their patient might get there might be white matter damage and fatty related.
Okay, sorry to interrupt, ma'am.
Yeah.
Shresi, ma'am, sorry. The 6 minutes are over.
Yeah, I think I'm done.
Ma'am, can we go ahead with the next participant?
Yes.
Okay, Dr. Logeshwari or Dr. Gautaman Kala?
Yeah. Is it okay? Is the
Okay.
slide coming up?
Yes, it is. Please
Yeah.
start, sir.
Good evening, everyone. I'm Gautaman, working at R&D Academy for Health. Today, I shall present the use of social media in palliative care setting to improve the quality of life. If you look at the digital health, the market, both the demand and the market are increasing by many-fold in the recent years. The projected increase is around 1,200 billion USD by the year 2022. The digital market is alone having an increase by 430 billion USD by 2027. So it is imperative that we reposition ourselves with changing paradigms. Whether we like it or not, digital transformation is going to be
And Dr.
the
Logeshwari,
medical care policy in the
Dr.
coming years.
Logeshwari, just a minute. Can you put it in slideshow mode?
Sorry?
Can you keep your presentation in slideshow mode?
Is it okay?
Yeah, it's better. Thank you.
Is it okay now? Is it okay to go switch between the slides to show you the additional data?
Yes, yes. Yes.
Fine, thank you. So basically, when we talk the digital era, both the demand and the market is showing unprecedented growth. As said, it is by around 1,200 billion, 12,000 billion USD by 2022. And more so in the coming years of the health, which is mobile health segment, is showing an increasing pace of development compared to the services and the software segment. Whether we like it or not, digital transformation is going to be the new model of healthcare. But going digital has helped us in many ways, especially we all know during the early phase of the COVID pandemic, the whole medical fraternity was under intense pressure. The patient numbers skyrocketed. There was a medical supply chain disruption, manpower shortage, and exhaustion. But we overcame all this by going digital to whatever extent possible. So the healthcare today, the main focus is on faster and reliable communication, providing unified healthcare solutions and reducing the overhead cost. So providing dedicated patient care service is the goal. If you talk of digitalization, the use of mobile phones comes in, and more than 90% penetration has happened in most of the countries. Social media applications has become the tool of communication between primary care physicians, the medical specialists, and the patients. Of the different social platforms available today, WhatsApp seems to be leading the pack because of its ease in communicating the pictures, transferring the pictures, videos, and the text messages. Believe it or not, there are 350,000 digital health apps today available online. But the sad thing is, only 7% of the healthcare and the pharmaceutical companies have gone digital. So there is a long way for us to realign ourselves. And in RMD, we enrolled around 120 male and female patients who were undergoing palliative care therapy over the last 3 years. Both males and females, ranging from 26 to 90 years, were included in a structured questionnaire-based study. So this was mainly a qualitative study. What we did was give out a qualitative questionnaires in their native language to the patients and get the feedback on their effectiveness of social media, whether they met their needs and care, and how effective it was in reducing the hospital visits, reducing the cost, and whether they can get the services immediately, and so on and so forth. And let me present to you the results of the study here. As
Sorry to
mentioned,
interrupt, sir.
yes.
Sir, sorry to interrupt, but the 3 minutes of presentation are over. We are
Yeah,
going
3
ahead
minutes.
with
We'll
the
finish
question
it.
and answers.
Okay, fine, no problem. So of the 120
Yes, thank
patients,
you.
we
Ma'am,
used
please
9
go
tests.
ahead.
Yeah.
Ma'am, please go ahead with the question and answer.
Dr. Logeshwar, hello, Dr. Logeshwari. Can you just tell about your conclusion of your presentation? What was your conclusion?
The conclusion is of the use in the social media platform, especially the WhatsApp, 98% of the patients responded to us saying that they were quite comfortable in connecting to the medical specialists and caregivers, and they were the quality of life improved much better than before. Of course, 2% said they needed patient visits, and 98% acknowledged that since the hospital visits are limited, there was a reduction in the patient care and the total cost involved for patient care. So this is something we will be going in the future to use mostly the digital platform using recognized softwares and FDA approved softwares to extend patient care in future.
So can you tell us about the limitation of the digital world?
The limitations, of course, currently we are using the WhatsApp, which is not valid accredited software for sharing patient information. Although it is end-to-end encrypted, we cannot share much of the patient details. But basically, being a qualitative study, this was presented here. Otherwise, we are planning to use only FDA-approved softwares for use in medical treatment, medical care. Basically, we already know that there are established systems like the management information systems, the electronic health records, emergency medical records are all digitalized. Even today, we have the books on the telemedicine and the artificial intelligence and machine learning algorithms creeping into digital area. So in future, unless we transform ourselves from the current old practice, although it's an invaluable tool, and embrace a little bit of the digitalization, digital technology, I think we will be soon losing the healthcare sector.
Any other
paradigm is shifting.
Any other limitation comes to your mind in thinking in our condition where that most of the population is a rural and urban area?
The limitation is, of course, traditionally we have been using the patient-centered care. That emotional bonding, that emotional support is always lacking when we go to digitalization. We can't deny that. But the faster and reliable access, the ease of communication, especially like in times like the pandemic, where we cannot see patients directly. So this will be the only mode of extending the patient care at a relatively easy and convenient mode.
Thank you, over to Dr. Vinita.
Yeah, Dr. Logeshwari, I just want to ask you this very same question. Because that's what I wanted to ask you, I'm just going to echo what Dr. Seema just said. How do you think we can generalize this in the rural population where the accessibility to mobile phones is not as much as what is there seen in the urban areas?
Yeah, I do agree. The penetration of the mobile phone segment, the mobile head segment, is mainly in the urban areas as of now. But the plan is digitalization, and also our government is talking of global going digital in the coming years. But as you said, rightly said, the reach is not going to be there as expected. In the next coming years, this is not going to happen. But nevertheless, I was part of the COVID assistance team from the US, and I was getting calls from even remote places. People who come to the local panchayat union offices and call from there over midnight. And anyone available on the internet from US, from globally, they pick up the calls and they answer immediately. So this was something which we never saw in the previous years. I think slowly we will be getting used to this sort of a modality for treatment. This is what we are looking for.
Right. Thank you.
Thank you so much.
Okay. Can we go ahead with the next participant?
Yes, please.
Yes, Dr. Sweetie Gupta already started sharing her screen. Ma'am, please begin with the presentation. Dr. Sweetie Gupta, ma'am. Dr. Sweetie Gupta, ma'am.
Yeah. I'm sharing my screen. Yeah.
Yes, ma'am. Ma'am, please put this presentation in the slideshow mode. Yes, ma'am.
Yeah. Thank you. Good evening, respected ma'am. Myself, Dr. Sweetie Gupta. The topic of my presentation is factors affecting survival after palliative radiotherapy for brain metastasis. So, as we know, brain metastases are associated with poor prognosis because they cause significant morbidity and affect the quality of life of patients. And the management depends upon the patient's age, performance status, location of the tumor, comorbidities, primary tumor type, and extracranial metastasis, and the disease burden. So in the present study, we studied the pattern of occurrence, clinical characteristics, treatment outcome, tumor characteristics, and treatment that may have influenced overall survival in patients with brain metastasis. It was a retrospective analysis in which the medical records of patients with histologically proven primary malignancies with brain metastasis were included. The study variables included the age, gender, primary site, stage, primary tumor type, time of diagnosis of brain metastasis, synchronous versus metachronous, the number of lesions, location, number of extracranial metastasis, the recursive partitioning analysis 1 and 2 and 3. Patients were categorized according to that. The technique of radiation, dose, time of brain metastasis, and status at the time of analysis. A univariate analysis was done to assess the relationship between the variables and according to the Cox proportional regression model. So a total of 116 patients of brain metastasis from various solid malignancies were included between February 2018 and March 2021. The age ranged from 18 to 81 years with a median of 53.5. The mostly patients were male, that were 71, females were 45. The most common primary site of cancer was lung, followed by breast in 80 and 23. Rest were less in number, including gynecological, soft tissue, GI, genitourinary. According to the RPA analysis, the most common were in RPA 1, 51 patients, followed by 3, 50, and 15 patients in 2. The number of brain metastases varied. In 30, it was single, and 86 patients had multiple brain metastases, and most of the patients had metachronous, 73 patients occurring 6 months after the diagnosis of the primary tumor. The variables which were analyzed are radiation therapy. Most of the patients received whole brain radiotherapy. That was 104 patients. 3 received whole brain followed by boost. Only 7 patients received stereotactic radiosurgery and 2 received stereotactic radiotherapy. The dose of radiation in the SRS and SRT and whole brain varied from 18 to 24 gray in one fraction, 27 to 33, and 8 to 14 fractions, 40 gray in whole brain followed by boost. At present, only 9 patients are alive, 47 have died, and their loss to follow-up is more, that is 60 patients. So overall survival was 22 patients survived less than 6 months, 6 to 12, 18 patients, 1 to 2 years, 7, and more than 2 years, 9 patients. And if we see the factors which affected the survival, it was basically the female gender, the RPA1 with the metachronous brain metastasis were associated with a better survival. And patients with adenocarcinoma histology and supratemporal location survived more than 2 years, but that was not statistically significant. So to conclude the RP analysis for the brain metastasis, it has suggested that certain factors have a prognostic impact on survival. But according to our study, we can think of other factors such as synchronous versus metachronous, location and number of brain lesions, which might also influence the survival of the brain metastasis patients. And we can have a look to see whether we can include them in the RP
Dr.
analysis.
Sweetie Gupta, ma'am.
Okay, yeah, so further research is warranted to insight
Dr.
into
Sweetie
this.
Gupta, ma'am, can you hear me?
Yeah. Thank
Ma'am,
you.
the time is over for the presentation,
Yeah.
and we are beginning with the question and answers.
Thank you.
Okay. Ma'am, please begin with the question and answer.
So Dr. Sweetie, can you just conclude, please?
Yes, ma'am. So basically, ma'am, in this study, we had studied that RP analysis usually takes care of the age, the extracranial metastasis, and the number of lesions, patient's performance status. But in this study, what we saw that even the chronicity of the lesions, synchronous versus metachronous, the gender of the patient, the adenocarcinoma histology, they also had some effect on the survival status. So basically, more prospective trials are required to see whether these can be included in the RP analysis, because that so that we can further define our survival outcome in brain metastasis patients.
Have you taken into account that how many patients they had a multiple metastasis other than the brain mets?
Yes, ma'am, that we had taken. Yes, ma'am, that we had taken into the analysis, because according to the RP analysis, the extracranial metastasis was present in basically 2 and 3 patients.
So out of 160, how many?
15 and 2 and 3 in the RPA group. Otherwise, it was 65 patients.
Okay, 65 patients. And what were the performance status of the patients?
Ma'am, patients' performance status we had categorized according to the RPA. So it was in KPS was more than 70% in cases in 51 patients, and otherwise it was less than 70, and in the 15 and 50 patients.
Okay. Thank you, Dr. Sweetie. Over to Dr. Vinita.
Yeah, hi.
Hello, ma'am.
Nice presentation.
Thank you, ma'am.
What is the reason that there was such a high loss to follow up?
Ma'am, actually, our study was from between 18 to 21. One thing is that we are residing in a sub-Himalayan region. Most of the patients come from the hilly areas. So we are having a lack of follow-up and non-adherence to treatment, even in radical malignancies where we are having radical. So patients are not that aware of the disease process. Second is, most of the time, if you see, it was in the COVID era, 20 and 21. So they were lost to follow-up. And when the patients come to know that they are suffering from disease which is not curable, they do not adhere to our treatment strategies, in spite of repeated counseling.
What is the sample size once again?
Ma'am, it was a retrospective analysis and we had 116 patients of brain metastasis.
How did you select the patients?
Ma'am, actually, we just excluded the leptomeningeal metastasis patients. Otherwise, all patients other than that were included in our study. Those who had received radiation.
Oh, right. Yes, thank you.
Thank you, ma'am.
Dr. Sarvadarshi Saraswat, ma'am, please start.
Very good evening to eminent faculties and the presenters. Myself, Dr. Saraswat, pursuing MD Palliative Medicine in AIIMS, New Delhi. At the end of this evening, let's talk about end of life death and end of life care policy of AIIMS. My topic is effectiveness of AIIMS end of life care policy and observational study. Dying with dignity is the legal right of every humankind, and breaking bad news must be the confidence of every treating physician dealing with life-limiting illnesses. According to a study in 2015, India took 67th position among 80 countries in providing good death. Hence, AIIMS New Delhi has created a well-defined end-of-life care policy to help patients suffering from life-threatening illnesses to curtail unwanted medical interventions, as well as to provide better quality of care, staying within the boundary of ethical limitations with patient and his family's consensus. The aim of this study is to evaluate effectiveness of AIIMS EOLC policy in real clinical practice. Method is data were collected from NCI Jhajjar and IRCH AIIMS New Delhi from November 2021 to January 2022. Responses of patient or family regarding further management was recorded in terms of first, opted for home-based end-of-life care, hospital-based end-of-life care, end-of-life care failure, that is prognostication insufficiency. A result was as such, a total of 32 cases were studied. Patient and caregivers were counseled regarding EOLC and expectations. Of the 32 cases, 30 cases, that is 94% cases, were convinced well, whereas prognostication failure occurred in 2 cases, that is 6%. Among 30 terminally ill patients, 24 patients, that is 75% patients, were went for home-based end-of-life care. 2 cases, that is less than 1% patients, opted for hospital care. 4 patients, that is 13% patients, stayed and peaceful death was offered to them. The conclusion was AIIMS EOLC policy has successfully managed to handle deadly situations associated with life-threatening illnesses. Respecting caregivers' emotional involvements has also contributed to reduce the hospital mishappenings tremendously. Thank you.
Dr. Vinita, please.
Yeah. Hi. That was a nice presentation. I was actually wondering, once you are giving the option of proceeding for end-of-life care for these patients, you do talk to the family and the patient, right?
Yeah, ma'am.
Yeah. So in between, do you counsel them or give them the option of revising it? Or do you ask their opinion or if they still would like to continue with it?
Yes, ma'am. Actually, end-of-life care is not like DNI, because end-of-life care is established after getting fertility or further management from the primary treating physician. So generally, there is no option left to revise the further management protocol, because if a patient denying it also can be reverted, but such cases usually does not happen.
All right. I just wanted to know that. Over to you, Dr. Seema.
Yeah, Dr. Saswata, very good. So what do you think that how easy for you to collect the data being such a doing the GR shape? How difficult you felt discussing with the end-of-life care? You had any difficulty any point of time?
Madam, previously when I was new in this department, it was a bit difficult, but after knowing the proper method of prognostication and establishing fertility of care, it is getting easier and easier, and we are getting trained how to communicate all these things or all these bad news with the patients and the patient caregivers.
Okay, very good. Thank you.
Thank you,
All the
ma'am.
best.
Any other questions, ma'am?
No.
Okay. So the next presentation is of Dr. Nilima Shingade. Ma'am, are you here?
Yes, I am here.
Ma'am, please share your screen.
Yes, wait. Is it it visible?
Ma'am, not yet. It's visible now, ma'am.
Okay. So, good
Okay, ma'am,
evening.
go ahead.
Am I audible? Hello.
Yes, you are.
Yes, ma'am, you are audible. Please go ahead.
So, good evening, all. This is my psychology project research paper, and I'm glad to present in IAPCON. This is related to anxiety, stress, and depression among nursing staff deputed on COVID-19 duties and those on routine duties across government hospitals in Delhi. Myself, Nilima Sharath Shingade. I am working as a senior nursing officer at AIMS, New Delhi, IRCH, Department of Oncology. And the aim of my study is to see the level of stress, anxiety, and depression among the nursing staff deputed on COVID-19 duties and routine duties across government hospitals in Delhi. For that, I have collected 100 nursing sample from 100 nursing staff. 50 of them were on COVID-19 duties and 50 are from non-COVID duties. And the tool used was electronic version of the depression, anxiety, stress scale, that is DAS. And analysis of the study was descriptive and inferential analysis done by SSP. To introduce medical staff, as we know that medical staff, including nurses, are in direct contact with the patients and experiencing high work pressure, especially during the COVID-19 pandemic. Direct contact with the patient could create some psychological problems in this group. That thus the prevalence of such problems must be investigated. After giving the DAS scale, the results shows there was no significant difference between nurses who were on COVID or non-COVID duty in the prevalence of stress, anxiety, and depression. Anxiety was statistically significant with stress, and depression was statistically significant with age, stress, and anxiety. This correlation chart shows the mean age of the study participants was 36.5 years. The mean value of stress, anxiety, and depression in the study sample were 9.76, 6.58, and 6.53 respectively. There was no significant difference between nurses who were on COVID or non-COVID duty in the prevalence of stress, anxiety, and depression. Also, there was no significant difference between female and male nurses in respect to the prevalence of stress, anxiety, and depression. Anxiety was statistically significant with stress at 0.01 level, and depression was statistically significant with age at 0.05 level, and statistically significant with stress and anxiety at 0.01 level. So the conclusion of the study was, this study revealed that the majority of the participants had a normal level of stress, anxiety, and depression. The nurses who were posted on COVID duty had a higher level of anxiety, stress, and depression as compared to the nurses who were posted on non-COVID duties. The female and male nurses had more or less the same level of stress, but the prevalence of anxiety and depression was more in male nurses as compared to the female nurses. Although there was some little mistake here. Male participants are 17 and female participants were 83. So in spite of the few numbers of male, this has been shown that male nurses have more anxiety and depression compared to the female nurses. That is all. Thank you.
So Nilima, have you done, when you evaluated that COVID posting and non-COVID differences are their anxiety level, have you done extra care for such type of staff? That is not related to your study, but anything you have done extra for them?
Yes, ma'am. As we all know that during the COVID duties, our staff were in very stressful situation. So whenever we have many groups formed during the COVID time. Whenever we found that our nurses are COVID positive, we try to call them. I'm a charge nurse, so being a charge nurse also, and being an COVID tracing team member also. So we used to call every staff who got infected with this COVID or who are posted in the COVID area, and we try to inquire about their family members, try to inquire about their any issues which can be resolved by our own level, or which can be needed to move forward these problems to the administration level. So this gives them that they are in the family, and they find that we have a support system among ourselves. So this was very useful for all the nurses to cope up with this situation.
Okay, thank you, Nilima. Over to Dr. Vinita.
Thank you.
Hi, Nilima.
Hi.
Yeah, your this questionnaire, was this recorded by, assessed and filled by you, or was it self-scored?
Which questionnaire? DAS scale? It was
both.
It was sent to the participants on Google form.
All right.
And it was they filled it themselves.
All right. When was the study done?
It was
June. Was it in the peak of the pandemic, or?
Yes, May, June of 21.
Okay. And what was the mean age of the study participants?
36.5.
All right. Okay. And did you find, like, in any particular age range, was it more, or those who are married, unmarried, in anybody with comorbidities or something?
Yes, ma'am. Anxiety was moderate in 21, and it is normal in 64, but severe in 5, who have very who come from a far distance to workplace, and who have children in their families, children as well as elderly people.
Okay. And had you taken a history of whether they had already been, they were already affected with COVID? That difference?
For this study purpose, no, ma'am.
Okay.
But as we all mostly known to each other, so we were aware about their status.
Okay. Thank you.
Hello, everyone. Thank you, ma'am, Dr. Vinita ma'am, and Dr. Seema ma'am, for being with us and giving your precious time to us. And thank you to all the partners are over for today. So can we conclude, ma'am?
Yes, thank you, everyone.
Dr. Seema ma'am, Vinita ma'am. Okay,
Thank
so
you.
on behalf of the organizing committee, IAPCON 2020, and on behalf of Dr. Anjum ma'am, and sharing your precious time.
Okay, good night.
And being a part of IAPCON 22 and making it possible on a bigger level.
Okay.
Thank you, Priyasi, and thank you.
Okay. Thank you
Seema
so
ma'am,
much, everyone.
also for being here. And
Thank
thank you
you,
to all the
ma'am.
participants.
Thank you.
Have a good day.
Dr. Seema ma'am and Dr. Vinita ma'am, I would like to tell you one thing, that please share the results assessment sheet with me, either through the mail or through WhatsApp.
Okay.
Bye.
Thank you so much, ma'am. Good night, ma'am.